Okay, good morning. Okay, 10 o'clock, so we're going to start the meeting. Jessica?
Moderator, are you able to start the recording?
Recording has begun.
Thank you. Dr. Solocito?
Present.
Dr. Grant?
Present.
Dr. Noland?
Here.
Ms. Pulowski?
Here.
Ms. Prado? Dr. Bradbury?
Here.
We have a quorum.
Fantastic. Well, first, we would like to begin the meeting with a land acknowledgement, which is a public recognition of the Indigenous peoples who have been dispossessed and displaced from their ancestral homelands and territories. A land acknowledgement is the first step towards creating a policy of inclusion that recognizes the culture, history, and continued contributions of the original caretakers of the land on which this meeting is held. This statement is made to acknowledge the Nisenan, Southern Maidu, Valley and Plains Miwok, and Patwin Wintun people, as well as the Sacramento's only federally recognized tribe, the Wilton Rancheria. This acknowledgement also marks the Board of Veterinary Medicine's commitment to work with these tribes on issues of mutual concern. We're next going to move on to agenda item number 2. And I just wanted to say that before we open public comment on matters not on the agenda, I would like to remind individuals making comments not to discuss pending complaints, pending licensing applications, or pending disciplinary actions that may later come before the board for decision. This includes public comment on this item as well as public comments on future items. Additionally, please be aware that public comment during this agenda item should provide information to the board members, but it is not a discussion between the board members and the public. The only action board members can take during and after public comment is to listen to comments and decide whether they want a future agenda item on this topic. Though this may seem at times like the board members are not being responsive, following these guidelines is critical to ensure the rules of the Open Meeting Act are followed to avoid compromising the speaker's goals or the board's mission. In the interest of time, as we have done in the past, public comment will be limited to 3 minutes, and we would like to request that public comments not repeat statements made by a prior commenter. If you are in support of a statement made by a prior individual and your comments have already been made, please just state your name or association and your support for the previous commenter. Legislative hearings regularly use this practice as it is a good way to ensure that we can hear from everyone today. Now let's move into public comments not on the agenda. And since we are in a hybrid situation, we'll take comments from people in the room first, and then we'll ask the moderator to open it up to those online. Are there any public comments in the room? Seeing none, moderator, can you open it up to the public online, please?
We are open for public comment via WebEx. If you'd like to make a comment for items not on the agenda, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. For our mobile device users, you have 3 different screens and only one of them has a hand button, so you may need to hit the ellipses button, that's the ... at the bottom, in order to find the appropriate page with the hand button. As noted, you will be given 3 minutes to speak, and I'll give you a 15-second warning before your time expires. We're going to take just a couple of seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, thank you, moderator. Okay, we're going to move on to agenda item number 3, review and approval of board meeting minutes. Any issues, comments? Yes, Ms. Pulowski.
Sorry, you know I always have something. On page 12 of 48, the 1, 2, 3, 4, 5th paragraph at the bottom of that paragraph. 6, 7, 8, 9, the 8th and 9th line at the end of the ninth line, where it starts at the end of that, when it says, when the is the veterinary premises, it just misquotes what was stated there in the video. It's just a typographical, and it's just, I think it's duplicative language when it's in there.
Okay, any others? Yes, Dr. Nolan.
Not a very important one, but page 11, fifth line from the bottom, my name is misspelled.
That is important.
I have a couple similar kind of typos. I have on page 11, same paragraph, I believe, at the end, it says, but she wanted to speak her piece, and it's spelled P-E-A-C-E, and it should be P-I-E-C-E. Page 16, second paragraph, it, just add it for clarity, but she thought think. I think probably says thinks. I didn't have, so I should say, but she thinks when the board is creating these regulations. It's possible I said thought think. I didn't read over it. I sometimes get tongue-tied up here. And let's see here, page 29. Instead of ODIC, O-D-I-C, that's in the paragraph starting, Dr. Miller continued. There's two references in there where it says if it's stated canine ODIC preparation or feline ODIC preparation. ODIC is spelled O-T-I-C for those two. And again, I didn't have a chance to listen on page 34. It says Dr. Bradbury stated she had reviewed the comments in the third sentence. I think it should read, she thought that corporate medicine and increased cost for pet care, not medication, has priced many people out of veterinary care. If somebody could just listen to that and see if that's correct. And that is all I had. Seeing no other discussion, can we get a motion?
I will move to approve as amended.
I second it.
Great. Any public comment? I see none in the room. Moderator, would you please open it up to the public for public comment?
We are open for public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users, dial *3 to raise a hand. And I should also note we have a Q&A box in the lower right-hand corner of the screen where you can type the word comment if you're having trouble finding your hand button. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, thank you. Okay, can we call for a vote?
Dr. Solocito,
Yes.
Dr. Grant,
Yes.
Dr. Noland,
Yes.
Ms. Pulowski,
Yes.
Ms. Prado,
Yes.
Dr. Bradbury,
Yes,
motion carries.
fantastic, thank you. Next up, we have a report and update from the Department of Consumer Affairs and Ms. Gear. Good morning.
This is the moderator. Hold on just a moment. All right, Ms. Gear, you should be available to unmute or be able to unmute.
I'm actually in person. So I will get started. Thank you, moderator. Hello and good morning, President Dr. Bradbury, Vice President Dr. Solicito, Executive Officer Sieferman, and members of the board. I'm Melissa Gear, Deputy Director for Board and Bureau Relations, and I appreciate the opportunity to share the Department of Consumer Affairs update this morning. Before I get started, I wanted to take a few moments to thank board member Dr. Jamie Nolan for her many years of service to the board and her commitment to protecting California's consumers. Although she has a few more months before her term officially ends, I did want to not miss this opportunity to recognize you. I will now begin my update. Let's begin with an important update regarding federal Title IV funding, a new U.S. Department of Education regulation that goes into effect on July 1st, 2024. It will impact students of boards or bureaus that approve non-degree school programs leading to licensure. Currently, schools can offer programs that exceed a state's minimum hour requirements, and they can still offer their students federal financial aid. Starting July 1st, 2024, this will change. The U.S. DOE regulation limits the program length to 100% of the state's minimum requirements, making the minimum requirement the maximum. As a result, non-compliant programs will not be eligible for federal Title IV funding after July 1st, 2024. The program length must be equal to the state's minimum hour requirements. There can no longer be any deviations or the entire program will lose federal financial aid. However, as of April 9th, the U.S. DOE issued a notice that allows for the delay in enforcement and implementation of the 100% requirements for Title IV until January 25th, 2025. DCA will continue to work with the U.S. Department of Education, California's legislature, and your executive officer on this important issue. Next, DCA's Diversity, Equity, and Inclusion, also referred to as DEI Steering Committee, held a meeting on April 5th. The committee discussed DEI actions, priorities, and language access. As a reminder, DCA's learning management system has many DEI-related training courses available to board members. If you need any assistance accessing these courses, please reach out to Board and Bureau Relations. Also this month, DCA's Office of Public Affairs staff will participate in 2 Facebook Live events hosted by the Consulate of Mexico during its Financial Education Week. Staff will present Get to Know DCA in Spanish and share a broad overview of consumer and licensing resources. The first event is with the Consulate of Mexico in Sacramento, and the second event, the department will join the Consulate of Mexico in Fresno. Additionally, in the coming months, DCA will be developing workforce development outreach opportunities for all boards and bureaus to participate in. I look forward to sharing more information soon. Last month, the DCA Division of Investigations, or DOI, updated the complaint prioritization and referral guideline for healing arts boards. The new guidelines are effective and should be used to evaluate complaint referrals. Referral guidelines for non-healing arts boards and bureaus are in progress. Last but not least, on April 30th, DCA will host an in-person meet and greet with Secretary Tamika Moss and executive leaders. The meet and greet will serve as an opportunity to meet the new secretary and hear her vision for the Business Consumer Services and Housing Agency and the department. Invites have been sent to executive officers and bureau chiefs. Board members with any questions for Secretary Moss are encouraged to submit them to their executive officer or bureau chief. Now that this year's annual Form 700 period has ended, DCA and BBR would like to thank all of our board members and executive officers who helped us achieve compliance. Thank you all very much. And so again, I'd just like to take this opportunity to join you, say that I'm happy to be here to answer any questions that you may have. And if you have any questions or need further assistance on anything that I've said today, please feel free to ask.
Thank you. Don't see any questions. No, thank you so much for your report. I need to just see if the public has any questions. So anybody in the room? Not seeing anybody. Moderator, would you please open it up for the online audience?
We are open for public comment on the DCA report. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise a hand, and we will call on people in the order we have requests. As a reminder to our mobile device users, if you're having trouble finding that hand button, you may need to hit the ... that's the ellipses button at the bottom of your screen, and cycle through 3 different pages in order to find the hand button. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the agenda?
Yes, thank you. Okay, I'm assuming this is going to be online. Um,
We have Dr. Jones, the state veterinarian, here
Oh,
in
Oh,
person.
sorry. Hi. So the next agenda item is agenda item number 5, presentation on barbiturate use in performing humane euthanasia in bovine cattle. And from the CDFA, we have
Annette
Yes.
Jones, yep.
Dr. Jones. Thank you for coming.
I'm going to cheat a little bit and keep an eye over here on the slides.
Do you want a computer? We can put one. You can use one of ours.
I didn't, but I think you have it. At least last night we did.
Can-
Oh, there you go.
Oh, that's great.
Okay.
That's much better, huh?
Oh, now I can see myself too. I guess we're used to that with all the Teams meetings and everything.
I
these
always
days.
minimize myself in the corner.
Yep. So today I just wanted to make sure that you all were aware of a new regulation that we passed. Now it's been a little while since it's been in place at the Department of Food and Agriculture. And it was to, go ahead with the next slide. We'll just give you
I
some
think our
back.
team is trying to pull up the slides right now. There we go.
Yeah. Yeah, and maybe I'll, so maybe I'll just take a second to introduce myself for those of you who haven't met me in the past. I'm Dr. Annette Jones, the state veterinarian and director for animal health and food safety services at the Department of Food and Agriculture. Primarily we deal with livestock and poultry. So just real quick, I wanted to give you an update on where we are with and what the issue is related to rendering and barbiturates. Go ahead.
Okay, so we have the slides up, and then board members, if you turn your monitors on, you can also see what's being presented as well.
Next slide. Is, who's running the slides? Oh, okay. Yeah, go ahead. Next slide. So anyway, just really quickly, the reason this is an issue is a lot of animal mortality is handled through rendering, and rendering, some of the byproducts are used for feed and like, protein meal and things like that. And because of the preventative control rules that went into place several years ago now by USDA, there's a lot of preventative actions that are taken to ensure that our pet food and livestock food supply is safe. And part of that is included is the renderers have to have good manufacturing practices, and they use HACCP, which is hazard analysis and critical control points. And one of the hazards that they identified is if animals are euthanized and then processed through rendering, there's a potential for barbiturates to be in some of the end product. So, and there's zero tolerance for that. And so because they've identified the hazard, they have to test their product to ensure that their preventative controls are working. It's kind of the way the system works. And there's a zero tolerance for barbiturates. Technically, scientifically, there probably could be a safe level, but you can imagine there's a lot of that would be challenging to say that it's okay to have some barbiturates in ingredients that could potentially use for pet food. So it's a zero tolerance at this point. Okay, go ahead. So the problem was that the renderers, so when they started their critical control points, they were testing their products and they were finding barbiturates at very low levels, but it's a very sensitive test. And so most of them, in fact, quit taking horses, equines, because commonly, barbiturates are used to euthanize our horses. But they were still getting positives. And so anecdotally, when we talked to veterinarians, it looked like more than in the past, barbiturates had been used to euthanize cattle and other livestock species like goats and sheep as well. And we were thinking perhaps that's what led to the problem. So working with the rendering industry and our advisory board, we passed regulations to require marking of animals that veterinarians have euthanized with barbiturates. So that when the renderers pick up those animals, they can separate them and make sure they don't go into inputs for any kind of pet food or livestock feed. So go ahead. So basically, we require that the animal be marked with a B and on the forehead. We talked to a lot of veterinarians. We recognize that might be uncomfortable for some owners to put a B, right on their animal's forehead. But if they put it in other places on the body, from what we've understood, it can be confused with other markings. Other Bs are commonly used to indicate other, go ahead, to indicate other conditions like beef or banamine or, other messages to make sure the animal's handled properly. So you can see we've done some outreach. We have it on our website. And I did just, or one of my staff members did just call all the renderers this week, actually yesterday and the day before. And the good news is this is probably not an issue for the board because we're really seeing less occurrences. Because I'm not so sure, it's not so much that we need, although we want to make sure we're aware in case enforcement became an issue. I think just the fact that the regulation was passed and that we've socialized it with veterinarians, I wouldn't guarantee every animal that's euthanized, every livestock and poultry species that are euthanized with barbiturates are marked. But that's not the goal, is that kind of, technical enforcement. The goal is to make sure that those animals are not getting into the food supply, the feed supply. Obviously, they're not getting into the food supply, but make sure they're not getting into the feed supply. So that seems to be working. So that's my report today. Go ahead. There's kind of next steps. I probably should mention this. So one of the reasons that we wanted to do this is because, the renderers is like, what are we going to do? We keep trying to tell people to be careful about that, and we keep getting residues. And my thought was, well, this is probably one of the easiest problems any of us have because veterinarians control barbiturates. So, all we need to do is reach the veterinarians because they're not out there in the general public floating around. They're a reason they're a controlled substance. So I think it worked. So anyway, go ahead. Last kind of next steps. At this point, I think it's really a matter of just continuing outreach and education to veterinarians. We have turnover in our professional workforce daily. And so we need to make sure that we're still reaching the recently and reminding the practicing veterinarians that it's important that we do notify the rendering system, and they have they're responsible for this controlled substance, and they're also responsible for keeping it out, for making sure they follow the rules. What happens after they leave, that is out of their control, but it is their responsibility to mark the animal. So if we do start seeing issues again, we'll probably maybe have some informal meetings with the vet med board just to talk about it if we're seeing issues. But right now we're good. Okay, I think that that's the end. Yep. Any questions or comments?
Dr. Nolan?
Thank you, Dr. Jones, for being here. Hi, good to see you. Um, As you well know, we're sending horses now to mostly to landfills and whatnot, and that is also a bit of a concern as far as an environmental risk. And any thoughts of where we're heading to try to mitigate some of the downside risk of that?
Right. So that is the ongoing real problem. Frankly, like I already mentioned, trying to protect our ingredient stream was the easy part. The hard part is, now what is a, environmentally responsible, practical way to handle mortalities that, animals that have been utilized with barbiturates. And the bad news is we don't really have an answer to that. We're looking at, I know some people find this distasteful, but we're looking at things like composting, and just alternate means for disposal. Right now, unfortunately, landfill sometimes is common. Cremation, not every owner can afford that. That's another option, but that's not always practical. So we're working with the water board, air boards, Cal Recycle, and others on some projects to look at maybe changing some rules so that composting could be a viable option.
Dr. Grant?
Are there other forms of euthanasia becoming more popularized or accepted?
Can you repeat that? I just have bad hearing.
Oh,
Oh, wait a minute.
I was wondering if there are other forms of euthanasia
Oh,
that
okay.
are taking the place of the barbiturates.
Yeah, so,
Especially in horses.
blunt force trauma is obviously safe from as far as any introduced substances. So that I think has occurred again for a while. That was, when I was first started practice, that's pretty much what happened for a lot of large animals. They were, but that apparently there was a move away from that. And I think that's, becoming more common again. And then there's other means of euthanasia, other chemical mixtures. And the problem with that is it's not clear what the tolerance would be for some of those other alternative methods. So there's just no good answer for veterinarians.
Yeah, thank you so much for your presentation. Yeah, when we met previously in the informal meeting, there was it seemed like dairy and large animal in general was they were seeing more use of euthanol than before, and that was kind of a perception thing, while there were other very humane modalities for euthanasia. So it sounds like that now that you've had your outreach, people are kind of moving back towards these other modalities. Is that's what you're saying?
Yeah, that's what I think. I think there's a shift away. Either that, there's one of two things that have, and probably both are occurring. One is there's a shift away from using chemical euthanasia for animals that could, enter certain streams. And then also, I think when there's an increased awareness so that if euthanasia solution is used, veterinarians are working more closely with their clients to make sure they have an alternate means to handle the remains.
Got it.
Other than rendering. So my guess is both.
Yeah. Yeah, it seems like it would be really environmentally harmful going to landfills there's wildlife that feed on that. There's the leaching and all of that. So
yeah, I think the landfills are actually very environmentally safe because we use them when we have disease outbreaks as well as not our primary method, but a secondary method, because they have a lot of oversight. Most of them are the ones we would use are lined. They need to be permitted to take these animals. So from a environmental perspective, in the idea of contaminating the environment with mortalities, that's probably a safe place. But the problem is we're trying to, as a state, we're trying to reduce organic matter in landfills to try and save the airspace for things that can't go elsewhere. So that's the problem with landfills.
So that's the composting idea. Okay.
Mhm.
Okay, great.
Exactly. So
Yeah.
it's a safe disposal from an environmental perspective, very safe disposal, but a method we're trying to preserve for other.
Got it. Okay. Dr.
I have a-
Solcito.
Yeah, I have a question. It's more for curiosity for the lack of knowledge, about the landfill stuff. Are the landfills being monitored too? Like, are there testing involved with regards to residual, barbiturates?
Like they're affluent for drugs and chemicals. I think most, I'm not an expert in that. So I probably would have to defer to Cal Recycle, who provides that oversight. I can say just because we work with Cal Recycle a lot, again, for animal mortalities when we have a disease outbreak, there is substantial oversight of landfills, both at the local and state level, and they look at affluent, they look at, they are heavily regulated.
Great. Any public comment in the room? Okay, I don't see any. Moderator, would you open it up to the online audience, please?
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, thank you. And then I think,
Yeah, I just want to really thank you, Dr. Jones, for the continued collaboration. I don't know if all the board members know, but we were having regular in-person meetings pre-COVID with CDFA, and then COVID happened, and then not so much. But we did start meeting with Dr. Brady from CDFA for the animal blood banks on a regular basis. And now, to Dr. Jones's recommendation, we're going to go back to meeting more regularly to address it. So I just really appreciate that, and
Yep.
thank you.
Yeah, we have a lot of crossover issues,
Yes.
so. it's
Thank
great
you.
that's
coordination.
great. Thank you so much for
Thank you
coming
very much.
today. Okay, agenda item number 6 is presentation on holistic medicine within the veterinary curriculum. And we have representatives from UC Davis and from Western University to present. Jessica, do you want to go ahead and take it from there?
Sure. So if we can get Dr. Sarah Lejeune, she is presenting for UC Davis, and then hopefully joining us shortly will be Dr. Tegsis, and I think I might have mispronounced his name, will be joining us from Western. And also if I can ask the moderator or our team to share the PowerPoint presentation, that would be helpful as well. Thank you.
Good morning. This is Dr. Sarah Lejeune. I'm a sports medicine specialist and boarded surgeon, and also provide what we call integrative veterinary medical care to horses, and especially at UC Davis. Shall I go ahead and start?
Yes,
Can you
please.
Can you all hear me? Okay. And just apologies from Dr. Coe. He's not able to join, so he's my counterpart who handles the small animal side of this. Next slide, please. So first, I want to start defining the topic, because I know we were asked to talk about holistic medicine. And that's sort of in the middle there, which is a medical approach treating the whole body rather than just one organ or system. A lot of people actually think that it has to do with necessarily with alternative medicine, but actually holistic medicine is a more of a philosophical approach to treating the whole animal. And so what we do at UC Davis is we practice integrative medicine, which is a combination of non-conventional medicine and conventional medicine together. So conventional medicine, of course, I think everybody's familiar with, which is the medical system used in the Western world, commonly where symptoms and diseases are treated using drugs, radiation, or surgery. So some synonyms, allopathy, Western medicine. And then sort of opposed to that would be complementary alternative veterinary medicine, which is what's not part of conventional medical care. So that's where that the synonym holistic medicine comes in. But again, I think that's not a good use of that term. Natural medicine, Eastern medicine. And then alternative medicine, which is, the same kind of idea where you even take it a step farther, where non-conventional medicine is used in place of conventional medicine. And actually, we do not recommend that at all. So where we stand at UC Davis, and I want to be very clear on that, is that we practice integrative medicine. So where we combine conventional medicine, all of what we do, with some of the non-conventional approaches that actually do have scientific merit. And we do practice holistic medicine more than just in that integrative service, because we do try to approach the whole animal, not just the symptom. Next slide, please. So integrative veterinary medicine combines conventional medicine with research, scientifically based complementary medical approaches, and it really does help to maximize patient care. So the modalities would include acupuncture, chiropractic, laser therapy, extracorporeal shockwave therapy, pulse electromagnetic field therapy, some massage therapy, myofascial releases, and then some dietary supplements and herbals. Next slide, please. So at UC Davis, we have several lectures and discussions that we provide to those students on integrative medicine, with the goal of illustrating basic principles and clinical applications of integrative medicine, including their indications, and I would add contraindications, types of therapies, the scientific evidence or lack thereof, benefits, risks, and legal and ethical issues. Since both Dr. Coe and I are sports medicine boarded and rehabilitation boarded, we actually do have a very strong focus on sports medicine and rehabilitation for that, those modalities, both in small animal and large animal patients. We also have integrative medicine clinical rotations for senior vet students, and there's a small animal component, and then there's an equine integrative sports medicine and rehab component, which I lead. Next slide, please. Additionally, we have topic rounds and lectures. Some topics are multimodal pain management, acupuncture, laser therapy. We have a bunch of lectures on rehab, dietary supplements, herbal medicine, regenerative medicine, myofascial pain, and palliative and hospice medicine. Next slide, please. And we have very specific learning outcomes for the rotation and the various lectures and discussion sections. So with the aim of recognizing similarities and differences, strengths and weaknesses between integrative medicine and conventional medicine, we really hope that the student understand how aspects of the two systems of medicine can be used to improve patient care, and to identify the appropriate time frame and clinical scenario for referral. We're trying to help them identify chronic, neuropathic, and myofascial pain and their management with pharmacological and non-pharmacological options. Just like in any other clinical rotation, they're expected to formulate problem lists, treatment goals, diagnostic plans based on clinical findings and history, and then formulate and implement an appropriate integrative medicine and rehab therapy plan based on that diagnosis. And then we do focus on trying to explain basic mechanisms and modes of actions, clinical applications, and then adverse effects of common forms of these therapies, and those would include acupuncture, chiropractic, laser therapy, electrotherapy, shockwave, electromagnetic field therapy, therapeutic ultrasound, hydrotherapy, orthobiologics, supplements, and herbals. Next slide, please. So just as an example, for a large animal case, just to show how we would work up this case and where we would go with it with a student. So an example, 12-year-old warm blood dressage horse with chronic back pain and hind limb stiffness. So just like any other, conventional workup, we would have a full orthopedic lameness and neurological exam, including a functional exam of the axial skeleton, and then a saddle fit evaluation and a ridden exam. The diagnostics would include diagnostic analgesia, radiography, ultrasound, and possibly advanced imaging. And then the treatments might include chiropractic, acupuncture, shockwave, therapeutic laser, some local injections, a saddle adjustment, change in diet, change in shoeing, and then specific targeted exercises and stretches to help strengthen the animal. Next slide, please. And then an example of a small animal case, if we have a 10-year-old Australian Shepherd mixed breed dog with severe hip dysplasia and osteoarthritis and chronic hepatitis, the clinical evaluation would include, of course, pain, lameness, orthopedic, neurological, and functional exams with imaging of the hips. Of course, the hepatitis would be managed by the internal medicine specialist. And then the treatments would focus on pain relief, improving mobility, including acupuncture, manual therapy, TENS, shockwave, therapeutic laser, joint injections, weight management, supplement, herbals, therapeutic exercises, etc. So we're just adding more tools in our toolbox, but we're certainly not taking away from any of the diagnostic and therapeutic modalities. Next slide, please. So thank you very much, and I'd be happy to entertain any questions that you might have. But I do want to make sure that it's emphasized that we're not promoting alternative medicine, but we are promoting integrative medicine, which is a different concept.
Thank you, Dr. Lejeune. I really appreciate you coming. I know we all do. This is sort of such a mixed bag kind of when we hear about it. And the definitions for me, at least, were really helpful. And I think as a regulatory body, we're at a time in veterinary medicine where there's just so many variations of these practitioners, some that are, using it as integrative medicine and others that are just doing alternative medicine. And so that's obviously concerning because how do we even begin to start determining standard of care in these situations? So I'm really glad that that UC Davis has taken this on and is utilizing some of the integrative forms because it obviously does benefit the patient in a lot of these instances. One of the concerns that I've always had are the herbal supplements and kind of the traditional Chinese medicine and how that's evaluated and whether that's safe. And I, as an internist, I use herbal supplements, milk thistle, and nutritional supplements like SAMe, and like in the chronic hepatitis case. But in my mind, there was some scientific evidence behind it. How are you teaching your students about the herbal supplements and traditional Chinese therapy or medicine?
Yeah, so you're correct. I think the quality control is a problem. And even in some of these formulas, we actually don't really know what's in them. So we teach them to be very, very cautious about that. We don't endorse any formulas or any of these nebulous kind of, herbal formulas. So like you said, an isolated ingredient that has some scientific merit we would say is probably okay, but I think this is definitely an area that is still wide open, and I think where we need to probably do more research and find some way of controlling what we're actually administering. So we are actually telling the students specifically to be very cautious. And if they wish to learn more about it, because that's the other thing, is that there's so many unknowns, that there are advanced courses on that, but to provide with caution and remain critical. So that's kind of where we are. I know it's probably not a very black and white answer, but I think we just have to tread cautiously still.
No, I think that's helpful. Dr. Nolan?
How did you know I had a question? Thank you, Dr. Lejeune. Really appreciate you coming and spending some time with us. I was wondering, I have several questions, but are the students expressing interest in your clinical rotation? And how long have you been offering it?
Yeah, so I've been offering it for 17 years. Which I mean, I will tell you that I'm a boarded surgeon, and when I started doing this at UC Davis, everybody thought I went to the dark side, but I've done it cautiously and only, like I said, as an integrative way of treating animals and specifically painful conditions. But I would say the interest. So I have a little bit of a longer view on the interest. Initially, the interest was very small. And I would say over the last 5 years, it has like exponentially gone up, where the students are actually, quite a few of them are taking some of these courses actually in their final year of vet school, and expressing a lot of interest in getting more, more trained in it, because we're just exposing them sort of to the bare bones of what it might be. But, we're not providing some formal education on the different techniques. And I would say it's really surprising how much interest there is. And when the students ask me, when should I delve into this, I always tell them, I really think it's very, very important to get your conventional medicine very solid, because I see that this is a little bit the problem, is that you have people who are somehow frustrated with conventional medicine, and then they go down this road and in that case, I would call it alternative medicine, because they're not incorporating the two. And that's where I think it becomes dangerous. So I tried to steer students away from that, and to really promote the fact that they should get strong with their conventional medicine. So do like a basic internship first, and then maybe 1 or 2 years down the road, practice a while, get your feet wet, and then do it. Because then I think you can see the pros and cons better than when you just jump into it and people tell you it can cure everything, And so that would be my approach, and that is, I think, what UC Davis promotes. But, of course, what every individual does is, they're going to do what they're going to do.
And thank you. And do you have any focused internships or residencies that are associated with your integrative program?
So we
Specific
have so it's more focused on the sports medicine. So there's a American College of Veterinary Sports Medicine and Rehabilitation encompasses some of the modalities in rehab, because like acupuncture, chiropractic, the strengthening exercises, shock wave, laser, all of that is used in rehab. So we do have a program, a small animal residency in sports medicine and rehab, and a large animal internship in integrative sports medicine. But they don't specifically focus on just, those modalities. I mean, it's the big picture kind of thing.
Well, thank you very much.
Yeah, Dr. Grant?
Dr. Lejeune, Barry Grant, and I'm glad to see that the program is facing up to the dilemma of making a good, accurate diagnosis with all our modalities versus trying to make a diagnosis with treatment with the so-called alternative forms of therapy And from a consumer affairs thing, I see a large number of cases that the people are very frustrated. They've spent up a lot of funds doing alternate forms of therapy because it seemed less than actually getting a good clinical workup, when what they really needed in the long run was a good clinical workup, and then be able to decide on which modality would work. I think that's really important to protect our consumers and our patients.
Yeah.
Ms. Pulaski?
Sorry, Christy Pulowski here, and just to kind of go off of Dr. Nolan's comment in that you guys do offer extensive continuing education courses on integrative medicine. Am I wrong on that? Because I thought I've seen seen courses. Is that correct?
Yeah, so that's not, I mean, it's the Chi Institute which is a traditional Chinese veterinary medical institute that's actually based in Florida. And they have partnered, and actually Dr. Ko, who is unable to be here, leads those courses, but they are not, I mean, they're held at UC Davis, but they're not part of UC Davis. You know, they rent the facilities, and so it gives them an opportunity to provide a course like that on the West Coast, but it's not specifically UC Davis curriculum.
Thank you.
Holly?
Hi, I just wanted to add, as a UC Davis student, we do have an integrative medicine club that first and second years really enjoy. I'm part of it as well. And it provides a lot of opportunities to shadow veterinarians in the clinic, and also has a lot of really great speakers come and talk about the importance of, heavily research-based integrative medicine.
Great. The other thing is, do you have any funding for research on some of these modalities? Because I know that that's kind of part of the problem, right? Is actually having funds to do clinical trials to see if any of these things work.
Yeah, I mean, we can submit grants through regular grant, channels, the Center for Equine Health, et cetera. So we don't have specific funds for that, but we are definitely trying to do more work in that area. And you're right, it's very, very much needed, but
Maybe
there's no
maybe the club can
specific
do it.
grant area. What?
I was saying maybe the Integrative Medicine Club can come up with a study and volunteer to
Right.
help with some of these.
Yeah,
Yeah, sorry for
that'd be good.
interrupting. Yeah. I had one last question, which is, what is an orthobiologic?
Oh, that's we have in the veterinary side, we have less regulation when it comes to like harvesting blood products and re-injecting them after they've been, incubated to upregulate some of the anti-inflammatory endogenous cytokines and growth factors, et cetera. So I don't know if you've heard of platelet-rich plasma. They use it in humans as well, but that would be, for instance, an orthobiologic. But we have a lot of different ones because we get a lot of different kits to manufacture different, byproducts. So that's what an orthobiologic is.
Great, thank you. Sorry, Dr. Solicito.
Just a question here. What do you think is like the percentage of popularity, I would say, of integrative veterinary medicine in small animals compared to like large animals like horses and stuff?
You mean in the students or in the?
Yeah, with the students like interest. Yeah.
Well, I would say it's, I think very common in both small animal and equine. I mean, I lead a discussion section every year to the third year students. And I polled them every year and I asked them who's interested in pursuing more, more training and really interested in these modalities. And this year, I think close to 90% of the hands went up. So that was wild. And of course, we have a huge percentage of small animal students, right? We only have like 10 equine students, but I know most of those equine students and most of them are very interested because from a, sports medicine standpoint, a lot of the modalities that we use in horses like acupuncture and chiropractic are very, very effective to treat, back pain and some of these very common musculoskeletal issues. So yes, there's a huge interest.
Just a follow up, but do you think the acceptance in the industry with like small animals, do you think that's something that is gaining more popularity in the industry as well?
Absolutely. I think a lot of clinics are offering it now, and it's so yes, I think it's very, very popular and accepted, especially here in California, I would say.
Yeah, it's been helping my dogs for sure with my old Labradors. The acupuncture, chiropractic, and laser therapy seems to have really helped them a lot. So I really appreciate you coming and taking the time. I'm just going to let the public ask some questions, and then I think we'll be wrapping up. So any
Thank you.
public comment?
Grumpy Mike's. Grant Miller, California Veterinary Medical Association. While I appreciate that the board has Dr. Lejeune here, hi, Dr. Lejeune,
Hi.
has Dr. Lejeune here to better familiarize yourselves with these areas of medicine, I also think that this serves a dual purpose in really proving the point that the veterinary profession has been accused of being very deficient in this type of education and, by some other folks who want to practice veterinary medicine without actually going to veterinary school. And this really shows how robust this training is, not only at Davis, but we also know that Western has very similar offerings to their students. And I think it's a really valuable reminder for things that might be coming in the near future for this board to just refresh its conviction that veterinarians actually do have extensive training in all of these areas. And we're very capable of providing those to our clients. Thank you.
Thank you. Any other public comment? Seeing none in the room. Moderator, would you open it up to the folks online, please?
Absolutely. We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users dial *3 to raise a hand, and we will call on people in the order we have requests. As a reminder, we also have the Q&A box in the lower right-hand corner of the screen where you can type the word comment. And for our mobile device users, you have 3 different screens and only one of them has a hand button. So you may need to hit the ellipses button, that's the ... at the bottom, in order to find your hand. We're going to take just a few more seconds to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yeah, thank you. Thank you so much for coming today and putting this together. Again, it's very helpful. And thank you for teaching the future veterinarians all of this. It's really great. So thanks again. Okay, I think we're going to take a 10-minute break, and we'll come back at 11:10. Thanks. Are we recording?
This is the
Moderator?
moderator.
Yeah.
Yes, we are recording.
Great. Okay, we will get started again. So next up, we have Dr. Sullivan, our fearless leader. So today, he's going to be going over all of the MDC meeting, which was exciting. There's a lot of technical stuff going on, and just to let everybody kind of know how I think this is going to be presented. Dr. Sullivan is going to be presenting items 7B and 7C together because really they do go together. So just to keep everybody on track there. So Dr. Sullivan.
Thank you. There will be a number of people here keeping me on track. So we'll start off with item 7A, which is a summary of the last two meetings that we've had. The
I
most
think your
of
mic
what,
is, I think
not loud enough. Okay, how's that?
that's good. Thank you.
Okay. So most of what our minutes, most of the summary of the two meetings, we're going to be going into detail today on almost all of them. So they'll, the summary of the two meetings will be quite brief. The January 24th meeting was called to order at 10 o'clock. There were no public comments on items not on the agenda. The minutes of the October 17th, 2023 minutes were approved with minor changes. There were recommendations regarding the medical records, which will be discussed in great detail on your item 7D, including a proposed legislation to amend Business and Professions Code, section 4826.6 and 4855, and B, the initial rulemaking to amend Title 16 of Section 2032.3. There were recommendations to amend multiple code sections to change the word oral to verbal, which will be discussed in your agenda item 7E. There was a discussion and recommendation to amend Title 16 sections 2036.5, 2090, 2091, 2092, 2093, and 2094 regarding drug compounding, which will be discussed in your item 7F. There was a recommendation to make changes to the board guidelines on veterinary drug compounding, which is on your agenda 7G. There were recommendations on frequently asked questions concerning AB 1399 of 2023 and SB 669 of 2023, including hypothetical situations. And that will be discussed on agenda item 7H. Dr. Waterhouse gave a report on her and Dr. Sequoia's review of 4 cases on the Complaint Audit Subcommittee and their plans going forward. Future agenda items and meeting dates were discussed, and we adjourned at 5:15 p.m. And the minutes for yesterday's meeting, we had a little bit of shorter meeting yesterday, called to order at 10. There were no public comments on items not on the agenda. Minutes of the January 16th meeting of the MDC were approved with a few corrections. There was an update. There was update, discussion, and potential recommendations for previously approved text amend California regulations, Title 6, sections 2030, 2030.05, 2030.1, 2030.2, and 2030.3, which will be discussed in your agenda item 7B. There was discussion and proposal to initiate rulemakings to amend Title 24 of Section 1251. This will be your agenda item 7C. After discussions on the section of hypotheticals within the discussion of frequently asked questions related to SB 669, it was decided that the hypotheticals would cause more confusion at this time. We had a great discussion. A subcommittee may come back with some ideas in the future or may add more F&Qs to the subject. There were no action items on that item. There was an update and discussion from the Complaint Audit Subcommittee, Dr. Sequoia and Dr. Waterhouse, with Dr. Waterhouse giving an update on the recent roundtable discussions with both the record review consultants meeting and the SME meeting. And then we had the future agenda items and meeting dates were updated, and the MDC gave a big Thank you to Dr. Sequoia and Dr. Lazarchef for their work on the MDC, as both are coming off of the committee. And we adjourned at 12:20 p.m.
Thank you. Is there any questions about that? I don't see any. I think I'll hold public comment to the end of your first group of presentation. Thanks.
Okay, so we're going to work with 7B and 7C together. And I'll go with the introduction to this to give it some background for those that weren't there yesterday. Recommendations on previously approved text to amend California Code Regulations Title 16. This issue has a long and convoluted history working with stakeholders back well before 2017, which culminated with the MDC making their final recommendation to the board at their February 20th, 2018 meeting. During 2018, the board made multiple changes in terminology, made some content change, and recommended legislation to permit fee exemption for low-cost and no-cost vaccination events. Because of a backlog of regulatory proposals by the board, the rulemaking language wasn't submitted to the regulatory unit of DCA until July 2021. During the January board meeting of 2022, concerns were raised about how the VCPR was being established during a vaccination clinic and referred that back to the MDC. The subcommittee that was working on this issue, along with board legal counsel, the regulatory counsel, and board staff, drafted proposed amendments to address those concerns. The MDC approved those changes and recommended the amendments to be forwarded to the board. However, before the next board meeting, the regulatory council found a new concern that needed to be addressed. Because there was significant changes in the language of these minimum standards, regulatory council said that OAL would not approve the duplicity that was present in the old form. Over the next number of months, this subcommittee, stakeholders, board staff, our legal counsel, and the regulatory legal counsel reformatted everything to be sure that the duplicity was eliminated and none of the previous identified minimal standards were lost. As you can see, the end result was having everything that was common to all practice types placed in Title 16, Section 2030, and then listing other types of practices with their unique characteristics and listing exemptions when needed. The MDC and the board approved the revised proposals with amendments at the April 23rd meeting, with the addition of the shelter minimum standards added to the legislative package during the October 23rd board meeting, October 2023 board meeting. Was this the finished product? No, otherwise we wouldn't be here again. After the April meeting in 2023 and the package was ready to go, our regulatory council found a significant problem, and that is that there was a complementary regulatory language in Building Standard Codes Title 24, and that would not pass OAL. In essence, we had to pull out all areas related to the building code that are in Title 16 and move them over to Title 24 and remove all of the non-building regulations that are in Title 24. Sounds simple, but not exactly. As you can see at the bottom of page 2 of the memorandum, there is a definition of building standards in the Health and Safety Code, Section 18909. So it wasn't too difficult to identify minimum standards that are related to the building. So removing them from Title 16 and moving them to Title 24 was not that big of a deal. However, the California Building Standards Commission, which I am going to call CBSC, reviews their codes every 3 years and not quarterly like OAL. It is critical that both regulatory packages be synchronized, or we could have a problem with OAL refusing our changes because they lacked the building code. With many calls and meetings with OAL, CBSC, subcommittee, board staff, regulatory counsel, and board legal counsel, Jessica came up with a plan which will coordinate the timing of these two legislative packages, moving forward on the same timeline in two different agencies, finishing at the end of the same year, with both having an effective date of January 2026. So we better not have any more hiccups. Okay, so our president agreed that putting items 7B and 7C together. So I would suggest that you have the memorandum for 7B ready and proposed language for Title 16 and Title 24 ready.
Okay.
The MDC recommends revising the previously approved alternate veterinary premises rulemaking to move all apparent building standards, including any exemptions, to those standards and renumbering all remaining requirements accordingly. In addition, the MDC recommends a separate rulemaking to amend CCR Title 24, Sections 1251 to insert the building standards and related exemptions from the previous alternate veterinary pathway proposal and remove any practice management standards.
Okay. I'm going to interrupt you right there. I just wanted, before we move forward, because that was kind of a lot of information and I've been involved in it, so I know what that all means, but I just wanted to see if everybody's on the same page and understands what's happening with this, because we didn't talk much about it. We weren't really that in depth at the October meeting about the building code. We're all good? Okay. Up, Dr. Nolan.
So I did pull up section 1251, and so I guess my question is, we are able to propose changes to them? Is that how that's the part I'm getting a little hung up on. How do we?
Yeah,
Yes.
so after doing a lot of research, it does appear that the original language came from this board.
Okay.
And then in conversation with them, they are happy to take our proposals. Okay. Great.
Yeah, there were a number of phone calls and the timeline, and I have to say, both agencies were very cooperative in dealing with, the staggered timelines. So we're on schedule.
All right. And then I know that I feel like this next section is there's a lot to it. And I don't know, do you think do you want to go through all of the rationale for each change, or?
I was assuming that we had to do the rationale to have it in the record, or do we not?
I would say that the meeting materials themselves provide the rationale for each change for OAL and CSBC. To the extent anything needs to be modified, we absolutely need those comments and justification in the record.
Okay, so you'll keep me honest on that.
I was just going to add, sorry, that when we submit to OAL, we will include the memos.
Okay.
So, and as well as the meeting minutes and agenda.
All right. So then I will proceed with, we'll go through 3 or 4 of these, and then I'll open it up to you, for you to handle. I will not be reading the rationale, but if somebody has a question in the rationale, be sure to bring it up. So we're ready. So the first proposed amendment is to repeal Section A from Title 16, Section 2030, previously approved as subsection A2, and to amend Title 24, 1251.2 to renumber as Section 1251.1, Item 1, to reflect the following regulation on indoor lighting.
I'm just going to, again, interrupt real quick. For everyone, if you wanted to look at, we received an email yesterday, yesterday evening, with the updated proposed language. So do you guys all have that?
Yes, I do, but I don't see where it's talking about repealing anything. All I have is the proposed language. Where is he?
So the meeting memo is still the same. So the memo that you're seeing on your screen that's been in the meeting materials, that's where Dr. Sullivan is reviewing all of that.
So we need to look at that one.
That's where he's discussing why things have been taken away, and then the final product is on the in the email.
Yeah, I'm recommending you're going to be going from Title 16 to Title 24 back and forth. So,
Yeah, Chris, Dr.
Can I
Ms.
make a
Pulaski.
recommendation how I would do it in that if you're able to do this on your own computer or, the best thing is to look at and have what the proposed recommendation, right? And then compare it to the new document that you have and have them side by side so that you can see the new language. It makes it easier for you to compare what the new language is and what the proposal is, and you can compare them side to side and it'll allow you to follow. And that's how I did it yesterday. It makes it easier to follow and you can stay right along with them.
I agree, but I just wasn't caught up with him yet. So now I am.
the vast majority of this language is going to be exactly the same. We're just moving it to a different section. Okay. So we're addressed the first one, which is the old 2030 A2. And we have the rationale. Then we're going to repeal subsection B of Title 16, Section 2030. And that is going to be, well, it's in Title 24, it's renumbered and its existing text mirrors Title 24, Section 1251.3, Item 1. It's going to be renumbered 1251.1, Item 2. The next section is subsection C of Title 16, 2030, which was previously subsection A4. And that is going to have some changing to the word, from the word facility to veterinary premises. And it's going to move to Title 24, Section 1251.3, Item 2. Actually, what I'm going to do is just give you the renumbered section. So the new number is going to be 1251.1, Item 3. And let's see here. We're going to do one more and then we'll open up for questions. Repeal subsection D1 from section Title 16, Section 2030. That's going to be moved over to Title 24. New number in Section 1251.1, Item 7A. We'll do one more. Repeal subsection D2 from Title 16, Section 2030, and move it over to Title 24. And the new number will be Section 1251.1, Item 7B. So let's see if there's any questions.
Dr. Nolan?
Okay, I'm going to roll back to, again, which you want me to stay on the one on the screen or do you want me to move to the new? It doesn't matter. Okay. The number 3 under the 2030.0 is, I can read it, the first sentence, when animals are kept at the veterinary premises. That, you see that, number 3?
Right.
And then it has the statement, when they're kept at their premises for 24 hours or more, the animal shall be provided with an opportunity for proper exercise when medically appropriate. And then there's there's a whole bunch more, all the way down to 4, that it is trying to define what proper exercise when medically appropriate is. Is that correct? So I guess my question is, why did we think it was important to add all of that verbiage? Or why, what was that, what are we gaining from adding all that verbiage?
So that is existing language in our proposed minimum standards for 2030. So that's already been approved. What we're doing is we're moving that over to a different section.
Yes, when I read the 1251 and where it talked about, walking would be appropriate, the wording the wording that's in the 1251, it seems so much more clear and simple. And I kind of was like, wow, it seems like we've added a whole lot of verbiage that I'm not sure is helping us. Like, what exercise, if any, is appropriate for the particular species it's just a lot of verbiage. So that's why as I read it, I wondered if we need all that verbiage or is that important? And I couldn't
Well, the
figure out.
subcommittee worked on that for a long time and decided that the different species had different requirements, both for exercise and for the medical condition and for the facility. So, unless we're going to go species by species, we tried to include it all in this language.
I feel like we actually had a conversation about this. I could be wrong, like in the meeting when we were discussing this, and we went back and forth and finally agreed on this because there were some things that were in the old language that weren't even possible in certain instances. And so we were more descriptive here to allow for more situations, I think is what, if
Yeah.
I remember correctly.
I guess and so I can let it lay there, but I'm just saying, I think we would have been okay if we had said, shall be provided with an opportunity for proper exercise when appropriate and be done,
Well,
because it seems like we have added a lot more verbiage that may or may not make it more clear in the
our
law.
regulatory council says that certain words have to be defined, and appropriate is not well defined in enforcement.
Well, we use it 3 or 4 times in all of those subsections. We talk a lot about medically appropriate, but
Or lighting needs to be adequate.
yeah, that we continue to use them. I understand how it's nice to try to clarify them, but okay, I just wanted to remind
Well,
myself. I'm trying
what
not
I should
to-
have said was, I think that the added language
Was to define appropriate.
was to define the issue better than what the old language was.
But again, I'm not a lawyer, but I don't see how it is necessary, so.
Ms. Pulaski?
Yeah, I was part of that conversation and I remember this particular statement and it was discussed at length. And we went around trying to come up with better ways of saying it. And this was what we came to trying to determine what encompassed everything. And this was the best language that would do it. But it was not something we just
Sure.
came up with lightly.
I guess I'm trying to get you to remind me what the basis of that is, because I don't remember. And so I remember there was some reason. Remember how my first statement was, I know that we talked about why we did this, but when you read it again for the 4th or 5th time, you're like, this is very
Right.
ponderous.
I know. And I think the problem is that it's been so long because this statement was done back when I was on the MDC, because I remember it. And yeah, it's been a while.
Okay, well, thank you. I appreciate us going backwards for a minute.
Thank you. Okay, I think,
Okay, ready?
Yep.
Okay, repeal subsection F1 from Title 16, Section 2030. And we're going to move that to Title 24, Section 1251.1, Item 5. Repeal subsection F2 from Title 16, 2030. Except for renumbering and changing facility to veterinary premises, the existing language will be in Section 1251.1, Item 6. Repeal subsection G1, 4, and 5, Title 16, Section 2030. And let's see, except for renumbering, the board made no changes in the previous proposal. So that's going to be moved to Title 24, Section 1251.1, Item 8. And we'll do one more. Repeal subsection G6 regarding emergency lighting, which is Title 16 from Title 16, Section 2030. And we're going to move that to Title 24, Section 1251.2. I'm sorry, we're going to renumber it at Section 1251.1, Item 1.
I think Tara needs to tell us that we are also removing the surgery room shall be well lighted. But go ahead.
Yes, during the MDC discussion yesterday, there was additional text that will be repealed from the 2030 subsection G6 provision because it was determined that the requirement for the room to be well lighted was duplicative of what is already required under the building code standard. So I just wanted to make a note that we're also proposing that text to be stricken here in addition to the emergency lighting requirement.
Yeah, and that's on the updated text, I believe. Yes, that you received. Dr. Nolan.
On number 9, the statement, all drugs and biologicals shall be stored. That's the new word, stored, maintained, administered. So can you explain to me the difference between stored and maintained? Are we looking at different biologicals or different something? What's the difference between stored and maintained in that sentence?
Probably not, but I'll try. Stored would be, especially if it was a controlled drug in a locked facility. Maintained, I would assume, would have more to do with expiration dates to make sure they were not outdated. Again, I think, it's been a while, but I think some of that came from legal counsel looking at the pharmacy code, what words were used that are defensible.
Okay. I'm trying to read it as a veterinarian trying to obey the laws, and I'm like, I don't know what the difference is, but thank you.
And help me, other people, if.
Yeah, Dr. Solicito?
I just want to have a question with regards to the language. I think we were talking about the use of the term adequate lighting, changing it to well lighted. Or I guess
No,
I
I made an I'm sorry, I made an off the
okay.
cuff comment about appropriate versus adequate. I think we've changed it to adequate lighting for, is that
Yeah, that's.
the wording that we're using now? It was just instead of very prescriptive lighting terms in
Yeah, I guess
Title
my question is,
24, it's now, what is it? Oh, I don't have.
Sarah,
I can help.
Yes, please. Thank you.
So what the edit from yesterday goes back to, see if I don't lose my place here. (2030), I think it is B3. So the terminology there was the surgery room shall be well lit, shall have equipment for viewing radiographs. So there we remove the word shall be well lit because it's covered in another section. So that will now say the surgery room shall have equipment for viewing radiographs. That was an edit yesterday that you got last night.
May I follow up with that?
Yes, please.
So it's being stricken there
Right.
from the practice standard and instead will be covered under the building standard under 1251.1, item 1, which existing law requires indoor lighting to be adequate for its intended purpose. So instead of having to be well lighted, it'll just be, the requirement is to be adequate for the purpose.
And to let members know too, that that's existing law, so we don't have to further define what adequate means because it's existing law. So we just leave it.
How convenient. I have a quick question actually for Dr. Salicido. And we're on number 3 with the well-lit, surgery. Could you foresee a surgery room where only spays and neuters are being done, where they need to have a place to view radiographs? Is that a requirement for all surgical rooms, even let's say in a shelter that does just spays and neuters, or?
No.
The language doesn't say it's required. The language says
Says shall have, so that sounds like a requirement. to me.
shall have equipment for viewing radiographs. So my assumption when an inspection is done, they will be asked, do you have the ability to show it radiographs? And that could mean a computer, doesn't mean a wall.
Okay,
image.
okay. When I read that, it sounds like it should be permanently in the surgery room, which isn't really necessary, to be honest. So, okay. Again, I'm trying to read it as a practitioner and going, does this mean I have to put up a view box or a permanent, a screen, or what does it mean?
Dr. Gratt and I have been talking about that same issue today. Yeah. Now, are we at repealing G6? Or have we done that?
I'm not sure. Yes is the answer. I was going down my list here.
We've done repealing subsection G6? Okay.
Yes, because of
Re-
the stored and yes.
So repeal section G7, section from Title 16, section 2030. And this provision would be revised and inserted as new Title 14, section 1251.1, item 4. And then we'll do one more. We're going to add new subsection E to Title 16, section 2030. And this is to ensure that the veterinary practitioners are aware of the building standards that must be complied with. The proposal will add a new subsection E to clarify that all fixed veterinary premises also shall comply with the building standards under Title 24, Section 1251. And they have that in their packet, right? That language is there. Yeah, because I don't have that.
So I just have a question there. We've removed fixed from everything else.
I'm sorry, what?
We've removed fixed, the word fixed from everything else, and we have it here. I thought we were going with the all veterinary premises for everything and then carving out exceptions, but am I? Yes.
This subsection is for fixed facilities. I recognize what you're saying is that this entire section is now just general application to all of the premises unless otherwise exempt under a different regulation. But because this is actually making a cross-reference to the building standards, which only apply to fixed facilities, we've got that language in there specifically. So this subsection E is not going to be required for mobile units or locations where vaccination events are occurring, like grass, that you're not going to have to comply with the same building standards. So it is limited to those fixed facilities.
Okay, Jessica?
Yeah, and you also have 2030.1, those are minimum standards for small animal fixed veterinary premises. So it would apply there too.
Thank you. Any other questions? Okay, I think I might, because we're moving on to 2030.05. We'll just keep going.
Okay. So the next item is proposed amendments to previously approved Title 16, Section 2030.05, the licensing manager, amend subsection B in reference building standards. Clear? Okay. Propose amendments to previously approved Title 16, Section 2030.1, small animal fixed veterinary premises. Revive original text reference to Section 2030 in the opening paragraph and remove previously approved additions of subsection A to Section 2030.1. Okay. Removal of previously approved additions to Title 16, Section 2030.1.15, large animal fixed veterinary premises. Roland. Proposed amendments to previously approved amendments to Title 16, Section 2030.2, mobile veterinary premises. We're going to add new paragraphs.
Dr. Sullivan?
Yeah.
I want to interrupt you. We may want to note that, oh, I'm sorry, I interrupted you too.
Okay. Add new paragraphs 1, 5, 7, 9, and 9 to subsection B.
That's where I wanted to note that on 3A3, we may want to note that we added that emergency care may be available. We made that change. So we just may want to note that.
And to follow up, the intent of changing it from is available to may be available is to accommodate areas where emergency services may not be immediately available or nearby. So in those circumstances where there's no emergency services locally, the mobile unit wouldn't be required to identify some emergency service somewhere in the state. So it just reduces it from an absolute requirement to identify emergency services locations. It's a may identify those services.
Also for a large animal when there's not necessarily an availability for a large animal referral.
Okay, thank you. And everybody's good on the rationale there, right? Okay, revised proposed new subsection C, previously approved as new proposal subsection E, to remove exemption from previous paragraphs 3, 4, 10, and 20, and renumber remaining exceptions accordingly. Okay.
Any questions on the mobile? Okay. Go ahead.
Okay, proposed amendments to previously approved amendments to Title 16, Section 2030.3, animal vaccination veterinary premises. Revised proposed subsection C1 to remove exemptions for previous paragraphs 3 and 4 of subsection A of Section 2030 and renumber remaining exceptions accordingly.
Okay, I think we made some other adjustments on that, right, for 2030.3A.
Yes.
Yeah, where we just adjusted the language to be clearer for veterinarians. So subsection A now reads, for the purposes of this section, an animal vaccination veterinary premises shall mean a location at a scheduled vaccination event where a veterinarian or designated veterinary personnel administer vaccinations and perform preventative procedures for parasite control on multiple animals.
May I add, these changes were made to reduce existing confusion regarding the current regulation. As the MDC received information from a stakeholder at the meeting yesterday that there are veterinarians who are misreading the current requirement, specifically regarding maintenance of vaccination records. So we took a look at subsection A and reworked it to reduce confusion and clarify the situations where this regulation is applicable. So it's clearer that it's locations at a scheduled vaccination event. This is not a clinic where walk-ins are coming in and they're just one-off vaccinations. These are intended to be scheduled events where multiple animals may be treated, even if only one animal is presented for one vaccination. The intent is that this would apply to those situations where multiple animals are expected to receive vaccinations and parasite control. So we've retooled it to clarify it.
Thank you.
Okay, I think we're good.
All right.
Dr. Nolan?
So bear with me, but I think I'm on the vaccination veterinary premises section here, okay, 2030.3. And it looks like all minimum standards specified up above in 2030, except for paragraphs 5, 7, 8, 10, 11, and 13. Those are the current, the new numbers, right? Okay, okay. It's getting a little hard to follow all of that. Maybe it's just me, but.
Yes, it is. And Dr.
But it looks
Sullivan
like,
is
it looks
being,
like the
doing great.
continuous supply of hot and cold running water is not a requirement. It looks like it's an exemption
For,
for the clinic premises event. I'm
Correct.
having a hard time knowing what to call it. The vaccine, it's hard for me to put vaccination clinic or vaccination event with the premises word. That makes it, it's a little bit of a stretch for me. So I'm struggling through that. But
I had a
get-
hard
I
time
get-
saying it too.
I'm sorry, but I'm getting, I think that's, I'm getting it. So in other words, for section 2030.3, the water, hot and cold running water is not a requirement.
no,
Okay, thanks.
if I remember correctly, I don't have it in front of me, but I don't think so.
Okay,
Removal of previously approved additions of Title 16, Section 2030.4, animal shelter premises. We remove proposed new Title 16, Section 2030.4, because that is moving over to Title 24, Section 1251.2, subsection C, because it has again to do with, it's something we've approved, but it has something to do with the building and not the minimum standards of practice. So
okay. So I think are you through that
I
part?
think it's up to you now.
Oh. Well, I feel like we're through all of the changes, and we didn't add anything aside from, no, we didn't really add anything to Title 24 in the MDC meeting. So there's nothing, all of that was the same. So I think we should have either a motion or public comment. I think if everybody's okay with this, we can do the motion first and then we can get public comment. Dr. Grant.
I'd just like to clarify with the lawyers that the discussion Dr. Sullivan and I had this morning, that the radiographic viewing does not have to be in at least a large animal surgery unit. It can be, but it does not have to be. Because the radiographic equipment for viewing radiographs is becoming outdated.
I'm going to say that this is existing law. So to the extent board staff are reading this to require equipment in the room, I don't know. But this is existing law. So I don't, perhaps your executive officer could give us an idea, or enforcement staff, how this is being enforced.
Can
Good.
you read the exact statement? Is it in Title 20? Where is it? It's in Title 24 now, right? Let's
No,
see.
this
In
is,
the new handout, right? It's on page 4 and it is number 3 on page 4. That's what we're looking at, I think.
So there's no requirement for it to be in the room. It says have equipment for viewing radiographs. That's it. So if they have equipment, that's it.
You can have an iPad, you can have a computer, laptop,
There it is. Yeah.
anything. Just whatever. It's have equipment. I mean, we don't have a viewer, we have a computer that you just use, and it's the monitor that you use.
I think the term equipment is kind of outdated, so we're all kind of struggling with that. She'll have,
A computer is equipment. It's just
I know, but
equipment.
in the old school, it used to be the viewer box, so I think we're all, us old,
Yeah.
Should-
kind of hung up on the
that's-
equipment
Would
word.
it be better to say have the ability to view radiographs?
Yeah, that's what I would think.
Well, but now it's images versus radiographs, as was pointed out yesterday too, rather than you view or read. So
But
shall
there-
have it's the shall have bothers me. It's like you shall have equipment for viewing radiographs.
But it just says,
But
it
don't
sh-
you, go ahead.
I mean, it shall have equipment for viewing. It doesn't mean that it has to be installed in the room. You could actually just bring it in the room when, when
So,
needed.
so Dr. Grant, as a surgeon, don't you need the ability to look at images, which are technically radiographs, in order to sometimes kind of adjust what you're doing or?
Oh, yeah, all the time. But one doesn't use radiographs hardly anymore. And it seems like shall have equipment means that it's the surgery room shall have, to me, means that you have to have equipment in the room for viewing radiographs installed.
I see your point because it is specific to the surgery room. It's not.
Well, I think he and I are both hung up on the idea of viewing radiographs means you're looking at the actual film. We all view images of radiographs now and, right? I mean, so in my mind, when I read that, it means I need to have an old school viewing box in the surgery room, which seems really inappropriate to me. So, but I like what Christy said is it shall have the ability to view radiographs, and if that's how the board is looking at this now, when they do any sort of disciplinary or investigative procedure, then I'm fine with that. Sounds like, they're moving ahead with the time.
Yeah, I mean, I think that even though it's in existing law, we're here to adjust the existing law to make it better. So I like that we're discussing this now. Tara, you had your hand up.
All right, so we know this is existing law, and to the extent a surgery room does not have equipment for viewing radiographs because the improvements and significant advancements in technology. I see your point, but the question is, backing up, these are the minimum standards for veterinary premises. So accommodating these technological advancements, perhaps what we could do is when I look at page 3, subsection B, this whole section is a veterinary premises that provides aseptic surgical services shall comply with the following. And perhaps then on 4, we could strike the surgery room shall have, really strike the whole thing. And instead insert provide a means. So the veterinary premises providing aseptic surgical services here shall provide a means for reviewing or viewing radiographs. Instead of it being specific to the surgery room, the premises itself has to have some way for radiographic images to be viewed.
I think we're also hearing that maybe we need to change the word radiographs to diagnostic imaging.
Yeah,
Something
I
to
like
that
that because
effect.
there's also CTs that should be able to be viewed and MRIs and ultrasounds. Yeah, so I like that, changing it to diagnostic imaging and provide a means. I like that too, like changing it from specifically to the surgery room.
So I'll tell you right now, I don't know if providing a means is too ambiguous for OAL. but I think it, gets us closer to what your intent is, which is moving the requirement away from the room and physical equipment to, view images, to instead, make these images available for viewing somehow.
Well, I think the intent of this was to actually have the ability to evaluate a radiograph during surgery. That's why we added it. I mean, I think. So I don't know if you're right about taking it away from the room, but what I'm,
I don't think we added it. It was there.
yeah, but I think that I don't want to eliminate the idea that it's available when you're doing surgery, right? And I really like what Dr. Bradbury said about using radiograph or diagnostic images, to have accessibility to diagnostic imaging, something like that.
So what I have is, or renumbered subsection B3 on page 4, strike the whole sentence from the surgery room through viable power source, and instead insert provide a means for viewing diagnostic imaging
During surgery.
during surgery.
If needed. That also means if needed, because obviously there's a lot of, I think there are surgical centers that don't really need it. They're doing high volume spay and neuters.
I'm sorry, did you start the sentence with the surgery room?
No.
No, that's gone. Because, sure. So that whole sentence is stricken
Right. So how does,
to remove the requirement of the surgery room itself, and then instead focus on a veterinary premises that provides aseptic surgical services has to, and here is the new provision, provide a means for viewing diagnostic imaging during surgery, if applicable.
All right, I like that. I think that makes a lot of sense. Okay. So with that, yeah,
I propose an amendment to that section 3, that the surgery room sentence be stricken. In which section would the veterinary premises shall provide means for viewing diagnostic images during aseptic surgery? If
That-
applicable.
so
or
so
appropriate, or-
that sentence has just been completely replaced in that same spot. So it's under aseptic
Yep.
surgery. So now, since I think we've all agreed on that, if you would like to make a motion, that would be fantastic
For the entire thing.
for the
as
entire
amended.
thing as amended. And so I think you have to read
Okay.
at the bottom on page 7 of the memo. It has action requested, and you have to read all of those sentences if you wouldn't mind, or whoever would like to make a motion.
Page 8.
I can do it if I'm ready, if you want.
I think he wants to do it.
You want me to do it, Dr. Grant? I'm ready.
Yeah, go ahead, Chrissy, way better.
Okay. I would like to make a motion to rescind the board's prior motions approving proposed amendments to CCR Title 16, Sections 2030, 2030.05, 2030.1, 2030.2, and 2030.3, and adopting 2030.15 and 2030.4. Approve the proposed regulatory text for CCR Title 16, Sections 2030, 2030.05, 2030.1, 2030.2, and 2030.3 as set forth in Attachment 2 and amended today. Direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business, Consumer Services, and Housing Agency for review And if no adverse comments are received, authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any non-substantive changes to the text and the package, and set the matter for a hearing if requested. If after the 45-day public comment period, no adverse comments are received and no public hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulations as described in the text notice for CCR Title 16, Sections 2030, 2030.05, 2030.1, 2030.2, and 2030.3.
I second.
Yay. Nice job. Public comment in the room. I see none. That means you've done really good work, Dr. Sullivan. Moderator, would you open it up to public comment online, please?
Absolutely. We are open for public comment via WebEx. If you'd like to make a comment on the motion, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users dial *3 to raise a hand. And for our mobile device users, please remember you have 3 different screens and only one of them has a hand button. So tap the ... that's the ellipses button at the bottom in order to find your hand button. And first we're going to hear from Dr. Jenny Godkin. I hope I said that correctly. Please put that hand back up. Thank you. And I'm going to send you a request to unmute your microphone. You'll have 3 minutes to speak, and I'll give you a 15-second warning before your time expires.
Hi there, thank you. This is Dr. Jenny Gedkin. I am a former VMB inspector. And one thing I just wanted to point out with the current regulations on Title 16, Section 2030B3 that I did not catch yesterday at the MDC committee meeting is emergency lighting for Cal building is different than what inspectors are enforcing during inspection as emergency lighting. There is also a standard for inspectors to make sure that when we inspect for number 25, surgery lighting, x-ray emergency, that we are actually making sure that there is functional emergency lighting with backup battery operated lighting sufficient to illuminate the surgical field as well. So I do want to point out that it's being enforced that, yeah, you have backup lights in surgery, but as an inspector while I'm there, I say if the lights go out and you're elbow deep in an abdomen, those wall lights are not going to do anything. So we have also been enforcing from inspections, making sure that you have adequate lighting to illuminate the surgical field, which I believe is different than the Cal building regulation intent. So I do just want to point that out right now, that I believe what's being actually looked at boots on the ground during inspections does contain a component that is not technically addressed by the regs, which is emergency lighting sufficient to illuminate a surgical field. Thank you.
Thank you. And that was our only request for a public comment.
Thank you, moderator. Well, that is interesting. Any other discussion about that since we just removed that from, go ahead, Jessica.
Well, the emergency lighting too is also, it's in the building code standard. So it is in there and it says it shall be adequate for its intended purpose. So if you sorry, so I was saying it is in the building code standard under 1251.1 item 1 for the emergency lighting. And so, and that's existing law and it does say adequate. So I'd make an argument that if it's not illuminating the surgical area, then it's not adequate. So I think we're okay with, especially because it's existing law.
Okay, I'm good with that. Is any other discussion? Oh, all right. Then let's call for a vote. Jessica, needs a minute. Go ahead.
Dr. Solocito,
I,
Dr. Grant,
Aye.
Dr. Noland,
Yes.
Ms. Pulowski,
Yes.
Ms. Prado,
Yes.
Dr. Bradbury.
Yes.
Motion carries.
Okay, so now we also need a motion for the Title 24. And I'm having a hard time finding it on here because there we are. So at the bottom of page, go ahead. Oh, I thought you said, on the bottom of page 4, there is, this is to approve the changes to Title 24. Yes, Tara.
So we just received public comment regarding emergency lighting in a surgery room. We're already striking the lighting requirements from the practice standard in 2030, but I'm asking the board if you would like to consider revising the building standard proposal on page 6, section 1251.1, item 1. I believe this is what the public commenter was proposing. Right now, the proposed revisions to this section would be indoor lighting shall be adequate for its intended purpose. All surgical rooms shall be provided with emergency lighting with a viable power source. And I think the concern raised was that the surgical room should be provided with emergency lighting sufficient to illuminate the surgical field. I think that was a clarification that was trying to be communicated. And I'm wondering if the board members would like to consider inserting that type of language here. I can read that again.
Yeah, can you, I'm looking at the memo and I'm having a hard time. What page are you? You said you were on page 6?
Of attachment 1 to item 7C. Yeah, if you look on the screen.
Yeah, I'm just in a different memo apparently. I
Is
saved
it-
an
is it-
earlier one.
is it possible to just add to the existing language about having adequate light, like emergency lighting, to accomplish or continue with like the procedure? Because I just feel it would be very hard to say just specifically for the surgical field, but if you have adequate lighting that would allow you to complete like the procedure. Yeah, that would be my suggestion.
Dr. Nolan?
Yeah, I'm actually pretty comfortable with 1251.11 or whatever the, I feel like it's, and we probably all been in emergencies where I've used a headlamp, I've used a cell phone. I mean, that we're kind of in an age where you get it done. And like Dr. Grant was saying, most of us, we were talking about abdominal surgery. We have a fairly small window anyway. We're not really, we're really doing a lot of it by feel and anatomical knowledge, for instance, the spay, I don't have a wide open field. So I think the wording is adequate. And it's my thought.
Yeah, and I was just going to go back to, so I think that the concern is that we need to add sufficient to illuminate the surgical field. But again, going back to that first sentence, if you have emergency, it's for its intended purpose. So if you have emergency lighting in the surgical room, the intended purpose is to light up the surgeries that you're doing. So I feel like we can make an argument that if it doesn't, it's not adequate.
Dr. Sullivan?
Yeah. I was just going to say the same thing. That is existing law. When inspectors have come in, we've had to show them what kind of lighting we have to see the surgical site. And it's not just the room, it's what's adequate for what we're doing.
Okay. I don't see any other comments. So I think what we're saying is we're all comfortable with the language the way it is. Thank you, though, for rewording it and making sure. Is there anybody who would like to make a motion?
Sorry, she had it ready. I got it. Okay. So I make a motion to approve the regulatory text for CCR Title 24, Section 1251. Direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review, and if no adverse comments are received, authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any non-substantive changes to the text and the package, and set the matter for a hearing if requested. If after the 45-day public comment period, no adverse comments are received and no public hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulations as described in the text notice for CCR Title 24, Section 1251. And did I say as today? Okay, I don't need to because I don't need to say that because we.
I second the motion.
Great. We have a motion and a second. Public comment in the room? Seeing none, moderator, can you open it up to the online audience, please?
We are open for public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Okay, let's go ahead and take a vote.
Dr. Solocito,
Yes.
Dr. Grant,
Yes.
Dr. Noland,
Yes.
Ms. Pulowski,
Yes.
Ms. Prado,
Yes.
Dr. Bradbury,
Yes.
motion carries.
Okay, fantastic. I'm sorry, Dr. Sullivan, but I think that this was very successful, first of all. Thank you. It is kind of time to take a break for lunch. Oh, yeah, Jessica?
I just want to say before we break for lunch, I just really want to acknowledge also, I know we all did a lot of work to this, but also thank our prior legal counsel, Christy Shields, for all the work that she provided on this. I know it was frustrating at times, but she caught a lot of things that we needed to improve. So I just really wanted to acknowledge her and her hard work for all of that. And then also welcome Elizabeth, who is our new reg counsel.
Thank you. Okay, with that, we'll come back at 1. Is that a good? Okay. We'll come back at 1, so we'll adjourn for lunch. Thank you. Are we recording?
This is the moderator. We are recording.
Great, thank you. All right, so we'll come back into session. Dr. Sullivan.
Okay. Okay, recommendations regarding medical records. This is agenda item 7D. Medical records began with work done by the equine subcommittee with meetings with many stakeholders. We realized that written records needed to be updated to not only include records for individual patients, but also for group of animals treated at the same time at the same location, including equine production animals and small animals such as kennels and catteries. While working on this issue, the subcommittee wanted to look more closely at the request of a client to receive a copy of the written records. Since statute only required a summary, the subcommittee decided that we needed both a legislative change and as well as a regulatory package. Therefore, we are proposing to amend BPC sections 4826.6 and 4855. While discussing this at the October 2023 meeting, there was a great discussion as to when a summary may be indicated and when a copy would be required and the timeline for each. Now, I'm going to quote some of this right from the memorandum because it's pretty specific. It's detailed, but it goes to the point. As such, the subcommittee recommended requiring a copy of the written records be provided to the client or the client's authorized agent within 5 days of the client or the authorized agent's request. If the animal's in critical condition, the subcommittee recommended requiring either a copy or a summary be provided at the time of the request. This would allow the veterinarian to choose the referring veterinarian to choose whatever option may be easier to provide to the client at the time of the request for the critical animal patient. At the January 16th, 2024 MDC meeting, the MDC discussed and approved the subcommittee's recommendation with minor amendment. After approving the recommendation and the legislative proposal, the MDC made additional amendments to the regulatory proposal. Some of the amendments to the regulatory proposal were intended to mirror the legislative proposal, but those edits were not reflected in the MDC's final motion on the legislative proposal. Some of the amendments to the regulatory proposal were intended to mirror the legislative proposal, but those edits were not reflected in the final motion of the MDC. So the attached legislative proposal would include the requirement for when a copy of written records must be provided to the client or the client's authorized agent to include either an emergency or a recommendation for the direct transfer to another veterinary premises to ensure subsequent veterinarians have sufficient information regarding the animal patient's condition from the original veterinarian. As this provision is proposed to be added to the statute, the attached regulatory proposal discussed below will no longer include this text as previously approved by the MDC. So from that, I think we can go directly to, I think that's enough history that we can go directly to the recommendation, the initial rulemaking to amend California Code Title 16, 2032.3. The list of the amendments are on page 3 of the memorandum. And that's how far we got before it became obvious, and correct me if I'm wrong, but it became obvious that we would be better off putting all of this in statute. Am I getting that correct? More or less. All right. Another issue has been raised recently, both at CVMA meeting, a recent meeting of CVMA, and at an AAVSB meeting that I attended last week. And it has to do with financial records. So while financial records may be considered different than the medical records, both types are considered part of the written record. To alleviate confusion, the subcommittee recommended reverting back to the current law in BPC sections 4855 and Title 16, section 2032.3, which do not specify medical versus financial. Instead, the subcommittee recommends adding any invoice and client payment related to services and treatment provided to the list of items that must be contained in the written record. So from that, I think I alluded to, but did not mention that we decided to remove the term medical record and just say written record so that we would get away from some of the problems we're having with the regulations and the statute. So from there, then I think we can, I guess, answer some questions and then go to the wording of, we can then go to the actual wording and go from there.
Okay, thanks. Dr. Nolan, did you have some questions?
And now's the time? I thought we were going to go through.
Yeah, I think we might as well.
You know, Dr. Sullivan, I thought I read that we didn't change it to written. It just went to record. Am I wrong? Or is he talking about, I know we took the medical out and I thought we just left it as record, but am I trying to find it real quick?
I'm pretty sure it's written record, but
Written
The
record now.
statute says written record.
Record written, okay, okay. Well, I went ahead and did a bit of research in what we're doing in the medical, the physicians world in California, just because I was really, I am struggling quite a bit with some of the changes that we are proposing. And I have a number of, I hate to use the word concerns, but I just have another number of areas that I am concerned about. I guess that's the right word. And I think if I step back, I think it's really important to realize that a lot of times as a veterinarian, and I know there's some people that don't do it well, and that's why we're, putting a lot of regulations and statutes in play. But professional courtesy is I pick up the phone and call the veterinarian I'm referring a client to, whether it's an emergency clinic that night or something. It's a professional courtesy, which is actually very prevalent. There are no laws in California that regulate physicians having to pass records on to the next referral physician. There are no rules that regulate that. It is considered a part of their professional duty, to have that relationship. And so I don't want to do anything that starts to make that seem inappropriate. I think that's something that we as veterinarians, that's what's best for our patients, is to have good, clear communication. But I do start to get really nervous when we start talking about a client or authorized agent giving verbal requests to give records. I can think of a lot of situations in practice. Who's giving the verbal request? Is it over a telephone? Is it the husband? Is it the wife? Is it a neighbor? To me that I start to worry about my ability to keep the integrity of those records. I would like it to be written so that I know for sure that it is somebody that deserves to get the records. Does that make sense? So that bothers me. I also feel like in human medical profession, they give the client, or the patient in this case, the ability to come and to look at the records within 5 business days, 5 days during regular business hours. They can come and look at their records when they want. But it gives the physician's office 15 days to actually compile a summary or to copy the records and give them to the client. And because it takes time, it takes staff, there's a bit of an onerous, especially if you're a private practitioner that has a small clinic and you are doing your record writing at night, right? And then you're going back the next day and hitting, a whole waiting room full of people again. And so I think we need to be really, I think the idea of protecting the client and the patient is really important. But I also think that we already have a burnout situation and and less veterinarians than I think we need, right? And so now we're going to add more regulations to them that may actually cause more burnout and actually backfire on us. So that's why I'm struggling a little bit with some of these requirements. Again, I may be all by myself in this, but those are the things I think about, and it makes me a little nervous. And I also am a little nervous about requiring the invoicing and the client information, the client payment information, because I have clients that I have their credit card on file because they travel and they have their authorized agent that, brings their animals in and out and whatnot. And so now all of a sudden I'm responsible for redacting that or making sure that doesn't leave my, that gets out and about and it's my fault. So those are just questions that I've had as I read through this that I wanted to just kind of bring up. So.
Okay, let me address a couple of these.
Can I ask a question first? Yeah, sorry. So Dr. Nolan, when you're talking about the time for records, are you comfortable with the immediate summary being needed if they have to be transferred to an emergency care or another practice?
I'm going to throw that question back on you. How many times do you stop and write down a summary? How many times do you call up someone that you trust and talk to them and then say, I'll get you the summary, I'll email it to you tomorrow,
Yeah,
How do you do that?
So I can tell you that I've been on both sides of that because I have patients that get transferred to me, have patients that would be transferred to me, and very often and frustratingly, I had nobody I could talk to, nobody who would get on the phone, and I didn't have records. And so I would be repeating diagnostics that the client had already paid for so that I could understand what was going on. I would try not to do that and do, my moving forward based on the limited, my physical exam and what the clients had said, but often, lab work, images, those sorts of things, and a summary, like no idea of what they actually did in surgery. I mean, I actually just ultrasounded a patient that we didn't have the surgical report, and they took out a salivary gland. We have no idea, so I'm looking to try and determine what's happening there. So, I've been on that side of it, and it unfortunately happened a lot, and it was very difficult. And we'd call the clinics and try and get it. If it was after hours in particular, you're not going to get it. So if the client hadn't asked for it and been provided whatever information they could, that was a situation. For when I would refer patients, I would try and call a lot of times who I would be referring to would be UC Davis for dialysis or some other procedure. I would be sometimes on the phone for 2 or 3 hours, like having somebody on hold to try. It's better now, but there was a time. And even then, we couldn't get a doctor on the phone, but we were still having to talk to somebody to try and even have them accept the transfer. For dialysis, they'd always get on the phone, but it would take a little while to get a hold of them. But I would get as much information as I had, and I would put it in a packet, and I would write a summary. So I would in every case when I was doing that, I would be providing that information. But I'm in a little bit of a specialized situation, but still I think, and I feel like that's how everybody in the practice I was at and in the other specialty practices that I've been at have been deal with all the time is trying to get that information is difficult.
And then let's say you were going, and I know you're a referral veterinarian, but if you're getting ready to send an animal over for emergency treatment at a referral practice, you're able to stop right there and write down your summary or write down that information or copy the records and give them to the person as they go. You have time to do that.
I don't have time to do that, but I make time to do that. And it's mainly because I feel like it's really important that they have as much information as possible, but it often means that my things have been pushed back, and it depends on, where it's being referred to and how quickly it's happening, but I kind of drop everything to do that.
Yeah. And again,
Oh, Dr. Sullivan. Yeah, sorry. Oh. But go ahead, finish what you're saying.
I can certainly see that side of it as well. And I think that, we talk about the letter of the law and then we talk about the purpose and the intent of the law. And I feel like sometimes we get the letter of the law right, but we have untoward results down the road that may or may not really support our intent, which is to protect the consumer and the animal. And so I'm just trying, I know I'm playing devil's advocate, so I apologize for that, but I'm just trying to think through from the standpoint of the logistics of it and whether this becomes onerous enough. And also, so let's say a veterinarian's referring an animal to another veterinarian, maybe the client's, asks for a second opinion. It's a rather urgent matter. They don't get the records in time. Everything turns out fine with the animal. They're going to come back and file a complaint because they didn't get the records in time. Do we have time to handle that kind of complaint? We have dead animals. We have animals that are receiving severe harm. And so I'm starting to, I just feel like, I don't know, I am struggling, but.
So if I may, we actually wrote this to be flexible. So we started off we felt that 5 days should be long enough to have your medical records finalized for that visit 5 days ago. We can make it 10, But the longer you make it, the more ability is to amend records with, you know, with.
So let me stop you and
with-
ask you, so there's is it really clear in this wording that it's not the complete medical record, but it's
Wait, no,
just?
no, let me finish. So we've put in here flexibility. So if it is an emergency or urgent transfer, maybe for surgery the next day or two, the veterinarian has the option of either giving a summary or printing off the medical records, the written records, making a copy or just printing them up. Their choice, get the animal to where it needs to go. But we wanted a timeline as to when those medical records should have been completed by the veterinarian. We picked 5 days. I know other districts make it longer than that, but that's the thinking behind it.
Jessica?
Yeah, and just the 5 days, Mary's current law is when to provide the summary. 5 days is the law.
Ms. Pulaski, did you have something?
I was just going to concur with what you were saying in that as an emergency hospital, we receive patients in and we refer out, and we get on the phone and our doctors call and we make that phone call, but we also give summaries to people because I don't think it's fair to a consumer to have to go somewhere and having been on the receiving end, so been on both ends, you get information, and now do we have to repeat blood work? Or does somebody else have to repeat blood work? They need to know what is done. And if a summary or medical records are not given with the client, they have no idea what is supposed to be done. And 5 days, I think, is sufficient. We're past COVID times. We're not in that time anymore, and I don't think we can use that as an excuse. And I think 5 days is sufficient.
Can I ask you a question? Do you feel like a summary or the complete records should be the choice of the veterinarian that is referring or sending the animal out? Or do you think that's something that?
For a critical pet, for a referral for a critical pet, in an emergency situation, a summary or the medical record, I will tell you most of the time, if we're referring a pet out, it's almost a complete record that we're sending. It's almost complete. The doctor may have to go back and make, some final adjustments to the medical record. Yeah, I think that. But I think 5 days for a complete medical record, if the client, or a written record, if the client is requesting it or their authorized agent is requesting it, I think 5 days is plenty of time for a client to be able to request it and receive it, because they should be able to get it to be able to get to their next veterinarian. I think that's sufficient time.
And do you have a staff member that is delegated to do the copying and the organization and whatnot?
I mean, any of our staff can do it.
Okay.
It's
Just
not.
curious, so I'm just asking.
Yeah,
so-
because it's not, I mean, everything's computerized.
Yeah.
So most
Well,
of the
not
time,
everything, and I mean, you live in a perfect world. Not every veterinary clinic is
Right.
computerized.
right, and I understand that, but yeah, and I get that, and I totally understand that. Most things are, and they can be sent quickly, but even if they're not, and they have to copy things, it doesn't take that long.
Jessica?
Yeah, so Dr. Nolan, you asked a question related to enforcement cases. And so one of the discussions the subcommittee had too was the board does receive complaints from consumers who their main complaint is they want a copy of their record. And we have written to, and I would say the bulk, I'm not concerned about the bulk of the veterinarians because they will provide a copy of the record when requested. But in certain cases, when the veterinarian refuses and says, I didn't break the law, I'm only required to give a summary, I did that, that's it. And actually prolongs the enforcement part of it, because then we will write to the respondent. The respondent says, no, he complied with the law, or she complied with the law. And we are entitled to a copy of the record. So we request the records for our investigation, but we then cannot provide that to the client because it's confidential information, part of the investigative file. So we're in a situation where we have the records, we can't provide it to the client, and the client just wants a copy of the records. And there's various reasons why they request copies of the records for their own record keeping. A lot of times is with insurance companies, and that's one of the big reasons why the invoices and payments are in there as well, because they need to show that to insurance companies, the breakdown to be reimbursed. But as far as enforcement goes, I think this actually would help with those enforcement complaints, because we could just say the law is that you provide a copy of the record.
Tara.
I also wanted to point out that the Practice Act does have a definition of client now. But this is pretty recent. And this, any practitioner can rely on this definition now, which is the individual or individuals who represent to the veterinarian that they are the owner or owners of the animal patient at the time the services are provided. So that's something on which to rely. And then the authorized agent of the client could also request this. I think being able to request the summary or records verbally is important, because if you're at the veterinary premises and you're picking up your animal for immediate transport, you don't have time to, okay, hold on, let me stop. Let me, email you a written request for, these records. I think oral is appropriate in that circumstance. And also this legislative amendment is about submitting records to clients. There's a separate provision, Business and Professions Code Section 4857 Subdivision D. This is the statute that prohibits veterinarians from disclosing medical records. Subdivision D specifically authorizes the exchange of medical information between practitioners for the animal's care. So this legislative proposal has really nothing to do with the inter-veterinarian communication, which is limited to medical information, not written, which potentially could include that financial information that concern was raised about. So there are some existing protections.
Yeah. Well, I guess I would respond to that, Tara. Thank you. But if I have a client standing there waiting for these medical records and they verbally say, I want my records, I want them to sign something that said they just requested their records. And if they're standing right there, a signature is not hard to do. So in my mind, the written record could be very simply, here, sign this, said that you want your record, sign it, so that I know you requested it. And when you're in the middle of a divorced spouse comes in, I don't have any, I have a record that you signed to get him, and that's why I said yes. I think that's not onerous at all, and that's why I don't think verbal implies you could be on the phone, or, and there's no interaction, and then now all of a sudden, who am I talking to? You know what I mean? So that's why I don't think limiting it to written is a onerous thing or a problem, in my opinion.
Yeah, I see what you're saying there. And I also think it's difficult to note like how it's a kind of he said, she said, oh, I asked for it on this day and there's no evidence of that. How do you even enforce that if it's not written? So anyway, I wouldn't be averse to changing it to written request. Dr. Grant.
Just to make it clear to everybody, a written record still can include a text, right? And a text picture of lab results, that's all written. Does that need to be clarified any place, or was just assumed these days that that's written?
I'm seeing nobody's shaking their head. Okay. So are we, yes, Ms. Prado.
Sorry, just a clarifying question. 5 days is 5 business days or calendar days? And I was trying to see where that's defined.
So typically, when it's not specified, it reverts to calendar days.
Okay, before we move forward, is anybody else? Yes. Ms.
So
Kowalski.
I understand. I understand what you're saying about the written and the verbal request. But as a consumer, I feel like you're making it more difficult for me. You're limiting my method. I understand that you're trying to protect me, but as a consumer, I don't understand that because I want to be able to call up and say, can you email me my record, or can you email my record, my medical record, to my next veterinarian?
Well, if you're requesting me to email the record, why can't you send me an email requesting that?
But that's like, I don't want to have to send, I don't want to have to get on my, this is a client saying this. I've made a phone call to you because it's easy for me. And now you're making me get on the phone, get on my email and send an email to you. And so I'm just saying, this is just another step that they have to do when when they could have just said, I would like you to do this. I'm giving you my authorization by calling you.
Again, I think there's a reason why the human medical profession requires a written written request as well. I think it's a protective thing. And if the consumer doesn't realize it's a protective thing, there are a few people that will realize it after the fact.
Diana?
I will say too, it's in terms of like, why don't you just email me, an accessibility issue? So perhaps it's more accessible for the consumer to be able to make that call. And then, and again, I'm not a veterinarian, but I would say that in order to then protect yourself as a veterinarian, one would put that in the records, like a call made to our office for vet records. And then on your end, it's on the veterinarian's office end, it's written somewhere that this was made. But in terms also just to Ms. Pawlowski's point of what is easier for the consumer. I mean, I understand both sides. It's also just how do we make it accessible and easy for the consumer? How also do we protect the veterinarian so that they're not like, oh, I called, and they're like, you never called. But perhaps then it's just a practice for each veterinarian in their own internal policies that if a call is made, we note that in our records in order to be able to protect ourselves, or we send an email. And then I just think of a lot of like seniors that maybe don't have access. I'm not calling out seniors, but I'm like, they could have very access to email or do that or capable of, but those that aren't perhaps computer literate or literate at all, right? To be able to only be able to access the records through verbal communication.
Dr. Felicito?
I hate to complicate the conversation further. No, because this is an actual situation that I dealt with. We had a person requesting for medical records, for written records. And it's the girlfriend, but is not the owner on record, right? But based on the conversation, the way that it was explained that I am the co-owner, yada, yada, so now that was a little bit of a confusion now because of releasing records with nothing written because it's all on the phone. And then later on, we found out that there was some sort of a custody issue between the couple. So that's why I kind of am leaning towards the written, part of it because of things happening like that. So.
Well, and sometimes, I guess different practices have different policies, but my written records have the owner's name, address, phone number, how to contact them. And so if you're in a custody dispute, that's a pretty easy way to get information that maybe you can't, shouldn't be getting. So.
I think I'm going to open it up to public comment because this has been a robust conversation, and I want to see if there's anybody in the public members that have any questions or comments on this section.
Okay, Bonnie Lutz. I'll have to admit, this is the first I've heard of any of this, and it did make my blood pressure go up a bit. Okay, so as far as the summary or copy, it's my understanding that if it's an emergency situation, you can provide a summary. Otherwise, you have to provide a copy within 5 days. My problem is there's no definition of what's in the summary, and there used to be a definition of what's in the summary. And I believe that's still in the regulation.
Still there.
So that, I've done a lot of these summaries, and that's pretty detailed stuff. So if your reason for having, allowing veterinarians to provide a summary under emergent conditions is to be able to get a quick sort of double down to the issues so that they can transfer over to another facility, then to have to put all those details that are listed in what has to be in a summary, essentially the summary parroted what had to be in the record. And so I think that you might want to change that regulation that talks about what has to be in the summary if the intent is to provide fast information so that the client can just take it over to the other facility. So that's that. As far as invoice and client payment information, I guess it's my understanding that your FAQs that are now on your website will change because there's clearly an FAQ that says that the board does not have any authority over financial matters. And if the invoices and client payment information are going to be given to the client, I assume that when the board asks my clients, the vets, for their records, that they're going to assume that they're going to get the invoices and payment information. I have a major problem with that for so many reasons. First of all, there's a lot of client confidentiality issues related. That would mean that we'd have to redact a lot of the information from those records. I don't know that I want to be the holder of those records that have potential client information, credit card numbers, and things like that. Also, for those of you who are veterinarians, I'm sure you know that even with computerized records, it's not a simple thing of doing a task and billing it and invoicing it and getting paid. That's not how it works in vet hospitals. You have an estimate, you try to get payment up front because oftentimes you won't get paid if you don't get payment up front. So then you go in to do the surgery, you find different things in the surgery, or you don't find what you thought you were going to find. The treatment changes. There's changes made to the invoices. People don't have the money. You say, okay, fine, you can come back later and pay. They come back and they want to pay you in cash because they just got some kind of a big, they have that kind of a job where they get paid in cash. It doesn't somehow get transferred to that client's record right away that payment was made. It's just a mess. And so even with good computerized records, plus I frankly don't think that the vet board has the authority to be looking at that kind of private information. My other concern is that kind of information getting in the hands of other veterinarians, because veterinarians now with corporate takeovers are very competitive. And I don't know that the run-of-the-mill veterinarian wants Joe Blow down the street competition, knowing how much they're charging for a spay and neuter or whatever. So I have a real problem with the invoices and client payment information being included in the medical record. Now, we've been asked a couple of times on an individual case, nicely by enforcement, who again, I always give a shout out because Jessica does such a good job and all the enforcement analysts are amazing, but they will send us a nice letter and said, please, in this case, can you please provide the invoices? And we're happy to do that. But to have that be part of the medical record, these medical records get sent all over the place and there's a lot of client information in there. I have a real problem with that. So thank you.
Thank you.
Hi, Grant Miller, CVMA. So in regard to the proposed statutory amendments to 4855, I would caution you, anytime you take something out of regulations and put it in statute, you're effectively losing it. Because statute, to change it, requires a legislator. It requires then the legislature to pass it. It requires the governor. When you do regs, it's you. So I would be very careful about what you're putting into statute. Once you put it in there, I consider it gone. And that's based on my 25 years of experience in public policy and watching in the way it goes. So I do think that if you were to make a statutory change, you could probably make it with much less wording here. You could leave a lot of this back in regs and specify what you want to specify here. but I think that it's a little excessive in the way that it's written. Granted, I did assist with this subcommittee. However, some of these changes are not something I was aware of. So I'm commenting post the work that I did with the subcommittee on these records. From the equine side of things, and we discussed, this is something I did discuss with the subcommittee, is this concept of if you're in the emergency and the client has to go to the emergency hospital, what record can you get together to go with them? And the idea of doing it at the time of request, it can be really onerous for the equine guys. So for instance, if I'm out treating a colic, I would say I have cell service in about 50% of the area that I work in. And I'm out treating a colic, and sometimes I'll treat 2 or 3 of them at a time where I'm just getting call after call after call. The challenge of carrying along a laptop computer and then writing out this record while I have another horse, if I have to choose to save another horse's life or write a record, I know what my choice is going to be. I'm sorry that the board is going to make me have to put that first and possibly penalize me for making the choice to save another horse's life versus sitting down and writing a record. But the fact is that on the equine side, if I'm referring a case to a hospital, I am calling that hospital and I'm telling them I'm sending this horse. Here's what I did. Here's how much Banamine I gave. Here's how much sedation I gave. Off the horse goes. So we do our best. Is it perfect? No, it's not perfect. But to sit down and have to write this summary, it's implausible. All the equine people know that. And part of the upset of the equine community with this board is that this board is only thinking about small animal clinics and how fun it is to have this computer system and the assistant and the tech. We don't have any of that. We're out there on our own. So please consider that as you move forward. I want to know, can I make comments on the financial side of it, or are we waiting? Because that wasn't actually presented yet, the financial part.
Go ahead.
All right.
We need to let him finish it.
Sure. Or, well,
We're supposed to just let public, yeah.
so regarding the financial part, which is these items in regulations that were added on, items K, any invoice or client payment. 100% of veterinarians in California are deficient in their medical records. None of us can do them correctly. None of them are ever sufficient. To add this on is going to turn the screw far too tight for us to handle. So for instance, in my situation, I have clients that are charity clients for me, and I don't give them an invoice. I say to them, okay, your horse needs a dental. How much do you want to pay? Do you have $100? Yeah, okay, give me $100. There's no invoice, there's no payment, there's no receipt, there's none of that. In instances where I do that, that is a handwritten little tablet that I carry that says, here's, I did a dental, it's $200 for the dental. But my records are done on a computer. So now I'm going to have to take the time to synthesize for each appointment I have. I'm gonna have to synthesize the payment information into that record. The purpose of the record is to help doctors and clients understand what happened to their animal. It's not about money. It's about medically what is happening with this patient so that one doctor can look at it to the next and the client can look at it and say, okay, I can see what happened, what test was run, et cetera. This represents a far greater requirement for us as veterinarians on a record by record basis to have to synthesize this information in, and it's not something that the CVMA is interested in supporting. Thank you.
Okay. Yes, please. Oh, sorry. Well, and there doesn't seem like anyone else in the room. Moderator, can you open it up to the folks online, please?
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Judy Mancuso, followed by Dr. Jenny Godskin. Hold on, Judy. We're going to send you a request to unmute your microphone.
Hello?
Go ahead, please.
Okay. As a consumer, this just happened to me 2 weeks ago. And I would like to echo what the members, Chair Bradbury, Pulowski, and Prado have said. So I was at the first veterinarian who had referred me to a dermatologist veterinarian, but they couldn't take me for a couple weeks to come. And I needed to resolve my cat's issue that seemed pretty important and needed to take care of. So I went to another vet here in town, and she asked me, okay, did she get a steroid shot? And I knew that she had had antibiotic shot, but wasn't aware of the steroid. And I said, well, I don't know. I mean, we better get her records because she didn't want to give her another one if she had already just had one. So what I did, exactly what you guys are saying, I picked up the telephone and I called that vet office and said, hey, I'm at Dr. George's. Can you send me over Bella's vet records because she needs to know what medication she has so she can treat her for me. And the receptionist was like, well, I'll send them to you later. I don't know, blah, blah, blah. And I was taken aback because I never even thought that that would be a response. And then we waited, and I'm waiting because now we can't resolve Bella's issue until we know about this. And then I called again and she said, okay, the doctor said it's okay. I'm going to send them now. And I said, thank you very much. And they sent them. Dr. George was able to then make her recommendation, do the meds, and I was off and running. That was pretty flawless to me. I would have liked to have got them immediately, but to throw some kind of wrench in this thing to where, as a consumer with my animal, that I cannot get immediate help because the other vet office is not complying in a timely manner. And I will say the only vet hospitals in my history I've had
15 seconds.
Okay. In my years are ones that have shoddy records that don't want to step up and send you the records. So as a consumer, I really support this. Thank you all so much.
Thank you. And next, Dr. Jenny Godkin. Hold on just a moment. We're going to send you a request to unmute your microphone.
Hi there, this is Dr. Jenny Gedkin. I am a consultant to the Enforcement Office of the VMB, and I just wanted to put out a few things. As a veterinarian who also has access to the consumer complaints that are waiting in line to be addressed, some as far as 2019. The first thing is, and I think Dr. Miller stated this, we do have to keep in mind the non-traditional small animal brick and mortar. I do see quite a few complaints directed towards non-small animals that are in that box. So we always have to make sure that we are looking at this from all sides. I think Ms. Sieferman also said this too, not getting records in a timely fashion is already coming in for complaints. So we are getting that maybe a bit more than people realize. It doesn't seem to be the crux of many of consumer complaints that I'm looking at now. It seems to be more peripheral. But without anything in writing, that is something that's a he said, she said. And by the time, I know the way I review cases, by the time I get to this case that might be a few years old because of our backlog, that part of the issue is not really not really discoverable. I'm not sure, like I said, it's a he said, she said on that situation. The last thing I want to point out is if, one of the goals is maybe recruiting and maintaining a pool of quality and consistent subject matter experts that are reviewing these consumer complaint cases as they come in. Right now, a lot of feedback is that the records that we receive to review, a lot of the records are superfluous. We're looking many times at a date or a narrow range of dates, and some clinics have 87 pages when I'm only trying to sift through and find one date. So adding on the financials on top of all the points that have already been made, when financials don't seem to be the issue that we can address. I'm looking at the medicine and trying to see what medicine was practiced, et cetera. Adding in more paperwork for us to review and compare when the crux of a complaint isn't necessarily, I paid for this service and never received it, would be more onerous even to the review process once it's handed down to a veterinarian. So I do think, as Dr. Miller said, putting stuff in statute might bind us, because perhaps this is something that enforcement might want to consider handling on a case-by-case basis. If a complaint seems to state that there was services she or he were charged for that weren't rendered, that might
15 seconds.
that might be able to kick in a request for records as well as financial documents from that veterinarian to enforcement. Thank you.
And those were all of our requests for public comment.
Thank you, moderator. So just in terms of the financials, I think we're forgetting that we're looking at restitution now, and clients, if this is consumers asking for their records and needing some of this information for insurance claims. So it's not, I don't think it's meant to go to other people, but that's just one comment I had. And then I just also wanted to say that we are working very hard to not just be myopic in our views, and we are working to include the equine committee or the equine community, and work with the large animal folks to try and make these regulations and statutes more inclusive of the needs of the variety of different practices that we have. So I wanted to, I feel like we've been trying very hard to do that, and it, the comment that we are really just focused on small animal, I just don't think is accurate. I do agree that a lot of things are related to small animal too, but in any case, I think first I thought Tara had a comment.
On the point of verbal or written requests for records, I just wanted to note that for human patients, they only have to submit a request for the records. It's not indicated that it has to be a written request. It's just a request, which likely could be written or verbal. That is Health and Safety Code Section 123110, Subdivision A. To reiterate, there currently exists a 5-day deadline to provide a summary of the patient records upon request.
I'm sorry, Chair, but I need to stop you. That is a 5 business days where they're allowed to come in and look at their records. It's not a copy of the records given to them. That 5 days is simply their ability to see their records personally.
I believe Tara is talking about our own rules right now. And you're referring to the human medical side.
I thought that's what she was talking about when they said they request their records and then there's a 5-day period, but the 5-day period is they're allowed to see their records. They can come into the office during regular business hours and see their records. And again, part of it is because human medical records are voluminous, to be honest. And there's just, it would be really onerous, I think, to copy those in a 5-day
Jessica.
period. They have a 15-day period. That's what I was told.
So current law says a summary of an animal's medical record shall be made available to the client within 5 days or sooner, depending if the animal is in critical condition upon his or her request.
So you're not talking about the human medical world now. We switched over. Okay, so I'm sorry, Tara. I thought you were I thought we were still talking about human medicine.
I made comments about both, and you just responded to my comment about human records. I'm just pointing out that there's no requirement for a written request to get access to them. and
Okay, my
frequently-
apologies then. Yeah, I
Okay.
thought you were continuing on in the human medical realm.
Christy?
I just, and I wanted, this goes Dr. Nolan and Dr. Grant, because just for my own education and for the summary for large animal and equine, why, and I'm trying to understand why that is difficult to provide a summary of care after seeing a patient if it's a critical pet. I mean, to me, it's the same for small animal. I mean, you have critical patients. If it's a critical patient, you're continuing to see other patients. And so, but it's still important for this patient to get the same amount of information on to the next doctor. So I'm trying to understand why is large animal, why is it less important for the next doctor to get information than a small animal? That's what I'm trying to understand, if that makes sense.
You want to go first? Or you want me to?
You go ahead.
I think that Dr. Miller was very accurate and much more eloquent than I've been with his concerns. And it is absolutely common to go from one colic course to the next and load them on a trailer and move on and keep going. And you're out in the field, Christy. So there is not we don't stop and try to find our computer. Half the time we don't have wireless. I mean, that's just not the real world in a general large animal practice. And so, but we also that's why I brought up the phone calls, because that's how we communicate most of the time in large animal medicine. I call the referral clinic and I talk to the receptionist as soon as I can. Sometimes you put the horse on the trailer before you call the clinic because it's 2 hours away. So get them down, try to get them down to the surgery room. I think he did a very good job. He's very eloquent. Thank you very much, Dr. Miller. I'd like to just reiterate what he said. This is, I think, meant to protect the consumer and the patient, but the animal. But I think the untoward result is going to be more harm than we are thinking about. And I think that's what I'm concerned about. And I think it's an absolute problem in equine or large animal medicine. We already have a hard time getting students to go out there anyway, and the burnout is atrocious. It's atrocious because it's really hard work. And then you add one more thing, we're going to break this rule now. So go for it. Keep treating animals, but you're going to break another rule. And I got to say something. Thank you, Judy, for calling in. But this regulation wouldn't have helped her get her records any sooner. She got them within, I think, an hour or two. So, I don't think this is going to affect.
Thank you for that. I'm trying to visualize. And
Well,
that's
Dr.
what
Grant may have another approach.
Yeah,
but he's
no, and I'm
also a
trying to
referral surgeon,
visualize,
so
right?
he's
So
going to tell you from the other
appreciate your
side.
input, 'cause that's what I'm
Dr.
trying to
Grant,
visualize.
Dr. Grant?
Yeah, from a standpoint of last portion of my practice life has been on a referral basis. And I certainly concur with Dr. Miller and Dr. Nolan that in the majority of cases for an acute, peracute emergency, that the vast majority of veterinarians who referred to me got on the phone, even though I may be busy or whatever. We always had a 24-hour thing. And the phone announcement said, you can get a hold of it. The intern would call back. They would get the specific information they need from the veterinarian, because there's a pretty standard thing. How long has it gone on? What have you given? How much sedation? And that was all transmitted verbally. And I don't think there was a big problem other than them trying to be in Marietta and rush over to Temecula or whatnot and try to type something on the way or whatever. It's just not a very practical thing to go. And I don't think patients were harmed by the phone calls. I don't think it had to be a written record. Now, on cases that were non-emergent, like a chronic diarrhea, those cases, the information would be sent, what the white cell counts were, what antibiotics it had been on, past history, that had surgery 5 days later. The veterinarian who referred it in most often got a hold of us and sent us that information. I don't think that's a major problem with the case.
Thank you. It seems like there's a lot of work that still needs to be potentially done on this. And I'm wondering if it would be best to send it back to the MDC and have a meeting with the equine subcommittee to work through some of this further. I don't know how the rest of the board feels about that. Yeah, Jessica.
Yeah, I just wanted to address one of the comments made regarding the board's authority over financial matters. I appreciate public bringing it up. I did a search on our website for financial matters. I couldn't find it. If that is the case, it'll have to be updated because that's not correct. We don't get involved in fee disputes. We don't set fees. We have no desire to set fees, but in situations where for example, has been said, if they were charged for services that didn't happen or abundant unnecessary treatments that they had paid for, the board has had authority to do restitution. It's also in a disciplinary guidelines to make the client whole. As far as that financial information getting out to other parties, again, the requirement would be to provide it to the client upon request. And so they have that information, which client is also defined now, and also to the board. That's it. There's no requirement to give to others.
Thank you for that. But I would also remind you that you're giving a medical record to a client who's taking it to the next veterinarian. So they're going to have to be savvy enough to redact their information if they don't want it out there. And I'm not sure that that's in their best interest all the time either. I think I understand what you're saying, but I also think that it's inappropriate to have that associated with this piece of regulation.
Okay. Tara.
I know there are concerns about the financial records. I think it might be possible to limit the amount of records that could be required under the records regulation. Right now, the proposed language reads any invoice and client payment related to services and treatment provided. Today, as a veterinary services consumer, I can get a receipt of my payment and it details what I'm paying for. I could walk that anywhere I wanted to. But I have access to that today. So perhaps since, the goal is for sending the receipt to the insurer to make, get reimbursed or potentially award restitution to the consumer. Perhaps we could limit that financial record requirement to just a detailed receipt of client payment related to services and treatment provided. That way, it's less onerous. It's information the client already is entitled to anyway as a paying customer. And that potentially could provide, a middle ground or for the records that we're trying to get for consumers. But also, I'm unclear what the request is to the MDC because a lot of ideas have been brought up during this meeting and, the MDC is going to need to know where to focus their efforts because this is a pretty large body of work here. So are you asking the MDC to find exemptions for equine practice, limit the legislative proposal to certain records, revamp the whole thing? I mean,
No, I
what's the
understand.
request?
I understand. Dr. Solicito.
I just wanted to clarify, Tara, about the receipt. Every time a client pays, a receipt is being issued. So if they're requesting for records, why would we need to include like the invoices? I'm thinking more of if it's for the purpose of reimbursement and they lost their receipt or whatever, it should be by request. Like, again, like a separate request, but not included with like the summary or something. I just feel like, we also have to put the responsibility on clients to keep track of their own, paperwork, because every time that they make payment, we issue them a receipt.
Okay, I think, to me, looking at the conversation today, I would say that, well, I actually have one question. Can somebody, Jessica, maybe, or Dr. Sullivan, explain why we have chosen to try and move this from regulations to statute?
So it was my understanding that, and correct me if I'm wrong, that in the things that are in the statutory proposal are because we need to have statutory authority to require it. And that's why it's put into the statute. The the addition from the initial proposal from the regulation was not changing current law as far, was changing current law, it's not in current law. And the opinion was that we don't have the statutory authority to put that in regulation, which is why it has to move from the proposal that the MDC approved to the statute, because we didn't have the authority to do that in regs.
Yeah, so to clarify, it started out with the statutes don't require a copy of records to be provided, just a summary. So to expand the requirement, we couldn't do that through regulation. We had to do that through the statute. Through discussions on the regulation, it was my recommendation, because there's now going to be special circumstances when the copy or summary is required to be provided immediately, in a shorter period than 5 days. That potentially could be seen by OAL as going beyond the board's authority. And so we would want to add that to the statute. So we don't experience, a hiccup later with OAL saying, oh, wait, no, that's beyond your statutory authority. So, but also, unfortunately, it's a heck of a lot faster and easier to get legislation through right now than it is regulation. So if you want consumers to be able to get their records, either a summary or a copy soon, not 5 years from now when the regulation goes through, it is advisable to pursue a legislative proposal.
Dr. Grant?
Yeah, I'd just like to add that in my experience, the biggest problem are the non-referrals, that when the patient just comes and the other veterinarian, for whatever reason, doesn't want to refer the case, that's when it becomes a problem. And sometimes the major reason they don't want to refer it is they're not getting paid in the first place. And, whether or not it's under our purview to try to demand all veterinarians who treat a case have to, whether they like the client or a situation or not, have to provide a record, depending on if it's an emergency or non-emergency, needs to be discussed. And a lot of that, like I say, has to do with the financing. People are bad paid. That's why you just end up on your doorstep.
So when I was thinking about sending it back to you, it's mainly regarding the concerns of the equine practitioners in the room. And so I was thinking that would be a rewording some of this, or at least working on it to see if we can make this doable for someone in the field going from colic to colic surgery. I was looking at on page 6, H4, where it talks about see the animal patient in person upon the request of the client and keep, maintain, and make available a copy or summary. If you were to call a veterinarian and provide a verbal summary, I mean, does that not meet that requirement there, or would the words and provide, instead of make available, provide a copy or summary. If you're providing a summary verbally on the phone to another veterinarian, would that satisfy that? Karen.
This is the requirements. Well, we're back to, you can share information, medical information with other veterinarians. So this wouldn't even come into play because it references 4855, which is all about providing records to the client. So I just want to split this up to where it's, clear that these are client records, not communications between vets. I understand that those records and summaries are then walked over to the new vet, but this is a separate requirement. I know, I'm not sure what the rest of your question was.
No, that was it.
But-
But I was just trying to, because if you still provided a summary to the other veterinarian, it was taking care of that need.
Where are you specifically
I was on page 6.
of the memorandum?
Yeah, of attachment 1, under H4. So I think it seems like we would be going around this a bit. That to me, that's the biggest, the two things that need to be, I think, hashed out a little bit more, or at least heard a little bit more clearly, are the this requirement is the concern. And I know that it's currently in law. I understand that it's currently in law, but the idea of this is to make it, I mean, that the whole part of the idea of this whole packet was to improve not improve the lives, but to make it more manageable so that equine practitioners were able to comply with the law and provide good service to their patients and the clients. And it seems like, as this packet is being brought to us, the people who are most concerned with it are the people this packet was, we're not entirely, but a lot of the work that was done on it that was the intent, was to improve things. So that would be the focus of the conversation with the MDC. Does anybody else have any comments about that? Dr. Nolan?
Well, I think I've been pretty clear with my concerns, and I do think that if nothing else, you should give that segment of the veterinary population a chance to chew on it a while. I don't, I feel like it's very, very critical to make sure that it is indeed accomplishing what we think it's supposed to accomplish. And at this stage, I don't think it is, personally.
Okay. Is that clear enough direction? Kara?
So the direction is to
With stakeholders?
right, equine
Fine.
practitioners,
Yes.
stakeholders.
Should I ask you to make that large animal?
Yes, large animal. Does that make sense, Dr. Sullivan?
Yes, but I would like further direction on the rest of the document that we're looking at as to areas of concern. I've got the financial.
Yep.
I think verbal referral, I think we can get that in there.
Yep.
But specifics of other sections that you feel are not easy for large animal and equine practitioners to fulfill. So if you can give that to us,
But
we'll.
I think
do the
that's
work.
why we want to talk to the stakeholders, because they probably have a better idea than 2 of us or 3 of us do as to where the problems will arise. So I like the idea that Dr. Bradbury mentioned, to bring it up to having maybe even a stakeholder meeting, or have some informal meetings that we'll
They
talk.
have been included.
Well, it
So
sounds.
I just want to tell you, this was not a small.
But I think
animal
Dr.
effort.
Miller made it pretty clear that he was a part of that, and yet some things kind of surprised him as well.
Yes, yes.
Yeah, it was the invoice part, so it wasn't the final part. But as members of the board, you were not part of that. And so I think that, I think one more round.
It is going to come back to you. So if you see other things there that are of concern, make sure we have it. Okay?
Ms. Pulaski.
When we had the discussion on integrative medicine, it was brought up that it was nice to see how things were changing in the world. And we could offer all of these new things to pets, and we had to accept it. And I think that when we go back to look at these new rules that we're about to make, we accept that things are changing in the world. And sometimes the way we do things has to change too, to accommodate the laws. And that may mean that when we look at the laws, not everybody's going to be happy, because compromise means that you both have to give. And I think that that's what's going to happen when we look at this at the end. And because it's not going to be perfect, but somebody has to give a little. So there may be things that in the large animal world you have to change. Maybe you have to come up with a template that you can drop in really fast. And maybe there are things that we have to change a little bit so that it can accommodate. But there are ways that things can be done to make this happen. And I think that when everybody goes to the table and compromise happens, nobody's really happy because they had to give in a little bit.
Okay, we're going to have one more comment and then we're going to wrap this up.
I don't
Dr.
see
Thorpe.
any of these problems being obstacles.
Great.
We just have to work on the verbiage.
Word, yeah, great. Thank you very much. And sorry to wrap that up, but we have people waiting as well, and we've moved it back to the MDCs. So I think we're in good shape there. So do you want to move on to the next?
Sure. Actually, this is good for the candidates for the MDC. They know what they're getting in for then. Okay, this is 7E, and I think this should go pretty quickly.
I think
Oh, I'm sorry.
we need to have public comment, one last public comment
And you need to send it back.
for to finish that agenda item.
Bonnie Lutz, I'll be quick. Okay, just a couple of things. I know you're concerned about the cost to the consumer, and I just want to emphasize that this financial information that you're asking to be put on all the medical records that cost is going to be deferred to the consumer. I mean, there's no way that vets can keep those kind of records to be able to send them on a real-time basis as far as all the client payment information and all the invoices. So I do suggest that you look at that wording. The other thing I wanted to make clear is that from our perspective, if there is an issue about restitution, we're happy to provide the invoices. So, I mean, it's not that the invoices can't be provided. And I do think that it's going to increase your subject matter expert costs based on what Dr. Godkin said, because if that information is added with every single record, it's not going to really be clear to her, you know, what she has to review and what she doesn't, because this is what I do for my life. And when I get records that have all the financial information, I really want to shoot myself, because to try to wade through it sometimes is really difficult. So I'm glad that you're looking at this again, and thank you very much.
Thank you. Any other public comment in the room? Oh, I thought I saw a movement there, but moderator, can you open it up to the public online, please?
We are open for public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds to see if we have a request for public comment. If you're a mobile device user and you're having trouble finding that hand button, you may need to hit the ellipses button, that's the ... and cycle through one of 3 pages in order to find your hand button. And do remember, if you're having trouble with that, we also have the Q&A box in the lower right-hand corner where you can type the word comment and send that to all participants. Looking around, I see no request for public comment.
Thank you. Okay, now we are on agenda item 7E.
You don't need to make a motion to bring it back to the MDC. Okay. All right, 7E, recommendation to amend BPC sections 4826.7, 4857, and 4886 to change instances of the word oral to verbal regarding client communication, authorization, and examination. During the January MDC meeting, a discussion came up about the terms verbal versus oral. It was decided that since oral refers to administration of treatment in veterinary medicine, it would be better to use the word, even though it's predominant in the law, it still would be better to change that to do a global change to verbal. Since the January 2024 board meeting was canceled and legislative deadlines were looming before the board would meet in April, the board's executive committee submitted the following legislative proposal to the California State Senate Committee on BPNECED for consider in the omnibus bill, and that you have before you.
Okay, any questions? I know we've all read through it. I don't have any questions. So what we're looking for is a motion. And would anybody like to make a motion to ratify the MDC recommendation to the California State Legislature to amend BPC sections 4826? Okay, well,
I will make a motion, so I'm waiting for somebody else, but I will make a motion to ratify the BPC sections 4826.7, 4857, and 4886.
I'll second that. Any public comment? Okay, moderator, would you open it up to public comment online, please?
We have a motion and a second on the floor. If you'd like to make a comment on the motion, please raise your hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, thank you.
Dr. Solocito,
Yes.
Dr. Grant,
Yes.
Dr. Nolan,
Yes.
Ms. Pulowski,
Yes.
Ms. Prado,
Yes.
Dr. Bradbury.
Yes.
Motion carries.
Fantastic. Okay, item F.
At the board meeting in January 2023, the board voted on a number of issues. This is related to veterinary drug compounding. The issues that they voted on was, one, to allow vet assistant controlled drug permit holders to perform certain drug compounding procedures under direct supervision of a licensed veterinarian. Two, they added the definition of immediate use. Three, clarified the location where office stock may be used. Four, established the supervising veterinarian's duties over the RVT and VA CSP holder when compounding drugs. Clarify the requirements to maintain a master drug formula for each compounded drug preparation, the documentation required for animal patient-specific compounding drug preparations, and documentations required for immediate use compounded drug preparations. And lastly, change the term animal hospital to registered veterinary premises. As noted in the legislative proposal, was necessary to amend Business and Professions Code, Section 4826.5, to allow VACSP holders to compound. If the legislation was not successful, that the regulatory language would have to be removed in regards to the VACSP holders' ability to compound drugs. During the October 2023 meeting, the Regulatory Council raised other concerns so that the regulatory proposal was sent back to the subcommittee to address those issues and then return to the MDC for with recommendations. I think that you could start on page 2 of the memorandum and look at the different sections that the subcommittee recommended and the MDC approved. And we'll kind of abbreviate this. Section 2090F, definition of office stock. Our Regulatory Council raised some concern about the word use and a couple of other things and made a recommendation that you have in the memorandum. The subcommittee decided to be more concise and address the concerns with use and maintain consistency with the statutory use of the term authorized agent of the client. The subcommittee recommended the following revisions. And that's under F. Office stock means compounded drug preparations without a patient-specific prescription that may be administered to an animal patient within the registered veterinary premises where the drug preparation was compounded, or administered in a mobile units and vehicles operating from a registered veterinary premises in accordance with Section 4853 of the code, or dispensed only to a client or client's authorized agent or other veterinarian in the same veterinary premises. Section 2092AF was written policies and procedures of manual record keeping requirements. The Regulation Council raised some concerns that Section 2092A1 was not updated to reflect the revisions in the new documentation record keeping requirements. And the subcommittee accepted the proposed revision, the recommendations from the Regulation Council, which the only real change there was the list of each of the requirements of subsection included B, D, E, and F, and subsections 2093 and 2094. Should I keep going?
Is everybody okay with that? All right, yes, please.
Okay. Then related to section 2092 D and E, regarding revisions to animal patient medical record requirements and newly proposed text for intravenous compounded drug preparation, the Regulatory Council raised some concerns with the language. Let me see which one this is. Okay, so the subcommittee did not agree totally with the changes, so I'll just go down to that part. The subcommittee is concerned that the additions make the section less concise and harder to understand. In addition, the subcommittee notes that the board has discussed this language at length with multiple licensees and stakeholders, and none raised a clarity concern with the word notwithstanding. As such, the subcommittee recommends maintaining the language from the previously approved proposal. However, during the October 2023 board discussion, it was noted that subsection D was not updated to reflect previously renumbered sections, and a recommendation was made to update the reference of paragraph 2 through 7 to change to paragraph 1 through 6. In addition, the subcommittee noted the proposed addition of subsection E does not account for sub-Q fluids, compounded drug preparations. The subcommittee also believes including that it is not otherwise compounded at the veterinary premises is unnecessary since IV fluids and Sub-Q compounded drug preparations for immediate use will always be compounded at the veterinary premises. So that language is there and with some modifications, so that's straightforward. Subsection 2094A regarding office stock labeling. We did not have that done properly in the regs, so the office stock needed to have be labeled so with the name assigned to the compounded drug preparation. And I think the rest of that was okay. Let's see.
Yeah, we just removed pursuant to paragraph 7 of subsection B. So that was a big conversation, so.
Yeah. So the subcommittee recommends accepting this proposed revision and has left the language word essentially by saying name assigned to the compounding drug preparation pursuant to the name assigned to the, yeah, that's repetitive. Okay, and then additional subcommittee recommendations and MDC approval. Based on further discussion during the October 23rd meeting and review, the subcommittee makes the following recommendations. And that is in section 2093C to clarify expiration of IV and sub-Q fluids. And basically that means that if they're not used within immediate use, they have to be, they will expire, have an expiration date of 24 hours. Amend section 2094 to add IV and sub-Q labeling requirements so that office stock shall be labeled with the following information. Name assigned to the compounded drug preparation, name, strength, and quantity of each active ingredient, expiration date, name of or initials of the preparer, and date of drug preparation. And also all intravenous and subcutaneous compounded preparations needed to have the following information on their label: name, strength, and quantity of ingredients added to the sterile solution, date and time of the initial preparation, name or initials of the preparer, and then the item that was A, we moved down to C. And let's see, and there's no change in D.
Okay, I just have a question.
Yeah.
About the 24-hour expiration.
Yes.
We probably came up with that at the last meeting. I don't know, but I do know that patients are in the hospital for more than 24 hours. I don't know if this is true in equine hospitals, but and I don't know how big of a bag and how quickly you guys go through fluids, but I do know that in small animal medicine, we sometimes will have fentanyl CRIs and the like, and we'll have make a larger bag to help clients with their costs so that it, you know, we usually, I think we have a 72 hours, what we would use. So I'm just wondering where the 24 hours came from and if that was, because if we're throwing it out every 24 hours.
If it's continuous use, you don't have to throw it out. But if you're stopping using it after 24 hours of the date of the time that it was made, it was felt by our staff that that was not abiding by, definitely by state compounding regulations. If you want to change the time and you can justify it as a specialist, I don't have any time. I don't have any problem. We came up with 24 hours because it more reflects human medicine. That's my understanding.
Yeah, I'd have to look at the literature. I don't really know if there, I know there's been studies on subcutaneous fluids and how long they were safe for, but I would have to, I don't know. That was my only question. Dr. Grant?
Yeah, I think that's a good. It was a good point that you made because in after colic surgery, lidocaine drips for pain management often continue for more than 24 hours, but they would be continuous most generally.
you know, this is the board that makes the final decision. If you want to amend that part.
Yeah,
That's up to you.
I guess I don't, I don't see anything about continuous, so I guess I'm not, I don't see what the differentiation is or how that would be viewed if it were looked at by our board, if something came in and there was a drug that was hung for 48 hours.
So the requirement is that if it's a compounded product of fluids and it's under immediate use, you do not, all you have to do is put it in the medical record. Okay, if you use it, let's say you use it some this day and some the next day, now you've got a compounding regulation problem. So you have to treat it as any other compounded product you've made. So the requirement is a little different, but continuous, if you start it within 4 hours of making it, then it's just the medication that you're giving. So I don't know if that fits the question you raised to begin with.
How does everybody feel about 24 hours?
Well, I appreciate that explanation, I think, but one of the issues that I have with that is that's not easy to figure out based on this wording. You are an expert at this compounding stuff right now, Dr. Sullivan, and so I kind of am a little bit with Dr. Bradbury that I think there might be circumstances where we have made a fluid to use, and I'm thinking subcutaneous at this point, that you may stop and start it. I don't know. I'd have to do a little more research, but I do worry a little bit about the 24 hours as well.
Okay, none of that applies if you don't add something to it. We're talking about IV fluids that now you have opened the port by adding another medication.
Right,
to it.
like B vitamins, let's say.
Yeah. So that would be a compounded fluid preparation. What you do with the fluids that aren't compounded does not fall under this regulation. So, and that's why the 24 hours, once you make that puncture, we felt 24 hours was reasonable, but if you think 48 is or 72, you're the experts.
I just think I would be looking at this thinking that my IV fluids that were compounded, I wouldn't know that they were something different than this, because it says for the preparation, I see, that does not, it's clearer now that I'm rereading it, sorry. Okay, I'm okay with it the way it's worded. Anybody else with questions on this?
I would just caution, this is the time to change it if you want it changed, because you're not going to be able to do it easily afterwards.
It's just difficult for me to make an informed change because I haven't looked at the literature to see when something like this should expire, which would be safe. So that's hard for me to make that just on the fly here at this meeting, if that makes sense, the way I work.
And there's also a difference, if I want to throw another curve in there, is what you're adding if it's a one-use vial or bottle as to a multiple-use injectable product. That makes a big difference too, which we haven't accounted for here.
Why don't you keep going through this and?
Oh, I thought I was finished.
Oh, you are, sorry. Yes, you are finished. Okay.
Can I make one more? This maybe is a very picky point, but it seems like, let me see if I can find it. We actually, on section 2094, to add to the IV and sub-Q labeling requirements, page 4, top of page 5, we talk about the expiration date. But are we still also referring to the 24 hours, in which case maybe date and time would be more valuable on that?
Dr. Solicito.
I guess I just needed clarification, because with the thought, like, if you add something, you're technically compounding it, right? So if it will expire 24 hours, what about convenia?
That's not adding something that you're.
The sterile diluent.
No, it's part of making the,
Did that,
no,
That's following manufacturer's directions.
thank you.
Okay.
I'm like,
all right. Yeah,
yeah, no,
because I
that-
just wanted to
that's-
make sure that
that's
that's,
specified there. But if you have, I know that some people put like B vitamins and sub-Q fluids and have them for their cats. And I don't know what you do at the shelters.
but
for-
we're not doing, we're not just talking about sub-Q fluids here, or are we?
IV or IV fluids or sub-Q fluids, yes.
Yes, okay.
For the
so
24
if
hours.
It's not, we're not talking about any other medication that you may, okay. Thank you.
Dr. Nolan, I didn't, where are you at?
Well, I think it's covered because it's, the first expiration date is under the name assigned to the compounded drug preparation. But then it goes down to B, subsection B on page 5, and it says all IV and sub-Q compounded drugs. It says date and time of the initial preparation. So it doesn't really indicate an expiration, but if you can extrapolate it by knowing when the date and time of the initial preparation was. I'm at the page 5,
Yeah.
does that make sense? So there is no expiration date for the IV and subcutaneous foods. I think it's just assumed that if you know when you made them, then it's however many hours later. So I kind of followed it. It was a little confusing, but I think
So-
I got it.
So the product that you have has an expiration date. And then the date of the preparation is now the triggering time. Now, maybe we should have put time on there also.
I'm wondering, it might be clearer if you have expiration date and time, unless we change the 24 hours, which, I don't know.
So we're talking about IV fluids. And now you're going to mess up my mind. But I think the expiration date is of the, well, let me back up.
May I intervene? So we've got expiration dates and we've got labeling requirements, and the labeling requirements specify that these IV, IM, and SQ compounded drug preparations have to be labeled with the date and time of the initial preparation. So that provides the information that starts that 24-hour clock running in terms of the expiration. Does that help?
Yeah, I think you kind of extrapolate it back. So that makes sense, but it's just a little confusing, unfortunately, because but Dr. Bradbury, is there a way that we can go on a break at some point and look up some of that information and then try to address the 24 hours?
Yes, I think we could take a break probably now, and that way we take a 15-minute break and then come back because we're about break time anyway. We'll
Okay.
break until 5 till
Dr. Nolan,
3.
this is for office stock labeling. Right? If you go to the previous page, A is office stock shall be labeled with the following information. So the office stock would have an expiration date based upon either 30 days if it's an IV product. I think it's 60 days if it's not, if it's a non-sterile, or the shortest date of any ingredient. So I think that's why you have an expiration date on your office stock. And then the date.
So I'm sorry, just to make sure, moderator, you're still, I had said we were going on a break, but there's continuing to talk. Are we still recording?
We are still recording. We have not gone on break yet.
Fantastic. Continue. I just, whatever you were saying, I want you guys to finish what you were saying to one another.
I was just saying this label has to do with office stock, not IV fluids. That's why we have an expiration date of
Right.
product or any, which has a formula,
Uh-huh.
including the shortest expiration date of any ingredients. And then we have the date the preparation was made.
Okay. Thank you.
That's why.
So let's go on a 15-minute break. We'll come back at 3. I guess it'll be a 18-minute break. I apologize to all of our MDC interviewees. I appreciate your patience, and we'll see you in a few. 3:00. Are we recording?
We are recording.
Thank you, moderator. Okay, so in that time frame, we've come up with a little bit more information. Number one, where the 24-hour guideline came from. It was in a reference, which you all should have, I think, in front of you. It's from an IOCOOC, which is a lab animal approval document from Oakland University, and it was quoting the CDC, I believe. It's on page 2. And it says fluid bags, 100 mils or larger. This is in the first couple paragraphs on page 2. According to the CDC guidelines, once any IV fluid bag is spiked, an IV drip set inserted into the bag for fluid delivery, or if a needle has been inserted into the injection port for any reason, these fluids are considered stable for only 24 hours. Another note that is interesting, but just that any type of pen inks can leach through the plastic, so don't write directly on the bag. I just thought that was interesting for any veterinarians in the room. Okay, so that's where this came from. I had we had our student who asked some questions during the break and mentioned that they often at UC Davis have fluids for much longer than 24 hours in the barn. And I know that in my practice, we typically would keep fluids for 72 hours before discarding them if they'd been either hung or just added to. I did find on the University of Wisconsin where they had, which is just another veterinary school, the bagged fluids for IV administration may be kept for 72 hours once an IV line is attached. An exception is those that contain dextrose or glucose. And it doesn't say what time. Subcutaneous fluids can be kept for up to 2 weeks. So, and I think Dr. Howard, when he came and briefly talked to us and mentioned, just as I'm concerned, that this is a very big change to veterinary medicine and practice for this 24-hour. I would be okay changing that to 72 hours, but I don't know how the rest of the board feels about that. Christy.
Well, I don't want to be I just want to say this, I don't want to have false information out there. And so I want to say, because you stated the information about the pen and some inks known to leach, I have researched this heavily, and I have found many studies to show that not to be true. So I just want to get that out there because
Okay.
that stresses me out.
Well, then it also calls into question some
I know.
other things.
And so it does, this
Um,
whole, yeah.
Okay. Dr. Sullivan?
Yeah, if you want to go to that direction, you may use verbiage like not to exceed 72 hours.
Yeah, I
because
like that.
I think there's some preparations that you do not want to do more than 24
I
hours.
agree. Dr. Nolan?
Is there a way to put it back onto the judgment, the professional judgment of the veterinarian? I mean, I think that there are some nuances that might make a difference, and it is ultimately their responsibility to give a safe product.
Or the standard of care?
Yeah, something that would not, instead of putting a finite number, put it, at, the fancy words, medically appropriate or something.
The medically appropriate expiration date? Legal, any suggestions?
Oh. Dr. Bradbury,
Yeah.
is it too onerous to think that if you had a adult horse that needed to have so much fluids dripped in a day, lidocaine, versus a foal, that you might use a smaller bag to make a lidocaine drip when you're compounding it? Maybe same as a adult dog versus a puppy or something like that,
Yeah,
in
I mean,
fact-
the reality is we're not even talking about that because that's a continuous infusion. But if you were to stop, the thing that I have a hard time with is this idea that if we put lidocaine in a bag as an example, and we are using it and then we stop it to do a procedure to take them out. Once you stop it, it's not a continuous infusion, and then now it expires within the 24 hours of compounding it. Whereas if we just kept it going, it wouldn't expire, and we would have, it would be okay to use it longer. So it doesn't feel consistent to me, but
But you could piggyback the fluids, right? I mean, you can add another line and you wouldn't necessarily be going into the same bag of compounding fluids.
so you're saying 24 hours should be kept in there based on the information we now have?
Yeah, as far as being a safe thing, but I don't be willing to listen to other people for sure.
Okay. I'm not, I don't feel strongly the other way, except that I am a little concerned about it. Dr. Nolan?
Well, we're also throwing in the subcutaneous preparation, which has, as we know, less risk involved with their administration route. Can you think, Dr. Sullivan, of a way to insert, instead of an hourly number, something that is, shall expire at a medically appropriate time or at a time deemed medically appropriate? Is that a bad idea? Tara's staring at me, so maybe that's.
Well, I think the problem, I think that where this is going to be used, if not already, is in hospital inspections where there's a bottle of fluids hanging up there with no date on them. If it's, I mean, to say at the judgment of the veterinarian, I think is leaving them off the hook when we know there is a time limit when something is safe and when it's questionable, even if it's sub-Q. That's why I would suggest maybe a little more leeway, but something firm. Is 2 weeks too long? Is a month
mean,
too
to
long?
give
I mean,
IV
there's some-
too.
Well, the
there's gotta be
example you
some
used, they didn't put any labeling in it whatsoever, so it's already in trouble. They're already, breaking the law, right? If there's no labeling. But, so I would be in favor, I think, of Dr. Bradbury's, no greater than 72 hours or, giving the veterinarian. And part of it is because we're worried about consumers and the cost of care. And if you're going to read
That
the
is
letter of
my
the law, you're going to, that's going to make a difference.
And I have found several studies that have cultured bags beyond, like, it's after 30 days that they've grown organisms, but there's so many different variables that we can't account for. So I think 72 hours seems like a reasonable time to me. Okay. Is everybody okay with us?
You want me to make a motion?
Yes.
And you want me to combine?
Yeah,
all
so I
together?
think if we're okay with the rest of, Tara,
Okay, I just want to be clear on what the proposed amendment is. I think we're on page, is that attachment 1? Okay, page 17 of attachment 2, section 2093, subsection C, second line, where it reads shall expire 24 hours after. The revision is shall expire within or up to 72 hours. Which is it?
within, I believe.
Okay, shall expire within 72 hours after the preparation is initially compounded.
Okay.
I guess I would just clarify that too, though, because are we then saying that all of them would be 72 hours? I thought what we were arguing is that some are going to expire within 24 hours.
Yeah, what was your wording,
So
Dr.
up
Sullivan?
to sounded more accurate. What
Okay.
you're getting at.
Up to then. Thank you. Okay. Dr. Nolan, do you want to make a motion?
Do you want me to do the whole thing or just that change? Okay. And did we get through all the rest of it, Dr. Sullivan? Yes, okay. So would somebody point me to the page where the blah, blah, blah?
Are you doing the whole thing or you
I'm
just?
looking for the whole thing to do it. so
Okay,
what
can
page?
I'm gonna make one minor, I discussed this over here really quickly before you do. On page 18C, in addition to the label specifications specified, can we change in addition to the label requirement specified above? Minor wording.
I'm okay with that.
Thank you.
I'm looking, sorry, my bad. So I would like to make a motion to rescind the board's prior, is that the right wording? Or, okay, I would like to make a motion to rescind the board's prior January 25th, 2023 motion approving proposed amendments to CCR Title 16, Sections 2036.5, 2090, 2091, 2092, and 2094, and approve the proposed regulatory section text for sections 2036.5, 2090, 2091, 2092, 2093, and 2094 as set forth in attachment 2 and as amended today. Direct staff to submit the text to the Director of the Department of Consumer Affairs and the Business Consumer Services and Housing Agency for review. And if no adverse comments are received, authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any non-substantive changes to the text and the package, and set the matter for a hearing if requested. If after the 45-day public comment period, no adverse comments are received and no public hearing is requested, authorize the executive officer to take all steps necessary to complete the rulemaking and adopt the proposed regulations as described in the text notice for CCR Title 16, Sections 2036.5, 2090, 2091, 2092, 2093, and 2094 as amended today.
I second the motion.
Fantastic. Okay, public comment in the room? There's none. Moderator, would you open it up to public comment online, please?
We are open for public comment via WebEx on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. As a reminder, we also have the comment box in the lower right-hand corner, the Q&A box, if you'd like to type the word comment instead. And for our mobile device users, if you're having trouble finding that hand button, you can tap the ellipses button, that's the ... at the bottom, and cycle through the pages to find your hand button. We're going to take just another second to see if we have a request for public comment. Seeing no request, do you wish to continue with the motion?
Yes, please. Thank you, moderator.
Dr. Solocito?
Yes.
Dr. Grant?
Yes.
Dr. Nolan?
Yes.
Ms. Pulaski?
Yes.
Ms. Prado? Dr. Bradbury?
Yes.
Motion carries.
Thank you, Dr. Sullivan.
Thank you. 7G, a recommendation on the board's guidance and veterinary drug compounding. While addressing the above concerns with the compounding regulations, the subcommittee thought that it would be a good time to improve the board's guidance document. It was brought to our attention by Dr. Howard that the two examples in the guidance document were not good examples, so we replaced them with, the first one was an example of a laparoscopic AIU sedation cocktail, and the second one is a compounding endrofloxacin and dexamethasone otic solutions. And that's it.
Great. Any comments, concerns? Ms. Pulaski?
No, I'm going to have some because there's, just like in the introduction, I think there's some dates like as of July 2021. Do we want to update the date on that? And then we'll need to update on page 4 the definition of office stock.
We can't make those changes to the guidance at this point until the regulations
Okay.
become enacted.
Okay. Would anybody like to make a motion? Okay. I will then make a motion to replace the existing guidance on veterinary drug compounding with attachment 1.
I will second.
Okay, public comment? There's none in the room. Moderator, would you open it up to those online, please?
We are open for public comment once again on a new motion. If you'd like to make a comment, please raise a hand by tapping that hand button. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, thank you.
Dr. Solicido,
Yes.
Dr. Grant,
Yes.
Dr. Nolan,
Yes.
Ms. Pulaski,
Yes.
Ms. Prado,
Yes.
Dr. Bradbury.
Yes.
Motion carries.
Yay. Okay, Dr. Sullivan.
7H, recommendation on frequently asked questions for AB 1399, 2023, and SB 699, 2023. In order to get information out to licensees, consumers, and stakeholders, staff requested that MDC create some FAQs to address these two new laws. These laws went into effect January 1st, 2024. The MDC discussed the FAQs during their January 16, 2024 meeting and made several revisions based on MDC and stakeholder feedback. The MDC is forwarding the FAQs for your review and approval. As I mentioned earlier, the hypotheticals are not being brought to the board at this time.
Thank you. Any questions or comments on the FAQs? Okay. Then can I have a motion? Which is on page,
The bottom of page 1, the top of page 2, we would just ask that you don't include the hypotheticals. So where it says and hypothetical scenarios, and then it says with hypothetical scenarios, whoever is reading that, if you could not read that portion.
I can do this. I can make a motion to publish AB 1399 FAQs on the board's website and disseminate the FAQs to stakeholder. And I will also motion for the for SB 669 FAQs and publish the SB 669 FAQs to the board's website and disseminate the FAQs to stakeholders.
Second emotion.
great. Public comment in the room? Okay, moderator, would you please open it up to the online audience?
We are open up on WebEx for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, thank you.
Dr. Solocito,
Yes.
Dr. Grant,
Yes.
Dr. Nolan,
Yes.
Ms. Pulaski,
Yes.
Ms. Prado,
Yes.
Dr. Bradbury,
Yes.
motion carries. Thank you, Dr. Sullivan.
Thank you so much, Dr. Sullivan.
Can
Okay.
I also publicly thank Dr. Sullivan and also Ms. Pulowski and Dr. Waterhouse for working hard on those. Those are not easy to do. So thank you all for your hard work.
And Miss Usury. Thank you.
Thank you, and Ms.
Ussery, sorry.
Ussery.
That's long day. Okay, we are here. We finally, we've made it to agenda item 8, interviews, discussions, and possible appointments to the MDC for the RVT member. Dr. Solocito and I, we were very lucky. We received a large number of applications, and Dr. Solocito and I had to somehow pick from a very talented pool, very well qualified. And if any other applicants are out there, both for the veterinarian and the RVT position that did not get chosen, I wanted to thank you and just tell you that that we're very grateful for your application, and it was a tough choice. I just thought I would mention some of the things that we're evaluating, and when we're trying to choose the candidates. We first and foremost are looking at their experience, and also the resume or CV that's provided, and their letters of recommendation. We're looking at experience both in the field and like in the profession, but also any experience in regulatory medicine or governmental bodies, just to that might distinguish them. And then we also had to evaluate the current composition of the MDC relative to the practices, the types of practice and the number of veterinarians in each type of practice in the state. And so we used all of that information to try and pick the best candidates for the position as the MDC is today. So hopefully that helps everyone understand maybe why or why not certain people were chosen or not chosen. So with that, I think we'll start with Ms. Kiki, since we'll just go down the line here. And I think you all should have your questions available. And I think we'll, hi, thank you for coming.
Thank you so much.
Yeah.
Thank you for inviting me once again. I appreciate that and giving me the opportunity to see you all in person since last time I was virtual. So thank you so much for that.
You've had a long day seeing what you might be up might be up to. Okay, I think we'll start with you. We'll go around this way. So Dr. Solocito.
All right, let's get the ball rolling.
Yeah.
Okay, so me?
Yep.
Okay, so hi, Darlene.
Hello.
Okay, so to the best of your knowledge, what are the functions of this licensing board and its committees?
Yes, thank you for that question. So having been able to watch these meetings virtually and even this in person, my recollection of what this is about is really that the board is committed into protecting our consumers and their animals. And in doing so, they work collaboratively with their committees to be able to enact laws and protocols and guidance, as well as to oversee all of the facets of licensure.
Ms. Prado?
Why are you applying to be a member of the MDC of the Veterinary Medical Board, and what do you hope to achieve as a member of the MDC?
Yeah, good question. I have, if you've all seen my CV, I've been almost 3 decades in this industry and have had a very unique background. I have owned 2 veterinary practices, including have founded a nonprofit, and uniquely, I've also worked with multi-species. So large animal, small animal, zoo medicine, and hoof stock within zoo medicine, as well as exotics. So I feel that that unique, diverse background can give a good perspective and maybe a fresh perspective, as well as from a consumer, as I own equids and have done lots of different exotics as well as small animals. So I'm applying because in this next portion of my career, as most of you know from the last interview, that I sold my veterinary practice. And I am dedicated to really giving back to the community that has given so much to me. I want to be able to protect our consumers and their animals, as well as forge a path for our new generations, including the current generations, that is safe and effective for their patients. I'm sorry, I gotta look everywhere here.
Yeah. Good afternoon. Thank you for coming and being patient. Do you have any specific advocacy for a cause, a group, or a movement? And if so, how do you promote this advocacy?
Yeah, that's a big one in today's time. We've gone through a lot, and I think the veterinary field is in a shift where not only do veterinarians want to practice a little differently, but I think also technicians. And I would say my biggest advocacy is for technicians and for their path, and ensuring that that is a safe path for everyone involved. We've seen VCPR come through. We have a lot of other bills that are also coming through, and some that are great for the field and some not so much. So I definitely feel that I can bring a little bit to the table of that. I feel that I am out there and definitely advocating for technicians, as I'm the leader of technician training and development for a very large consolidator. I also work very closely with our National Technician Association and have sat on the board as the secretary for the California RVT Association. So I'm very heavily involved with all of our associations, including the SCVMA and CVMA.
Thank you.
Yeah, thank you for your patience and for coming today. Appreciate it. The MDC meets quarterly for a half to a full day, and members are typically assigned to several subcommittees, each of which may take an additional 2 to 6 or more hours per month. Given this information, are you able to make this time commitment to fulfill the needs of the MDC?
Yeah, I've released a very large load of practice ownership. So I certainly can devote some of that time to this unique opportunity, if so you would choose me.
Okay. The mandate of the board and the MDC is to protect consumers and their pets, and our recommendations and actions are sometimes unpopular with the general profession. How do you feel about making decisions based on the needs of consumers and their pets, despite possible disapproval from colleagues?
That's a great question. So I think as a leader, we often have to make decisions that are greater for the good and the whole versus maybe the smaller portion that does not agree. I will say that I have, through my career, because it's been so unique and I have been a sole owner of a practice, adversity is definitely not something I'm not used to. But I will say that I have turned many people that were questioning or concerned into very close friends because of collaboration and communication and education. And I think that that is effectively how we can certainly change adversity. So
we assume you are aware of the current issues affecting veterinary medicine today. Which issues have affected you directly, and what issues would you like to see the MDC address?
yeah, I would I would say that directly, some of the new paths that technicians we're forging right now, right? So I have been the VCPR for sure, telemedicine, and there's bills now for surgery for technicians. Again, there are some things that I push back on and some things that are in for. So I definitely would like to be part of that initiative and part of having a voice and a seat at the table as to what I would feel would be better for the consumers, as well as the protection of our veterinarians and our technicians.
Okay, without getting into specifics, do you have any personal, legal, or professional issues that may potentially prevent you from serving a full term on the MDC?
No, not at this.
What qualities or traits do you think an MDC member should possess to be effective in serving the committee?
Yes, that's a great question. I think a level of commitment to the industry, I think, is very important, as well as a passion for the future. We have a lot of changes, like I've stated. It's great to think in the now, but for sustainability, we always have to think of the future. So I think somebody who's able to just have an open mind and collaborate, and also be able to listen and learn from the committee members that they work with.
I think we're done, aren't we?
Number 9.
There we go. Sorry. Can you think of any position that you hold or activities you're currently involved in that may present a conflict for you to serve as a member of the MDC and a representative of the Veterinary Medical Board?
No, I do sit on some boards, like I said before, the zoo and some other nonprofits. And I do work with NAFTA, but I do not feel that any of that is a conflict.
Thank you.
You're welcome.
So we'll wrapping it up with this last question. Is there anything else you would like to share with the board?
Just that I appreciate your time. I appreciate you guys inviting me again, and I hope for the opportunity to be able to serve this board.
Thank you so much.
Thank you.
Okay. So the next candidate is Tracy Mumby, and I am thinking she's online. Moderator, can you see if Miss Mumby is?
Checking right now.
Thank you.
All right, Tracy, you should be able to unmute it well.
Hi there. Okay, let me start up my video.
Thank you. Good afternoon.
Is that okay? Hi, good afternoon. How are you?
Good. Thank you for coming and
Yes,
for
absolutely.
being here. Great. So you just saw kind of the process here. So I think Ms. Pulowski, you're up.
Hello, welcome. So to the best of your knowledge, what are the functions of this licensing board and its committees?
Oh, you bet. That's a great question. I kind of see the Veterinary Medical Board as having their hands full with a multitude of lots of important tasks. So, of course, the primary function being to serve as, regulatory body that oversees and ensures the quality and ethical practice of veterinary medicine. But beyond that, there's the actual licensing. So being responsible for issuing licenses to veterinarians and registered veterinary technicians, all after they've ensured that educational and exam requirements are met. There's the oversight of the VACSP, enforcement of, varying standards and what have you, complaint investigations. I know, as far as like rulemaking goes, work with legislature to establish rules and regulations that govern our profession, and also in times of public health emergencies or outbreaks, responding to emergencies.
So why are you applying to be a member of the Multidisciplinary Advisory Committee of our board? And what do you hope to achieve as a member of the MDC?
Well, first of all, I really want to say thank you for the opportunity to interview today. This is the second time I've been invited back. I also interviewed in October of 2023 and kind of gave a broad overview of my experience, but didn't do a real good job of going in depth. So is that something that you also want me to answer with this question, is kind of what my experience has been and what brings me to the MDC?
Yeah, I mean, I think this is a good place to do that.
Okay, thank you. So I've been active in veterinary medicine for over 30 years, and over that time have filled many different roles. I've been a licensed RVT in good standing since 1992, and over the years have had the opportunity to work in a variety of different practices. So I've been through general practice, multiple specialties, emergency critical care, and also have spent 10 years in zoo medicine. My experience has also led me through not only the private sector, but also nonprofit and corporate as well. And then on top of that, I hold certifications as a veterinary practice manager and a human resource professional. And I currently serve as an educator for our local AVMA accredited veterinary technology program. So, to me, the combination of all of my experiences has really provided me with a comprehensive perspective of the profession and what I think is a pretty well-rounded overview of veterinary standards. But it's also taught me the importance of the MDC's role in consumer protection. So part of why I'm doing this is, as long as I can remember, I've kind of felt the need to give back to the profession and have tried my best to contribute over the years. I have participated on several conference panels discussing the evolving role of the RVT. I've been a past subject matter expert for the California RVT exam back when that was a thing. And I'm a current subject matter expert for the VTNE through AAVSB. Then 2016 to 2020, I had the privilege of being appointed as the international member on the South African Veterinary Council, which kind of gave me the opportunity to reach out on a more global scale, and worked on a team that was tasked with inspecting veterinary and para-veterinary colleges in South Africa to perform curriculum review, but also ensure that compliance with the region's regulatory standards had been met. So coming back around to the original question is, why am I doing this? I feel like I've been blessed with a very long and successful career myself. So now it's time for me to direct some of my energy toward, contributing to the veterinary profession in a different capacity. And I just really feel like the MDC offers a really dynamic space where I can leverage my experience and help to shape the decisions that align not only with the commitment to consumer protection, but also maintaining minimal standards. So my hope is that with the experience that I bring, I'm bringing a well-rounded perspective to the MDC, and really helping kind of us all as a profession to grow and thrive and change.
Right. Good afternoon, Tracy.
Hi.
For the next question, do you have any specific advocacy for a cause, a group, or a movement? How do you promote this advocacy?
Yeah, thank you for the question. Well, I do maintain memberships with CVMA and SDCVMA, and I say that because I feel like I do get a lot of really great information through the organizations. But just like Darlene, I am a very strong advocate for the RVT. I see our profession struggling with meeting the demand for appointments and what have you. And I, also coming from the perspective of being an instructor in the RVT program, I see the talent that comes through these classes, and I know what these students are capable of. Not to mention the RVTs that have been in the field for many years. I see them as a huge asset that maybe we aren't necessarily tapping to the full potential. So I would say that that's really where my advocacy lies. And as far as what do I do about that advocacy, as I mentioned, I have spoken on several conference panels about that changing and evolving role of the RVT.
Thank you. The MDC meets quarterly for a half to full day, and members are typically assigned to several subcommittees, each of which may be taken an additional 2 to 6 hours per month. Given this information, are you able to make this time commitment to fulfill the needs of the MDC?
Absolutely. I am fully committed to fulfilling those responsibilities. I personally value the importance of regular attendance and active participation in committee activities. And I recognize that the MDC is only as strong as the members that they have that are there and ready to collaborate. So my commitment would extend not only to attending meetings, but to actively participating in the subgroups.
Thank you for being patient. The mandate of the board and the MDC is to protect consumers and their pets. And our recommendations and actions are sometimes unpopular with the general profession. How do you feel about making decisions based on the needs of consumers and their pets, despite possible disapproval from colleagues?
Right. I think this is something we all have to think about. But as I mentioned previously, I have been a practice manager for many years. And I think any of us who have been in a management role know that we can't make everybody happy and that not all decisions are popular ones. So I will say that I've developed a little bit of a thick skin over the years. And while I do have full awareness that external stakeholders may not always align with the decisions, I'm committed to making choices that logically and effectively will safeguard the interest of the consumer and uphold our minimum standards.
Thank you.
Thank you for your patience.
Yes.
We assume you are aware of the current issues affecting veterinary medicine today. Which issues have affected you directly? And what issues would you like to see the MDC address?
Well, I will say probably the ones that have affected me personally the most is the challenges that we face related to availability and affordability of veterinary care. So I know in my own day-to-day, I see countless instances where pet owners are really unable to access necessary veterinary services, either due to a lack of appointment availability or realizing that their only options are expensive urgent care or emergency facilities. That being said and set aside, I think the issues that I would like to see addressed more are, as I mentioned, the evolving role of the RVT, feeling like maybe their roles could be strengthened and have that be not only a benefit to the profession, but also contribute to the improvement of animal care. But additionally, one of the things that I did not mention in my experience, I've also worked as a relief or per diem tech on and off for many years. And I see out there in practices that there always seems to be an ongoing challenge surrounding medical record keeping. So I would love for this to be I kind of heard a little bit of it today too, where a little more effort is put into creating some resources for all veterinary staff to help with maybe training or retraining programs in the medical record keeping area.
Thank you. Without getting into specifics, do you have any personal, legal, or professional issues that may potentially prevent you from serving a full term on the MDC?
No, I do not.
Okay. What qualities or traits do you think an MDC member should possess to be effective in serving on the committee?
Oh, great question. I would say probably first and foremost is some ethical integrity. There are some big decisions that need to be made at that level and within that committee. So bringing the integrity with you and then being able to have conversations and make decisions with impartiality, I think will go a long way. Of course, the desire to work as a team and collaborate with others, and then a true desire to protect the consumer and see our profession thrive.
Okay, our next question is, can you think of any position that you hold or activities you are currently involved in that may present a conflict for you to serve as a member of the MDC and representative of the VMB?
Yet nothing that I can think of.
Is there anything else you'd like to share with the board?
Just once again, I'd like to thank the board for the opportunity to interview. I'd like to reiterate my commitment to the mission and the objectives of the VMB and the MDC, and believe that my background as an RVT educator and practice manager has instilled in me a great appreciation for the intricacies of what the board and the MDC do. I'm really excited about the prospect of contributing to the MDC's efforts and hope that you'll consider me.
Thank you so much. Okay, Ms. Ussery. And if you'll just hang around, yeah. Good afternoon.
Hi, thanks for having me.
Yeah. I think it's Dr. Grant to start.
Good afternoon, Maria. To the best of your knowledge, what are the functions of this licensing board and its committees?
To my understanding, the functioning of this licensing board is to regulate licensees, promote practice standards, and uphold the California Veterinary Practice Act. The committees assist in that by providing recommendations to the board regarding rules and regulations to assist in that, upholding the Practice Act.
Thank you.
Hi there, Marie. Sorry for the wait. Thank you for being patient. So why are you applying to be a member of the MDC, of the Veterinary Medical Board, and what do you hope to achieve as a member of the MDC?
I am applying because I just finished my first term and I have been working on many projects that are still in the works. I would love the opportunity to continue to see those through. I think the work that happens on the MDC is crucial in consumer protection and advancement of the profession both. And I would love to continue to be a part of the discussion.
Do you have any specific advocacy for a cause, a group, or a movement? And how do you promote this advocacy?
All 17 of my years in veterinary medicine have been in rural Northern California, in a very underserved community. So I have a passion for representing agriculture, livestock, basically the large animal side of things that I think isn't very well represented at times. And I think that's obvious in some of the discussions that we've had here today. So I like to be a voice for that. I do that through participation in organizations such as CVMA and other forums to try to be a voice and an advocate for food animal medicine in underserved communities.
Do you have time for the MDC? I'm just going to shorten that. Do you still have time for the MDC? Do you understand the commitment and still have time to fulfill it?
I do, yes. I'm very fortunate to have an employer that understands the importance of the work done here and to allow me the time to take off to accommodate.
The mandate of the board and the MDC is to protect consumers and their pets, and our recommendations and actions are sometimes unpopular with the general profession. How do you feel about making decisions based on the needs of consumers and their pets, despite possible disapproval from colleagues?
So having been in management at my job, I have made many decisions that aren't popular. I know you can't please all the people all the time. I've also been a part of difficult discussions on the MDC where not everybody agrees. But I think these conversations are necessary. I think educating and communicating helps bridge that gap and create an understanding for why we're doing what we're doing.
We assume you are aware of the current issues affecting veterinary medicine today. Which issues have affected you directly, and what issues would you like to see the MDC address?
So as the primary large animal RVT at my practice, there are many issues facing large animal medicine that affect me directly. I think those discussions are starting to happen at the MDC in trying to make things easier for equine practitioners, large animal practitioners to comply with some of these regulations and still keep consumer protection in mind. So I think the start of those conversations are great. I would like to see that continue at this level. And being an RVT, I think there's also a lot of exciting stuff happening there, and yet some scary stuff too. So I want to make sure that I represent RVTs in the profession, but also that we stay in our lane within our educational requirements so that the consumer protection exists.
Without getting into Go again. Without getting into the specifics, Maria, do you have any personal, legal, or professional issues that may potentially prevent you from serving a full term on the MDC?
No, I do not.
Thanks.
What qualities or traits do you think an MDC member should possess to be effective in serving the committee?
I think good listening skills are key. The ability to work well as a team and collaborate on issues. I think keeping the goal of consumer protection first and foremost in your thoughts when you're having these conversations is key. And I think having an understanding of the regulatory process certainly helps.
Can you think of any position that you hold or activities you are currently involved in that may present a conflict for you to serve as a member of the MDC and representative of the VMB?
No, I cannot.
And is there anything else you would like to share with the board?
I just want to say thank you for having me here today. I want to commend you all for the fantastic work that you do because I know it's not easy. And I just hope for the opportunity to continue doing the work that I've enjoyed so much during my last term.
Thank you so much. And I'm sorry for mispronouncing your name earlier.
That's okay. Thank you.
Okay. All right, members. So as this is very, very challenging, we have amazing candidates, as we're very lucky. Any discussion or nominations?
I know it's hard and it's always hard, right? But knowing the work that has been done and being on the MDC, I would like to nominate Marie Ussery for a second term.
I would like to second the nomination.
Okay, any discussion?
Well, maybe I should add a little bit, and that is I
Sure.
am very concerned with having a large animal focus. And I think that Marie has added quite a bit to that discussion. I'm very grateful for that. And so I think even though the other two candidates are very, very outstanding, outstanding letters of recommendation, I mean, I just really feel that since Marie has started some of these processes, it would be great to have her be able to stay with us.
Yeah, I agree with you.
Can I just make a comment?
Yeah.
I just wanted to acknowledge that Darlene and Tracy, this has been their second time around, meaning that we're really seriously considering you, to be part of the MDC. And it's a very difficult decision to be presented with such great candidates. But I would have to say, just like in medicine, continuity of care is something that we support a lot of times. And as I think the way that I look at it, Marie's not done yet with what she's doing, and she's doing great job, at the MDC right now. So to support her to continue on, I think is something that is of great value as well. So it is with deep regret that I would have to say that, I really feel bad, to say Tracy and Darlene, maybe the third time is a charm.
I remind people that I attended MDC meetings for 6 years on my own before I was appointed. I came to every meeting, every VMB meeting, and the more you come, the more you learn, the more you get involved, and the more everyone sees your face. And it will help you gain so much more when you get onto the committee. And I cannot stress that enough.
Yeah, I agree with what everybody said here, and I wanted it's almost, it's just too bad that we don't have more than one position, because both of you, Darlene and Tracy, are uh, highly qualified and bring things to the table that would be very valuable on the MDC, or on the board if an RVT position were to open up. So it's very difficult to not be able to have you be involved. And so I would encourage you to continue to be involved in meetings. Not that we voted yet, but Marie, your work has been amazing, and she's just really been an outstanding member of our MDC, and her rural large animal experience has been invaluable, and really has moved a lot of things forward in ways that we couldn't have done without you. So I'm behind the nomination. Is there any public comment before the vote? I don't see any in the room. Any public comment online?
We are open for public comment via WebEx. If you'd like to make a comment, raise a hand, please, by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. For our mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand button. And do remember, we also have the Q&A box in the lower right-hand corner where you can type the word comment to make your request. We're going to take just a few more seconds to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, thank you.
Dr. Solocito,
Yes.
Dr. Grant,
Yes.
Dr. Nolan,
Yes.
Ms. Pulowski,
Yes.
Ms. Prado,
Yes.
Dr. Bradbury.
Yes,
Motion carries. Congratulations.
thank you so much. We'll be moving on to agenda item 9, interview, discussion, and possible appointments to fill the vacant MDC veterinarian member positions. So basically the same process. And I'm just going to go down the line here and start with Dr. Aberman. I don't see her in the room. So a moderator, can you see if, up there we are. Fantastic.
Can you hear me?
Can you speak up a little bit?
Can you hear me now?
It's a little light. Speak one more time. Now I can't hear you.
Dr. Aberman, how are you doing today?
I'm great. Can you hear me?
I think that'll do. Yeah, it's just a little light, but I think we can hear you and you're
Okay.
coming through.
It's up
Yeah.
as loud as my computer can go. So let's pray.
Yep, no problem. Hi, thank you for your patience
Thank you.
today.
Thank you.
Yeah. Who were we on? Who was the last? I think I was the last question. So Dr. Solocito.
Good afternoon, Dr. Aberman. Yeah, to the best of your knowledge, what are the functions of this licensing board and its committees?
So the Veterinary Medical Board, to my understanding, protects the consumers by regulating the practice of veterinary medicine through licensing, through enforcement, and also works very closely with the legislature. As far as the MDC relationship with the Veterinary Medical Board, I see that as assisting the board in deliberating on issues, making recommendations for Veterinary Medical Board laws and policies, kind of like consulting and providing insights to that board.
Thank you. Why are you applying to the member of the MDC of the Veterinary Medical Board, and what do you hope to achieve as a member of the MDC?
So I applied last January 2023. I have the time now. I've practiced. My father was a veterinarian, small animal veterinarian. I've practiced for more than 20 years in California. I've done relief, I've done area management. I was lead doctor. I have now a position where I have the flexibility as a director of medical quality for a small group of hospitals to really help drive change and offer that time commitment. Previously, working in the small animal field that I worked in, the time was at a premium. And now I can focus on things that are more in tune with what I'm interested in now, focusing on service, customer service, consumer service, our internal customer, our external customer. And now I have the ability to make that commitment. So that is why I'm applying. Did you ask me also about my my qualifications, or I can't remember, sorry.
No, yeah, why you were applying and what you hope to achieve as a member of the MDC.
So this is kind of an exciting time. So I think it's kismet. I didn't get nominated to the board last year. I've been following on YouTube all of your meetings, and there's just a lot of change going on, and I feel like I want to be part of that change and help. What I do right now is, as a project manager and developing SOPs and so forth, is getting important stakeholders in the room and being clear on what the issue is, and really getting into the discussion of what the problem is and looking at it through the prism of customer and consumer protection. That is really my passion. We all want, I think, as veterinarians, the same thing. We want the consumer protected and the pet protected. And I think this is just a bigger umbrella for me to bring my passion into practice.
Good afternoon. Thanks for being patient.
Sure.
Do you have any specific advocacies for a cause, a group, or a movement? How do you promote this advocacy? You may have answered this.
So in my day-to-day job, I am an advocate for the doctors and also for the patients that they see. I'm driving the medical standards and the medical practices in my group of hospitals, which is amazing and a like my dream job. I am very passionate about pain management. I think right now it's coming to the forefront, but most of when I talk at WVC or the AVMA, most of those talks are on pain management and really bringing pain management to life for those people that may not have all the resources that they think that they have, and how to utilize what they have in their hospitals to better control pain in their practices. That is a huge passion of mine. So that's mostly what I talk on, but of course, you know, there's always other things that come up and issues that come up in my day-to-day that that I can sink my teeth into.
Great, thank you, and thank you for your patience. The MDC meets quarterly for a half to a full day, and the members are typically assigned to several subcommittees, each of which may take an additional 2 to 6 hours per month. Given this information, are you able to make this time commitment to fulfill the needs of the MDC?
Yeah, I think the meetings are the basic, right? And so that's basically reporting out what's kind of happened in the war room, and I consider those subcommittees the war room, and that is my my happy zone, is figuring out what the problem is, whether it's an issue or a problem, or what the VMB has said, you know, this is kind of what we need to solve. Seeing it from all sides, getting a plan together, and being really smart about what that plan looks like once it's rolled out. As we saw with the RVT doing vaccines, like that was the right call, but when it came to fruition, there was a lot of questions, not just here on the board, but you know, in the local practices, and like, what does that actually look like? And so seeing an issue from all different angles is, of paramount importance. And I think that that's what the subcommittee is. And I think that's where I would probably spend most of my time. And I have no issues with spending time on those kinds of passion projects.
The mandate of the board and the MDC is to protect consumers and their pets, and our recommendations and actions are sometimes unpopular with the general profession. How do you feel about making decisions based on the needs of consumers and their pets, despite possible disapproval from colleagues?
Leadership can be very lonely. And I'm used to that. I've been in leadership positions for the last 15 years or so of my being a practicing doctor. I think really what it comes down to is being transparent and painting the whole picture, collaborating with the right stakeholders. There are times you're going to have to deliver bad news, but bridging the gap and answering the why. This is why we made this decision. I think when people hear of a new rule or a new operating procedure, if they don't understand the why behind it, they're more resistant to adopting it. And I think if we don't do a good job of educating those who it affects, then that's when we have issues. And so it's clear to me that when we are looking through the consumer lens and the customer protection, that is what's driving our decisions. And if we keep that in mind, the rest will follow, but it's all about education and transparency.
Thank you. We assume you're aware of the current issues affecting veterinary medicine. Which issues have affected you directly, and what issues would you like to see the MDC address?
Veterinary burnout is real. It makes me sad when I have doctors that apply for positions and they've been out for 7 years and they think that they're burning out. That makes me sad. I think the board is doing a good job of technician utilization in some of the regards. Of course, there are times that we won't all agree on everything, and you have to kind of accept and commit when things don't always go your way. But honestly, I think it was actually Dr. Bradbury and Dr. Nolan told me last when I didn't get a position on the board to do the consumer complaints because there was a backlog of that. And when I started evaluating those, and I saw that some of the complaints dated back to like 2019, it made me really sad. And is there a way to stream? And it wasn't lost on me that I was the one and I was the only one that was evaluating these cases, which makes me a little nervous when I evaluate cases for ABVP applicants or what have you. It's usually 3 or more people evaluating the same case. So that gave me a little bit of pause. So that wasn't lost on me, that responsibility. But is there a way to streamline that process and encourage new folks to want to evaluate some of these cases? And I think that there has to be a better way of doing this. So I didn't think it was going to be, it wasn't going to turn into that, but the more I do those complaints, I just feel like there has to be a better process for this. I would hope that the board and the MDC would be open to exploring that on some kind of level in the subcommittee.
Oh, thank you for that. Now, without getting into specifics, do you have any personal, legal, or professional issues that may potentially prevent you from serving a full term on the MDC?
No, I guess I would probably have to give up doing my reviewing of complaints, I'm assuming, but that would be the only thing.
What qualities or traits do you think an MDC member should possess to be effective in serving the committee?
I think that needs to be a collaborator. I think you have to be a good listener, and I think you have to be analytic by nature. There are those of us that are highly analytical, almost to a fault, and really it's all about putting your emotions, and honestly, some of it is putting your personal experiences and professional experiences aside to get to the right answer and to get to the right, to develop the right plan. I think people need to also be transparent on that board. And you also want somebody on that board that is going to be a workhorse. There are those of us that in high school and college would get on a group project and you'd be like, oh no, not this person, because they're not going to do any work. I was like the exact opposite. I'm a hard worker, and I think you have to be a hard worker and you have to be a self-starter, especially in these subcommittees, because you're working asynchronously potentially together on these important topics. I think that self-starting and self-sufficiency has to be at the forefront of your mind.
Can you think of any position that you hold or activities you're currently involved in that may present a conflict for you to serve as a member of the MDC and a representative of the Veterinary Medical Board?
I don't think so. Again, I do the reviewing of complaints right now, which I love. I think it's very interesting. I was a previous board member on ABVP Foundation Board, and I'm very involved in that organization. But there's nothing professionally that I can think of that would be a conflict other than that.
Dr. Aberman, is there anything else that you would like to share with the board?
No, I just think that this, I want to thank you for the opportunity of coming to you guys again. This is just an exciting time. There's a lot of, when I was looking at a few weeks ago, I was reviewing the October meeting, and there's just a lot of exciting things going on, with SB 669 and the VCPR stuff, and now there's stuff coming up about technicians wanting to, or assemblyman sponsoring a bill to have technicians doing neuters, and I think it's just an exciting time in the Veterinary Medical Board, and especially the MDC, to kind of hash that out. That's a lot of change. And I just want to be part of that change, and I have the time to do it. I'm passionate about it. It's really important that we're making these decisions, that whoever's on the board is making these decisions through that prism of customer focus. And I just think it was probably kismet that I didn't get on the board last year, and I hope to get on this year, just because it's an exciting time and there's like really interesting stuff going on right now.
Thank you so much.
Thank you.
So we're gonna continue on with the interviews. I did want to let everyone know that we do have a hard time limit at 5 o'clock because of our moderator. So we're going to try and get through these. We are going to get through these interviews, but I am a little concerned for those who have been here for the discussion on legislation that we may not make that 5 o'clock deadline. So, and it may get pushed to tomorrow. So I just wanted to be upfront about that. And it's my apologies that it's run so long. But wanted to just give those who are waiting for that. We're going to try. We'll see how this goes, but we do have a hard deadline at 5, I believe, unless there's any other way to get a moderator afterwards.
So our moderator just let us know we do not have a hard stop. He's able to stay.
Oh, that's fantastic. Thank you, moderator. You're wonderful. So we will get through, we'll go through that. We'll finish these interviews. We'll be skipping agenda item 10 and pushing that till tomorrow. And then we're going to be taking 11A1, I believe, and then pushing the rest till tomorrow.
Yeah, because I think we also have to be mindful of all the other staff here too. Anything after 5 is not encouraged. So I would just recommend, you would just, like you said, just do 2133 and then
Yeah.
stop for the day.
Okay. Sorry for that. That pause there. So next up is Dr. I believe you've been pronouncing it Gedkin. I'm sorry if I'm saying that wrong. But Dr. Gedkin, and are you online?
I am. Let me just
All
turn
right.
on my.
Did I say your name right?
You did, and that's why clients call me Dr. Jenny. So I'm not offended at all whatsoever.
Okay, great. And I also got hello and welcome and thank you for your service. Is it who? Oh, thank you. Okay, Christy.
Hello, thank you for waiting. To the best of your knowledge, what are the functions of the licensing board, of this licensing board and its committees?
Hi, thank you guys again for taking the time to do this. I know your days are long. To the best of my knowledge, the function of the VMB and the committees are to protect people and their pets by enforcing the Practice Act, as well as regulating licenses and promoting professional standards. I do specifically kind of lovingly refer to the MDC as kind of the right-hand nitpicky workhorse for the VMB. That is what I specifically see as the MDC in the larger role of the VMB.
Why are you applying to be a member of the MDC and what do you hope to achieve as a member of the MDC?
Thank you for that question. You know, it's interesting sitting here and listening to such amazing people come before me. It's like an embarrassment of riches in our profession right now. What I think the reason why I'm stepping in now and asking for a position on the MDC is my experience and what I bring to the table. I have been a veterinarian for 19 years, and I am in a non-traditional clinical setting as a mobile practitioner. So I do bring that hat, but I kind of bring one seat and a few perspectives to the table. One of the main reasons that I think I could have a valuable voice is with my work with the enforcement department of the VMB since 2014. I was an inspector for 6 years up through COVID, and I was an expert witness reviewing cases for 4 years and have even testified twice on behalf of the VMB. I did reach out to enforcement a few years ago once COVID settled down and I had the time to try to give back. And I am now very honored to be considered a consultant to the enforcement division of the Veterinary Medical Board. So I do think one of my advantages is the experience in the past 10 years of kind of being boots on the ground with enforcement, not only understanding the Practice Act and the intent of not only the black and white words, but also the gray areas with those words, but also being a veterinarian as well. I kind of pride myself in the fact that, especially in my area, I'm kind of considered the face of the VMB, even though I am now just a consultant with enforcement because I have inspected over 120 premises in my county. I have interacted with veterinarians while actually enforcing certain aspects of the Practice Act. So I do feel like that is a unique perspective, especially when we are trying to make sure that the regulations are fitting into this next era of vet med. I do think it's important to have a perspective of how is it actually being enforced and interpreted now? Where are the gray areas of that? What is the intent and what can this be construed as?
Thank you so much for that answer. For the next question, do you have any specific advocacy for a cause, a group, or a movement, and how do you promote this advocacy?
Yes, I do. Outside of vet med, I am a huge advocacy for education. I'm on 2 PTA boards as well as music booster boards, West Valley in my community back to school, serving underprivileged kids, filling their backpacks beginning of the year. But I would say that my largest advocacy is for the profession of veterinary medicine. I am the president of the Santa Clara Valley Veterinary Medical Association. That kind of fell apart during COVID, and we kind of bootstrapped back together. I do enjoy volunteering with the CVMA on their DEI inaugural committee, as well as being an alternate to the House of Delegates. I also advocate for the veterinary profession by directly contacting our assemblymen and representatives when there are bills or proposals that do affect our profession. I did speak to Senator Cortese on SB 669. He is my direct district senator when that was going through. And even just last Monday, I virtually met with Representative Kalra to discuss AB 2133 and give perspective there. I am also involved, and another advocacy for me is access to care. I do volunteer with the Bay Area Street Dog Coalition. We have a clinic this Sunday, as well as I am a volunteer with Silicon Valley Pet Project, pulling high needs dogs out of San Jose Animal Care and Control.
Thank you. The MDC meets quarterly for half to full day, and members are typically assigned to several subcommittees, each of which may take an additional 2 to 6 hours per month. Given this information, are you able to make this time commitment to fill the needs of the MDC?
Yes, I do feel confident. I am very good at carving out time where needed. And once I'm committed, I am committed. In fact, I do actually miss driving up to Sacramento. We used to do that way pre-COVID and meet at least yearly with 1747. And I am looking forward to not only in-person meetings, but also doing the majority of the work behind the scenes and collaborating with others. I'm confident I can.
The mandate of the board and the MDC is to protect consumers and their pets, and our recommendations and actions are sometimes unpopular with the general profession. How do you feel about making decisions based on the needs of consumers and their pets, despite possible disapproval from colleagues?
That is a great and realistic question. I do feel like in my past 10 years of being associated with enforcement for the Veterinary Medical Board in my community, that I have had direct face-to-face conversations with colleagues, especially during inspections when I am enforcing certain regulations that maybe colleagues can't actually see why that is being enforced or looked at. So I've actually been pretty boots on the ground with staying professional and explaining the intent behind it. And I have also testified on the stand twice on behalf of the VMB in front of administrative law judges, where I do have to stand by my reports and my findings, no matter what. Even personally with the rescue work I do, there are decisions that I will help make in the best interest of pets that a lot of other volunteers might not see that perspective on. But it is always good to take a breath and remember that we are all working towards the same goal. So I do feel like in my past 10 years, especially in the profession, I have handled that and feel comfortable with that position.
Thank you.
We assume you are aware of the current issues affecting veterinary medicine today. Which issues have affected you directly, and what issues would you like to see the MDC address?
So I would say directly, and I do think, wellness plays an issue, and wellness and mental health is part of the reason why I am in non-traditional clinical veterinary medicine doing hospice and palliative care in home. I will say as a whole, record keeping requirements, as I review up to 60 cases a month, 60 plus cases a month, is an issue that I think might need to be reevaluated, especially discussing prognosis and communication with clients. There are many consumer complaints that I do feel like communication in that medical record of prognosis with that client may help. And in general, an issue that is on my radar and I'm pretty passionate about is kind of the creep on scope of practice. I do want to make sure, for the best interests of animals, consumers, and veterinarians, that we make sure that we not only are staying in our lane, but protecting our lane as well.
Thank you. Without getting into specifics, do you have any personal, legal, or professional issues that may potentially prevent you from serving a full term on the MDC?
Not that I am aware of.
And what qualities or traits do you think an MDC member should possess to be effective in serving on the committee?
So I do think the committee is a collaborative effort. It is teamwork. And like many of us, we have staff around us and we have people that are naturally collaborative. With that collaboration comes communication skills and respect and open to all inputs, open to everyone's perspective. Even sitting through meetings, it is so interesting to hear someone bring up a point where it's like, oh, I didn't even think of that. Now we do need to kind of sit there. So being open and again, realizing that we're all here for the same purpose is so important. I'm going to be honest too, it takes stamina as the time can see. So you do need some mental stamina. You do need to, at times kind of feel like you need to grind it out, but at times also know when to step away when all the words are kind of blurring and go, okay, I need a break. So that realistically, I do know kind of those boundaries where I can get the best work done behind the scenes by making sure that I'm not plowing through and all of the letters and numbers start jumbling together. So I do think, just like in a clinic or in any work environment, there are people that are naturally suited to collaboration. And there might be people that are not. And I do pride myself on being a collaborative member of everything that I take part in.
Can you think of any position that you hold or activities you are currently involved in that may present a conflict for you to serve as a member of the MDC and representative of the VMB?
No, I do not. I will say I take this interview and just the fact that I was selected extremely, extremely personally just amazing. I do know if I am honored to have a seat on the MDC, I will have to balance that with my work as a consultant to the enforcement to VMB. I will not plan on dropping that unless it is deemed a conflict by any of the parties or stakeholders involved, but I will balance that time. So I have thought about it long term, if that would be a conflict of time or interest. I do not think it will be.
Is there anything else you would like to share with the board?
I just want to say thank you. I do know, being privileged to be working with the VMB enforcement, and I lovingly call them 1747, so many names I recognize, so shout out to 1747. It is a lot of work, and a lot of it is behind the scenes, and a lot of it is thankless work. So we don't do this for the glory. We do it for the work and for the mission. So I do want to, especially hopefully towards the end of a long day, thank you guys, because I don't think a lot of you hear that a lot. So thank you so much for taking the time.
Thank you so much for coming and interviewing and taking the time as well. So thank you. Dr. Nunez. Welcome back.
Thank you.
Thank you for your patience today. I guess your meeting midday didn't get in the way of the interview. All right, Dr.
The green
Grant.
light. Now's the time where you switch to questions.
That's
Give me
right.
all new
'cause
questions.
Yes, we're definitely have a different set for you.
Dr. Nunez, to the best of your knowledge, what are the functions of this licensing board and its committees?
I think I really understood the purpose of the licensing board in one of Tara's famous legal presentation. I forget what the issue was, but she cited the 1890 Sherman Antitrust Act in her presentation, in letting us know that we as veterinarians have a monopoly on veterinary medicine. Only veterinarians are allowed to practice veterinary medicine. But in order for us to have that exemption, we have to regulate ourselves and hold ourselves to the highest standards so that we protect the consumer. And that really, in a nutshell, is the purpose of the Veterinary Medical Board. Regulating our profession and holding our profession to the highest standards involves a lot of things. It involves licensing, disciplinary actions, hospital inspections, accreditation programs, and so forth. And a lot of those things can be very complicated and convoluted and intertwined amongst each other. And our profession is constantly changing. So our Practice Act is constantly changing. And when new issues come before us, those issues deserve the time and consideration necessary to make the right decisions. And that can't be accomplished during a regular board meeting. And because of I always call it the Bean Casserole Act, but it's the act that prevents you from talking amongst each other in between meetings. The MDC was created to really get into the nitty gritty of all these issues through their subcommittees, which is comprised of no more than 2 people in it, so that they can devote the necessary time to the issues to provide recommendations to the board on how to best deal with the issues that are before us.
Thank you.
It's not the Bean Casserole Act, it's the Bagley King, just for the record.
Thank you, Dr. Nunez. Thank you for your patience. Why are you applying to be a member of the MDC of the Veterinary Medical Board? And what do you hope to achieve as a member of the MDC?
It's very rare that you meet someone who really enjoys regulation. And I'm one of those persons that really enjoys getting into the regulatory aspect of our field. If I'm on a plane and I don't want to talk to someone and they ask me what I do, I tell them I'm a regulator. If I want to talk to them, I tell them I'm a veterinarian. But I enjoy doing this. I think I find it odd that more people in our profession don't understand the importance of regulation and how it really affects their day-to-day practice and work. If it wasn't for sound regulatory policies, things in the practice area would be really crazy. And I also have to thank efforts from the people that come to these meetings, the CVMA and other stakeholders, because if we weren't paying attention to what's going on with legislature and regulatory efforts and special interest groups, then it would be very difficult for us to practice veterinary medicine. So I think it's important that I stay involved in the formation of regulation involving our profession. What do I hope to accomplish? Hospital inspector uniforms, of course.
Do you have any specific advocacy for a cause, a group, or a movement, and how do you promote this advocacy?
I am an advocate for my patients, for my clients, and for my colleagues. I think that our pets got us through the pandemic, and we all have our own personal stories of how they were there with us. They kept us sane, and they're an important part of the human-animal bond. And I think that that is a precious bond that we have a duty to protect and to make as long and as healthy as possible. Um, our clients, it's getting harder and harder with this economy and this society to properly take care of the pets that are so important in our lives. And I will be an advocate for them as well to make sure that they are able to get the medical services that they need for their beloved children, patients, pets. And I also have to acknowledge that I do not forget about food, animal, and equine medicine because they're also under our jurisdiction. And I am thankful that we have experts on both the MDC and the Veterinary Medical Board that can help us out making the right decisions for those fellows. And for my colleagues, it is getting really hard to practice veterinary medicine with all the rules and regulations and burnouts and changing expectations from our clients. So any regulations that we make, we always have to be mindful that veterinarians and paraprofessionals are also consumers, and they're the ones that have to deliver veterinary medicine. And if we make it too difficult for them, then we're going to lose a valuable resource. And they always have to be kept in mind when we're establishing regulations and rules.
The MDC meets, oh, she's.
I was just looking to where the next question.
Oh, I'm like, as you know, the MDC meets quarterly, and members are typically assigned to several subcommittees, each of which may take an additional 2 to 6 hours per month. Are you able to make this time commitment to fulfill the needs of the MDC?
I'm going to write down 6 hours as a monthly commitment to that. But I think a wise person said to me once that if you want something done, give it to a busy person, because a busy person is in that mindset already to get things done. And it's I've been accustomed to having to serve roles like this for most of my veterinary career. So it's not going to be anything different than what I'm already doing. And I believe that I do have the time necessary to get the job done.
Right. The mandate of the board and the MDC is to protect consumers and their pets, and our recommendations and actions are sometimes unpopular with the general profession. How do you feel about making decisions based on the needs of consumers and their pets, despite possible disapproval from colleagues?
I think that the collective decision is the wise decision, and any decision that we make as a committee or as a board is the result of discussion amongst each other. I won't say that I will agree with every single person on the MDC. We're going to have disagreements. There's going to be discussion. But in the end, it's going to be a collective decision. And so I'm comfortable with a decision being unpopular with my colleagues, because I know it's the best decision that's been made with a group of very talented people, and it's right for the mission.
Thank you. Oh, it's me, right? Yeah. Okay. I'm like, it's me. I'm like, it's me, Mark. Okay. We assume you are aware of the current issues affecting veterinary medicine today. Which issues have affected you directly, and what issues would you like to see the MDC address?
Of the current issues, I think the issue that affected me directly was the establishment of the virtual VCPR in California. Although I know that we already did do a lot of virtual or telemedicine and so forth. The establishment of a virtual VCPR was a surprise. It's a strain on how we practice and how we maintain quality control of our medicine. And there's lots of pressures from corporate medicine to see more patients. And one possible suggestion on how to accomplish that is to see patients more virtually. But I've had a really hard time accepting that, and it's been a real effort to kind of push back on that. The issues that I think need more attention in the coming years relates to the scope of practice, I believe, because of the workforce demand issues. It's hard to know. There are going to be lots of new schools, veterinary schools, that are going to be opening up over the next several years. And it's hard to know whether or not that's going to be sufficient to meet the workforce demand of veterinarians. My thought is that it's probably not going to be sufficient. And the generational changes of how many days per week veterinarians are expecting to work or is going to be different from what it has in the past. And so I believe that we're going to have to rely more on other members of the veterinary team to deliver medical services. And that's going to have to require an evaluation of the scope of practice for our paraprofessionals. And that's going to be our next biggest challenge in the coming years.
Pardon me, without getting into specifics, do you have any personal, legal, or professional issues that may potentially prevent you from serving a full term on the MDC?
I'm currently on the board of directors of the American Association of Veterinary State Boards. That's my only affiliation right now. I don't believe that that's a hindrance at all. I think it's actually a good thing to know what's going on in the rest of the country. And I've also had to pay hush money to my chihuahuas, not let anyone know what a horrible singer I am in the morning. Other than that, I'm good.
Dr. Nunez, what qualities or traits do you think an MDC member should possess to be effective in serving the committee?
First of all, I think they should have a good sense of humor because sometimes it helps wake everyone up during these long, grueling meetings. But I also think that a effective committee member needs to be prepared for the meetings. That requires you to read all the board package materials and understand them and not start to read or figure out the issues during the course of a meeting. And I believe that a good board member needs to be a good listener and willing to hear completely the other side of an issue and be willing to compromise with fellow members, again, to make that collaborative decision that I think is the best decision.
Apologize. Can you think of any position that you hold or activities you are currently involved in that may present a conflict for you to serve as a member of the MDC and representative of the VMB?
No, like I said, my current commitments right now, I'm still a full-time practicing small animal veterinarian in West Hollywood, California. I serve on the Board of Trust Directors for the American Association of Veterinary State Boards, and that's it. No other affiliations.
Is there anything else you'd like to share with the board?
Yes. One thing that I have learned with being involved with the AAVSB is that California is the greatest state in the nation. Our veterinary medical board accomplishes so many things and has so many license holders and premise permit holders that so many other states are in awe with how much we do. And I'm so proud to be the representative from California when I'm attending those national meetings, because we rock, and it's a really hard thing to sit through these meetings, but we're doing a really good job, and I'm very proud of all of you on this board and all the members of the MDC.
Thank you very much.
You're welcome.
Okay. And finally, we have Dr. Silverman. Moderator, can you promote Dr. Silverman, please? Oh, I'm sorry. I didn't see you. Hello, Dr. Silverman. You were actually behind the, you came out of nowhere. Hello, good afternoon. Thank you for your patience. I think you get to start. Yeah.
Okay, I get to start. Good afternoon, Doc. To the best of your knowledge, what are the functions of this licensing board and its committees?
It would be to evaluate the candidates that are entering our profession, technician and veterinarian wise, based on the previous standards, to modify those standards as needed, and also to protect the consumers and care for the well-being of animals.
Why are you applying to be a member of the MDC of the Veterinary Medical Board? And what do you hope to achieve as a member of the MDC?
Well, I think I've got a broad range of experience, even though I'm a radiologist, I've been in several different formats of veterinary medicine. And I think I can bring forth some of that experience as far as not tempering, but influencing some of the regulations that are made and some of the opinions that are rendered by the board.
Good afternoon, and thanks for being so patient. Do you have any specific advocacy or a cause, a group, or a movement? And if so, how do you promote this advocacy?
I think my main advocacy is continuing education for veterinarians and technicians. So very early in my career, I co-authored the first veterinary technician radiology manual. And I published extensively and wrote books and such. And now I'm a consultant for Veterinary Information Network. And I'm active in the small exotic animals, the avian, the reptiles, and diagnostic imaging. And I think what it's done is it's opened my eyes to not everything is as it is in the San Francisco Bay Area. And also that a lot of people are, since we're veterinarians, we have to be able to do things that are, quote, outside of our comfort area. And these people are asking for help. And I have to realize that you can help them without criticizing them and give them avenues to help their patients and their clients.
Thank you.
Thank you for your patience. The MDC meets quarterly for a half to a full day, and the members are typically assigned to several subcommittees, each of which may take an additional 2 to 6 hours per month. Given this information, are you able to make this time commitment to fulfill the needs of the MDC?
Other than my morning workout and walking my miniature doxy, yes, I can, I can do that.
The mandate of the board and the MDC is to protect consumers and their pets, and our recommendations and actions are sometimes unpopular with the general profession. How do you feel about making decisions based on the needs of consumers and their pets, despite possible disapproval from colleagues?
Well, as a radiologist looking at other people's work, or a mobile ultrasonographer doing examinations that they wouldn't do, you're often in the situation where you have to render an opinion that is not their opinion or the way that they would do it. So that my primary goal whenever I approach any clinical case is the welfare of the pet. And sometimes it's got to be a direct suggestion, sometimes it has to be a suggestion, sometimes it has to be a series of options. And so it's quite likely that no matter what regulation, no matter how well thought out, how well researched, is not going to be what people want to hear. And so you have to, one, decide what is best, and two, the best way to present that so that it doesn't offend people, and three, present it so that somebody can be enthusiastic and support it. Maybe.
We assume you're aware of the current issues surrounding veterinary medicine today. Which issues have affected you directly, and what would you like to see the MDC address?
Well, that is the simplest question. In that, when I stopped doing mobile ultrasounds and in-hospital work, I suddenly became a consumer of veterinary medicine. I used to be able to walk into one of 50 or 100 hospitals and say, you know, my dog has diarrhea. Can we do this or this or this? Now it's Silverman who, hospitals have changed, people have changed. And now, especially living in Nevada County, I don't have the options that I had in the San Francisco Bay Area. And so I think the challenge in veterinary medicine and a challenge for the board is to formulate rules and regulations, enforce those rules and regulations, admit people that are going to be able to increase the availability of veterinary medicine, whether it be a critical case or a long-standing case. I think, in Nevada County, there are hospitals that say, no, our next routine appointment is 3 months down the line. And if I were to tell my wife that would not be a popular thing.
Thank you. Without getting into specifics, do you have any personal, legal, or professional issues that may potentially prevent you from serving a full term on the MDC?
Negative.
Thank you. What qualities or traits do you think an MDC member should possess to be effective in serving the committee?
Well, recently I was on the American College of Veterinary Radiology Teleradiology Standard Committee. And you would think that all radiologists would be the same as far as what we do and how we do it, but we're not. And so the first thing is you have to be able to listen. And you have to listen to what the other members are saying. And I think my experience goes through many disciplines, and I can go back on some of my experience at zoos, which say a standard small animal veterinarian would not have. And you can temper what you say by your experience. But the other thing, which I don't know if I can take pride in it, but I am a tough reviewer. And I've written a lot and I've reviewed a lot of articles and I've looked at, a lot of clinical cases. And the chief of radiology at the teaching hospital was a tough Swiss radiologist. And when I finished that, I went to the medical center in Sacramento and did an abbreviated human medical residency. And that was run by a South African who was really strict. And, they would go like that and say, what does slightly mean to me? Does it mean the same thing to you? And that's how I look at things. And I sat in on yesterday's session and you could see that, some little word can mean a lot. And in that session was, one where you have to be able to review radiographs or look at radiographs. Well, the thing is, it was much more complicated than that. So I think my attention to detail sometime may not be accepted, but I'm willing to modify my my standards as far as what the majority says.
Can you think of any position that you hold or activities you're currently involved in that may present a conflict for you to serve as a member of the MDC or representative of the VMB?
Negative.
Thank you.
Last question, is there anything else you would like to share with the board?
Well, I'm very, very impressed with the hard work of the MDC. And I sometimes say, gee, do you really want to do that? And I do. But I could see that this is not just a ceremonial position. It requires a lot of work. And I'm willing to do that. And I was also really impressed by staff, the support that staff gives the MDC in getting everything in proper order and wording and, formulating their conclusions.
Thank you so much.
Thank you.
Okay, well, we have 2 positions open and we have 4 good candidates. So does anybody want to make a motion? Everybody has their fingers ready. Okay, Dr. Solicito, Vice President.
Okay, I would like to nominate Dr. Gedkin.
Okay.
For the MDC.
I'll second that.
Sorry, I couldn't understand who you are nominating. Could you repeat that?
Dr. Jenny Gedkin.
Jenny, okay, thank you.
Okay. Is there any
Yeah,
discussion?
I'd like to nominate Dr. Silverman.
I think we have to,
Oh.
yeah, this one first. So any discussion on Dr. Gedkin?
I don't know. I just wanted to say the scope of work that she's done and her perspective, the way that she presented it. And I also appreciate the clarity in communication. I think she was able to express herself, very well with very clear intentions. And for that, that's why I'm putting my nomination behind her.
Yeah, I agree, and that she understands and she has a knowledge of the regulations and the statutes, and I appreciate that. So I agree with you.
Jamie, did you have anything to say?
I concur with your remarks on her as well.
Yeah, I think we have 4 really good candidates. Also, I just want to really acknowledge that we have wonderful candidates, and it's really exciting to see a group step up. I felt like almost throughout all 4 candidates, I got a little bit of a interesting feel, and maybe it's my problem with the perspective, but I really liked what Dr. Aberman said about these are workhorse people, you know. I mean, the MDC really, I think their influence comes basically on not making the decisions, but really providing accurate and in-depth information to the board. And I think that came through differently in all different candidates. And I thought that was kind of an interesting perspective. I do think that Dr. Goodkin mentioned stamina, which is very similar to being the workhorse, you know. But I think they're all really good candidates. I think it makes it really, really hard to, and I think maybe part of the question would be what kind of experience and expertise and ability to really work hard, you know, do we need? And I'm not really aware of the breakdown of the expertise anymore because I'm not sure who, I know I know one of the veterinarians that we're replacing, and then I guess I'm not sure maybe the background of both, and that would be helpful to me.
So Dr. Sequoia was a small animal practitioner, and I think Dr. Lazarchev was also a small animal practitioner. And they both were fairly, I think, busy practitioners. But there wasn't a lot of regulatory background. I think Dr. Sequoia was on the CVMA before. On the board now, we have Dr. Sullivan, and I think he's the first to term out in 2026. We have Dr. Waterhouse. We have Dr. Grant. We have Kathy Bowler. We have Marie Essary. We have Christy Pulowski, and I think that's it.
Carol.
Oh, sorry, Leah and Ms. Schiffelt.
Carol Waterhouse too.
Pardon? Yeah, Dr. Waterhouse.
Dr. Waterhouse.
Yeah.
Okay.
Does that help you?
Yeah, and I think, you know, we have a motion now made and seconded. So any other discussion of other candidates? Do you want me to table those or?
I think we should talk about it because we're about to vote on somebody. And if we have strong feelings about others that aren't on the table, it kind of came quick. So yeah, go ahead and.
Well, yeah, and I am very strong supporter of Dr. Nunez, partly because of his experience and ability to bring some of the national perspective and to help us achieve some of our goals and objectives that are really, really important, you know, including some of our testing issues. I don't know how else to call them, but, you know, some of our issues that we're having on a national basis. So I think he brings a lot to the table in that regard, and it makes him a very valuable candidate to me. So.
Yeah, we do have two, and I think it's difficult because if, you know, I agree with you, Dr. Nolan, and of course I wrote Dr. Nunez's recommendation letter with Very, and I'll okay. Like, oh, okay, I'll get you in a second.
No, I was gonna say that. I
I'll just-
actually was
can I
going
finish?
to nominate Dr. Nunez, because I think we have to remember that Dr. Sullivan is going to term out. And so it's really, we have gone down the road of, oh, let's try to make sure that we have new people on the MDC. But what people don't realize is that MDC is really hard. And without knowledge and people really willing to work on the MDC, you don't get the work product that you need. And Dr. Nunez we know, brings that. And so I think that was going to be I was going to do that. But I also liked Dr. Gedkin. So that I wasn't just jumping on your bandwagon in that, you know. So that is what I believe in, and those so I was going to nominate Dr. Nunez, and in putting it out there because I believe that he will bring that experience and knowledge and skill, and we know he brings the work. So
I'd like to speak on behalf of Dr. Silverman. I know he has been involved with the MDC specifically, but I do appreciate his background in wordsmithing and detail work, and perhaps a little bit of a fresh outlook to how some of the documents we have to go through. I think he's had a wide variety of experience with different species and different groups. So I think it deserves consideration for that.
Diana?
Thank you. I'd like to, Mike, as we're just talking to everyone now, I'd like to throw my vote of support in for Dr. Nunez. Not only have I had the honor to serve with him on this board, also to have the honor to disagree. And so in working through the issues, so I know firsthand what it is to learn, like work with someone and reach the much hard decisions that are necessary serving on the board and on the MDC, and know that his work ethic and passion for what is the veterinary profession is of I'm like, is of the gold standard, as you veterinarians should say. I'm like, I'm here all week. Thank you.
Okay, so we have one motion that's been seconded, I believe. And we need public comment on that motion. Any public comment in the room? Moderator, can you open it up to those online? Please.
We are accepting public comment. Excuse me. We are accepting public comment on the nomination. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to wait just a few seconds now to see if we have a request for public comment. As a reminder to our mobile device users, you can hit the ellipses button, that's the ... in order to find your hand, and you may also type the word comment into the Q&A box in the lower right-hand corner of the screen. Seeing no request for comment, do you wish to continue?
Yes, thank you.
Dr. Solocito?
Yes.
Dr. Grant?
Yes.
Dr. Noland?
Yes.
Ms. Pulowski?
Yes.
Ms. Prado?
Yes.
Dr. Bradbury?
Yes.
Motion carries. Congratulations.
Okay.
I'd like to make a motion
Yes, go ahead.
I'd like to make a motion to appoint Dr. Mark Nunez to the MDC position.
Then I'll second that.
Okay, we have a first and a second. Any further discussion? Public comment? Seeing none in the room, moderator, please open it up to the public.
We are open for public comment on the next nomination. If you would like to make a comment, please raise a hand by tapping that hand button. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, thank you.
Dr. Solocito?
Yes.
Dr. Grant?
No.
Dr. Noland?
Yes.
Ms. Pulowski?
Yes.
Ms. Prado?
Yes.
Dr. Bradbury?
Yes,
Motion carries. Congratulations.
congratulations. Welcome back. Pardon? And congratulations, Dr. Gedkin, sorry. I think this next agenda item is going to be take a few minutes. So I know that we're all here a bit late, but I think we need to take a 10-minute break before starting this, and that will be our last agenda item of the day. So just to clarify, we are postponing agenda item 10, the update and discussion on pending regulations, until tomorrow, and moving on to agenda item 11A1, and then we'll be tabling the rest until tomorrow. So we'll take a 10-minute break. We'll come back at 5:20. And thank you so much, moderator, for staying, and everybody else here in the room. Okay, moderator. Are we back on?
We are indeed.
Thank you. And again, thank you so much for staying.
Make
All
sure you
right.
thank the VMB staff as well.
Oh, yes, yes. I said everybody in the room, but I thank you for the reminder. I'm sorry to keep you all late, so thank you for staying. Okay.
Hello, Justin Sotelo here, new policy analyst for the board. I'm going to keep my comments brief. Just cue this up in the interest of giving our guests more time to speak. But we're just addressing Assembly Bill 2133 here, CALRA. And in short, this bill proposes to allow RVTs to perform neuter surgery on male domestic cats under the direct supervision of a California licensed veterinarian. More specifically, this bill touches two, or amends one statute and adds an additional statute, BPC 4840, where it would outline the conditions for RVTs performing neuter surgery on male domestic cats. This bill was recently heard by the Assembly Business and Professions Committee on April 9th. There were a set of amendments dated April 10th. And I'll just quickly summarize what this bill does. This bill would authorize an RVT to perform neuter surgery on a male domestic cat under the direct supervision of a California licensed veterinarian, only if all of the following conditions are met. Number one, the RVT is approved by the board to perform cat neuter surgery. Number two, the RVT reviews the animal patient's history in order to reasonably ensure that the neuter surgery is appropriate. Number three, the RVT performs the neuter surgery in accordance with written protocols and procedures established by the veterinarian. The recent amendments added a couple of provisions to 4840.3, and those provisions are C1 and C2, which read a registered veterinarian technician authorized to perform neuter surgery under this section shall obtain training in cat neuter surgery procedures before receiving board approval. Number two, for the purposes of this subdivision, training means completion of a board-approved curriculum in techniques and procedures related to cat neuter surgery. You'll see attached to this memo are letters or a letter from the bill's sponsor, Social Compassion and Legislation, along with a fact sheet. There are two letters of opposition provided as attachments to this memo, one from AVMA, the second one from CVMA. Additionally, there is a fact sheet provided from CVMA as well. Under the staff comments, I'm not going to go through them, but just kind of outlines just kind of the recent discussions regarding this bill. So I'll leave it at that unless there's anything else Jessica would
No,
like to add.
I think that's great. Thank you. I saw Jessica gave me it's all good. Thank you so much. Just a little bit of background so unfortunately, because we didn't meet in January, the board hasn't been able to really participate in any of the meetings or really on anything in regards to this bill. In November, Jessica, myself, and Dr. Solicito were asked to meet with Ms. Mancuso regarding this bill and just to try and get our thoughts and knowing that Ms. Mancuso was a board member and also because we made her aware that we couldn't speak on behalf of the board. She just wanted to sort of go over it with us, and we listened. During that meeting, Ms. Mancuso stated that she wouldn't pursue the bill unless both the VMB and the CVMA were supportive. We asked her to come and present in January. We discussed some of the concerns we might have had or we could foresee having, but again, couldn't speak on behalf of the board. So that's a little bit of the background on this. And we did receive, I just want to acknowledge that I know it's in the meeting materials, but just for the public, that we received many letters in support. We received an opposed letter from a veterinarian concerned about, even with direct direct supervision, jumping in to fix a dropped pedicle would be very difficult. The many letters of support, some of the things that have been said was that a lot of them were cat rescues and people who are doing really, I think, amazing work. And I just want them to know that we did read all of your letters. And we thank you for communicating with us. We have the opposition letter from the CVMA and the AVMA. And we also have the letter from the author. So with that, go ahead. Yeah.
So I just also wanted to update the board that once this was passed and the author's office approved amendments that were suggested by Assembly B&P Committee, after seeing those amendments, I am concerned about the technicality of how that was written. I did reach out to the author's office and the sponsors. And just as a reminder to board members, when I provide technical expertise, or not expertise, but technical assistance, it's more of just letting them know I cannot speak for the board. I'm not speaking to the policy of this. It's more of if this were to go into law today, what implementation could or could not look like. And I raised significant concerns about the inability of us to implement this bill as written. Just so I went over a few of them. Concerns, the first one being where it says B1, it is implied that the board, or it says that the board has to approve the RVT, implying that we approve them prior to doing the spay and prior to approving them to do the neuter surgery. But there's no requirement for an application. There's no requirement that we actually receive evidence that the training was completed. There's no requirement for a fee attached to that review process. So implementation wise, we wouldn't be able to do it today. And so they seem receptive to that and understanding. They asked about what it looks like in other healing arts professions where there's something similar. So I said I would provide them just what other similar things have done, just so for technically speaking, but also made it very clear that this is not about the policy of the bill, and the board will be weighing in on this today.
Okay. Does anybody have any discussion moment? I know, Ms. Pulaski, you had something you wanted to say.
Yes, so I did write something because I feel very strongly about it and I want to so I'm going to read it and I apologize. So I respectfully strongly oppose this bill, AB 2133. I am in favor of expanding RVT duties. However, those duties should include skills for which we are receiving an education and expanding our knowledge. As a member of the Veterinary Medical Board, I have a responsibility to protect the consumer. The consumer includes pets. I have not spent years of education on surgery or anatomy and physiology of surgery the surgery being proposed, nor am I being educated on the complications that can arise from a feline gonadectomy or feline neuter, which I believe is being severely downplayed. Now, if we want to discuss the workforce of RVTs, we should be discussing the utilization of RVTs. There are some registered veterinary premises that utilize RVTs to their full potential and are able to expand their premises capabilities because of their use of their RVT skills. However, I believe the majority of hospitals underutilize RVTs, which is why most are still underpaid and leaving the profession. This is the issue needing to be addressed and the way in which we can expand access to care, not by adding surgery to RVT duties. If a doctor is not willing to pay an RVT to perform RVT tasks, why would they be willing to pay an RVT to perform a feline neuter? And why should an RVT be willing to accept a pay rate less than their worth if they are performing a surgery for which the veterinarian will continue to charge significantly more? Surgery only harms the patient, the consumer, and the RVT who has no idea what to do when a surgery goes wrong. To be clear, when this surgery goes wrong, the tragedy will only ensure more RVTs leave the field.
Okay. Diana, I think you had something.
You know, when I'm like in listening, it is the importance of listening to one another and you know, finding the like, you know, the mutual agreement, because I like, in thinking about this, I did think about RVTs and what they do get paid, right? And I think about that just in any profession, but you know, but as an attorney and like, you know, paralegals and the paraprofessionals and what that's coming to, and the payment between just, you know, paralegals and attorneys, and even within attorneys, what is that like, right? And so in adding another skill, and what is that going to work out to in reality is a thought there. The other is in terms of training. I mean, yes, I mean, the text itself says that there's going to be a training that meets the completion of the board approved curriculum, and then I'm like Miss Seiferman's point. This can't be implemented without the approval of the board of the training, right? So all of that exists, and at the same time, what exists is that this comes from a need of having to have cats at this minimum neutered in order to be able to keep cats out of the overpopulation of cats and cats out of shelters, and what that is. And so, you know, I understand that the bill does provide an ability to, yes, change what RVTs do with training that, you know, I don't even know what the cost of that training is going to be, how that's going to be implemented in schools, how the implementation, again, is the part you know, this bill is just going to go through a lot of reiterations until, I guess at one point, how I see this is that the board, I'm like, and probably MDC does come up with some sort of training that either includes RVTs or not, right? I'm not going to like be a fortune teller, but in seeing where this is, it seems that the scope of RVTs wants to be expanded. That's coming. And so whether, you know, that's ever going to be an issue of how that's going to happen or how that's going to be, that's clear in this bill. And the other thing that I know, that both the CVMA and the AAV, the other one, pointed out was, or at least the CVMA, if I remember, was that direct supervision and how those costs maybe aren't going to be that effective at the end, right? There's on one side, they say that this is going to improve costs. On the other side, it says like, no, it's not. And that's also to be, I don't know, I'm like TBD to be determined, because the RVTs are under direct supervision, which I remember seeing the definition again earlier today when we were discussing, oh my God, so many of the different things we discussed, but I saw the definition earlier today. So there is going to be a required direct supervision of the RVTs. It's just, what is this going to look like? There's a lot of enforcement. New enforcement for the board. The board's like, yeah, where are we getting paid? I'm like, the money. You know, so I say all of that, and that's the discussion that, you know, I'm like, I bring to the table in the sense that it's a bill that has, you know, I'm like, a lot of yays is being passed through, and then also does require more, I'm like, they can't be, I'm like, to Jessica's point, it can't be implemented today in any way, shape, or form, because we don't have a training. I mean, from what I have read in all the letters and see, there is no training for the RVTs. And so for us to approve that is going to be more difficult to implement. But I also see the importance of at least what I think the author of this bill is trying to address in the issue of having at minimum cats neutered by others to have more cat neutering.
Yeah, the intention is definitely a good, there's good intention there for sure. Dr. Solicito?
Yeah, I just wanted to go over what I remembered from the conversation. I believe the intention when this was proposed was to address more of the shelter cat population, the community cat population. But then the way that it's written, I feel like it actually extends to privately owned cats. So I'm a little on the edge about this because I do recognize the need, in the shelter with the community cats, but at the same time, and this is what I expressed during the conversation, is that a neuter does not just entail cutting stuff. It's not. It actually, you have to take the totality, the health of the cat, and also with the anesthesia part, there's a whole, big consideration. And so training wise, okay, let's say that we come up with a foolproof training for RVTs, that they're going to be able to understand the physiology, the anatomy, and everything else that that is needed for them to do a cat neuter. My question is, you have RVTs that you would certify and you would have those that are not. How do we really discern who's practicing with the certification and those who are not? I feel like it's a very slippery slope, to expand, the responsibilities and, what an RVT can do. And then if there are complications that happens, they're under the direct supervision of a veterinarian. Who's liable then? Is it the vet? Is it the RVT? Now you have two whammies. You have two licenses that are going to be, be held liable for this. So I just feel like the bill itself, although it has great intentions, I feel like it's overlooking a lot of the technicalities that is needed, for it to be successful, I guess.
Dr. Nolan?
I'm a bit surprised we're tackling this at 5:30. Got to keep my brain going here. Again, I'm going to try not to be long-winded. It's going to be hard, but I think our society is getting frustrated because I feel like that our profession has not been able to keep up with access to care issues. And running the risk of making a mistake here, I would like to kind of extrapolate it back to human medicine, where we have nurses, nurse practitioners. Now we have physician's assistants, and we have physicians and doctors of osteopathy. And so in the human medical profession, they recognize that there needed to be another layer or two or three or multiple layers. But what they didn't do is start piecemealing it bit by bit. They started with changing the curricula or developing a brand new curricula for a different level of a practitioner, and they tried to look at it more holistically so that a physician's assistant isn't a nurse that took an extra class and started doing surgery. And I really think we're going to run into a huge problem, and I'm going to get all worked up here, so I apologize. But if we're going to do this, which I think there is a need for it, we've been talking about layering for years in veterinary medicine. We just kind of haven't done it, But if we're going to do it, I want to do it right. I don't want to start having society go, well, let's legislate this, let's legislate that, let's just do it now. Let's do it right. Let's actually sit down and say, okay, we're going to have a different level where it's similar to a physician's assistant, and the professional person is trained from the get-go to integrate surgery with anesthesia, with physical exam. It's not, I agree with all of the things that have been said, but it's not just, we're going to just cut a few things now. We're talking about anesthesia, and frankly, we've been relying on the registered veterinary technicians to monitor anesthesia. So who's going to monitor the anesthesia now while they're doing the surgery? I'm going to do that. I mean, it gets really complicated. So that would be my strong desire, is that we say no to this. This is way too piecemeal. We're not, as a board, meant to train people, right? That's the job of the educational system. And we need to ask the educational system to move forward with a different level of practitioner that is similar to what we're doing humans, that is able to help, not just with maybe the neuters, but maybe with the spays, which is probably a bigger problem in my mind than a cat neuter. So anyway, that's my 2 bits worth.
Dr. Grant?
I agree with Dr. Nolan. I just think that this bill is not well thought out. I mean, who's gonna train? Who's the board gonna approve some school or some curriculum, or do you just go out of state for an AI course over the weekend? It's just not well thought out, and I don't think that as far as a person power to get the work done, if there needs to be more cats castrated and whatnot, well, I think there would be people available if the marketplace, drives it.
Well, there's not. I mean, I think that is the reality is there's not. There's not people in particular for low cost spays and neuters, and there's a lot of feral cat populations that a lot of shelters aren't even. I mean, a lot of the letters that were written, were indicating that even the shelters aren't available, aren't able to provide it. So, I think that's what's driving this is the that there's people who have money who are willing to pay to get these cats, spayed and neutered, and they're not able to find somebody. And so in I think Ms. Mancuso felt like this was a way of, at least my impression was that this was a way of like a small way of getting it, of chipping into that. My thoughts when I even heard the prospect were like, is this really going to make much difference? We have less RVTs than we have veterinarians. Um, do we have RVTs in shelters that aren't busy enough? Like I'm not sure that it would be helpful, like is kind of what you're saying there. But I was willing, I thought, we should listen and see what they had to say. But some of the comments from the CVMA about, the direct supervision are accurate. Like somebody has to do a physical exam, somebody has to establish a VCPR. These are, and this again, in our initial conversation, it was, I thought, specific for kind of feral and shelter cats, but this is all cats. And not that should be any different really, honestly, but this is all cats, but a veterinarian would still have to be doing all of that. So I just don't know that it would solve the problem it was intended to solve anyway. And in the meantime, it would it would be very expensive for our board. I don't really know how we would be able to afford that. Like you said, there's no licensing costs or fees. Right now, we don't approve any kind of curricula for education. It's other folks that are providing that, and so that's just not even something we do. So anyway, this was a creative way of trying to approach a problem, and again, the intentions are good. I think at this point, since we've all had our say on this, we should open it up to public comment in the room. Oh, Tara.
I just wanted to add a couple additional issues I spotted with the language itself, in addition to the concerns that Ms. Sieferman raised regarding no application, documentation, or fee requirements. The bill raises the concern because it would allow the RVT to perform the neuter surgery if they just review the animal patient's history to reasonably ensure that the neuter surgery is appropriate. Well, it seemed like this would be used primarily in the shelter situation where there is no animal history. So what is the RVT reviewing? There's no examination requirement. So it doesn't really appear that a veterinarian is coming to contact with the animal at all. There is the direct supervision piece, but direct supervision is defined in regulation, which really it has two pieces to it, which is the veterinarian has to be at the location where the service is being performed, but also have examine the animal as dictated by good practice. But if the board attempted to enforce the examination piece under the regulation that could be challenged because perhaps the statute itself was intended to override the regulation. So we're really starting to muck up the functionality of direct supervision, the examination requirements. General anesthesia under regulation requires a veterinarian exam prior to administering. That's not in here anywhere. So I think we're really missing some, pretty technical but very important pieces of the care of the animal here. Also, this would allow performance of the neuter surgery in accordance with written protocols and procedures established by the veterinarian. What does that look like? The board isn't going to be reviewing these protocols and procedures. So I guess the veterinarian gets to come up with whatever procedures they want to. And the board wouldn't really have any say in that. This is very different than SB 669, which there's written protocols that the RVT can follow when establishing the VCPR as an agent of the veterinarian to examine, diagnose, and administer vaccines. That's all laid out in the legislation. So it's pretty clear what's required, and that's appropriate. Here, they could establish whatever they wanted to. Also, it would require board-approved curriculum of the training. As we know, regulations would have to establish the curriculum. What that looks like, that could likely be very contentious because, some groups want easier curriculum than others because of as we have seen, alternate premises has been a bit of a contentious issue, especially with animal shelter groups. It's taken over 10 years to get those through, and we're still not done. So most likely, because this requires obtaining training to even qualify for board approval, this bill wouldn't even be implemented for many years, just to get after we got regulations through. So this would not be a quick fix to provide access to care.
Okay, public comment. Good afternoon.
Thank you for staying late on this item. My name is Nicholas Sackett. I work for Social Compassion Legislation, the sponsors of the bill. Thank you for all your comments. I think some of you got to it. Our intention really is to expand capacity for spay and neuter in the state as a whole. I don't think it's any secret to all of you that that is a huge issue. And our intention here is to be creative to expand that capacity. Just to be clear, we're absolutely open to input from the board on technical assistance, as Jessica was saying earlier, how we can improve the bill to reduce the work of the board so that this doesn't take years and years to be implemented, because that would somewhat defeat the purpose, although whenever it happened would be a positive. I do want to mention that on the piecemeal, you talked a little bit about doing this piecemeal, and certainly appreciate that perspective. I would just say that spaying and neutering is somewhat unique in the sense that that really is the one medical procedure that could fix the pet overpopulation crisis. Other health issues, pets certainly would need a vast array of medical care that this, holistic approach could take care of. But I think the pet overpopulation crisis is not just a medical issue. It's a societal issue that overlaps with the medical issue. So I think that there's a little bit of a carve out for the piecemeal, why a piecemeal approach could be justified in this case. There are other folks waiting on the line to talk a little bit more about the training and the RVT piece that I don't have the expertise for, so I will kick it over to them. But I just want to reiterate that we are absolutely open to all the input that's necessary to make this as seamless as possible for the board. Thank you.
Thank you. Ms. Lutz?
Here we go. Okay, so in the 24 years that I've been defending cases, I've had a lot of cases of botched spay and neuters, which is interesting to me. And I am very concerned about this bill because what concerns me is the fact that it applies to privately owned animals. And consequently, if something goes south, there will be a complaint to the board or a lawsuit. Now, we're having an influx of small claims lawsuits. All of a sudden, everybody's decided that's the way to go. So there would be small claims lawsuits and complaints to the board. At this point in time, there are very few RVTs that have any kind of liability insurance. There really aren't any carriers that have really focused on that. And it's been my impression that, it's not something that the carriers are going to want to jump on. So if the RVT, if something goes south and the RVT has a complaint to the board or a small claims action, they will either be flying solo without any insurance to cover anything, or they will have to hire an attorney and pay the attorney themselves. That's an issue. The supervising veterinarian also will probably be sued, and there will be a complaint to the board. So that person also usually has insurance, but that will mean that for any case, any given case, you'll be dealing with two different claims. Okay. That's a lot of money. And also there's a possibility, a good possibility that if this happens, that the rates that RVTs have to pay for just to be an RVT will go skyrocket as well. So I think those are things we need to consider. The other comment I have to make is we keep talking about direct supervision. And because I do regulatory work for multi-state companies, there's a thing called immediate supervision, which means the vet is standing right there. Well, of course, that would be ridiculous because if you're going to have the vet standing right there, why not have the vet do the surgery? But direct supervision only means that the veterinarian is on the premises. So that, it sounds a lot better than it really ends up being, because if something's going to go wrong, it could be a big premises. It could be, and that vet could be really busy doing something else, because there's nothing that says the vet has to be available to help the RVT. So, I think for 1,000 reasons, this is not a good idea. And I'm especially concerned because it also applies to cats privately owned. Thank you.
Grant Miller, CVMA. Thank you very much for including both the American Veterinary Medical Association and California Veterinary Medical Association opposition letters in your packet. I appreciate all of the board's comments and thoughtful reflection on this bill, and it's clear that you have read our opposition letter. I'm going to make comments today specifically in reference to how I feel this bill will impact this board. And those comments relate largely to the amendments that Ms. Welsh had already discussed. The board will be charged currently with the way the amendments are written with two things. One is determining a training curriculum, and the second one will be approving the RVTs who do it. Traditionally, approval is in the form of an exam, and we have gone to great lengths to remove barriers to licensure here in California by eliminating our state exams. But I don't see another feasible way the board could approve these people if there wasn't some kind of measure of competency through an exam. So when you have licensure, when you have a CVTEA approved RVT program where they're all doing it the same way, they're all taught the same way, and they're licensed by the NAVLE in accordance with that curriculum, we can rely on that. If we have to do it ourselves, we're going to have to go back to creating that entire program again. And I see the expense to this board being far beyond what the RVT licenses can endure. As you will recall, the CVMA and other stakeholders voluntarily offered to raise our own veterinarian licensing fees to the statutory maximum in order to offset the high RVT licensing fee that was driving RVTs out of our profession. And we got their fee lowered down to $225. So if they're performing now surgery and we have to create all this, I do not see a way that their licensing fees would not move to a very, very high level. And I'm also concerned that even within that licensing fee, the board would still have financial impact in implementing what is required by this bill. And where is that money going to come from? That's something that we as the CVMA certainly would not be supportive of because we're in opposition to the bill. So I'd like you to consider the appropriations impact as you move forward. Thank you.
Thank you. Moderator, would you please open it up to the, oh. Okay. Yeah, we have a hybrid version of public comment.
Okay, I'm about to put you on speaker. Go ahead, sir.
Hello, board. I thank you for the opportunity to present or speak the direct that's near and dear to my heart. Dr. Richard Johnson, founder and CEO of All God Creature
Can you?
San Diego.
Dr. Johnson, can you mute your computer? Or just close it down, actually.
Okay, let me see. Are you getting feedback on it?
Yes.
Good enough?
Go ahead.
Okay. I'm Dr. Richard Johnson, founder and CEO of All God's Creatures Teaching Hospital and Vet Tech Nursing Academy in San Diego. We're new to the field with the academy. Our first class passed 12 for 12 in the national exam, which only has about a 50% pass rate. And our second class, we've had 3 students take the exam and they all passed. And our third class is now in session and we've got 24 students in that class. And so I've been quite anxious to try and expand the scope of practice for veterinary technicians for some time. My background review, I graduated from Davis. I did a surgical residency at the Animal Medical Center in New York City. I taught at that time with technicians from the University of Maine who came down and lived in the hospital. It's 6 stories of veterinary medicine. Probably at the time I was there, it was the largest animal hospital in the world. I was an assistant professor at the University of Illinois in the Department of Surgery. I, at that time, was in charge of veterinary technicians from a local junior college, Parkland College. And so I did a lot of the teaching and had classes and dissections for a lot of those students. I was an instructor at Mesa Community College in San Diego. And I also am quite active with the Registered Veterinary Technician Committee, was quite active for the Veterinary Medical Board, which many of you don't even realize existed. But I was on the board, on the Veterinary Technician Committee for 9 years. I was a veterinary board member, appointed to the board for 3 years. And I'm proud to say I was a recipient of the California Veterinary Medical Association, California Registered Veterinary Technicians, Outstanding Veterinary, Doctor of Veterinary Medicine of the year in 2011.
Dr. Johnson, please, can you support the bill?
I do support the bill. I support AB 2133. First and foremost, it'll have a dramatic effect on the cat overpopulation, which we've been fighting and battling against for decades. A local group, the SNAP, is Spay Neuter Action Project, did a hypothetical study, and they said that if one intact male and one intact female and their offspring in a 6-year period of time will produce 420,000 offspring. And so the numbers are there, and it's not only just in the pet population, it's also all the feral cats and the shelters and all of the other issues associated with it. And all the procedures that we're talking about right now required to do a cat neuter are already permitted under California Code of Regulations 2036 under direct supervision of a veterinarian. They can induce the anesthesia. It's a much more complex and risky procedure than doing a cat neuter. They can suture cutaneous and subcutaneous tissues. And in this case, all they have to do is learn how to tie a ligature on the spermatic cord. And they can recreate a relief hole. And the relief hole, it would be in the scrotum created over the testicle that is being removed. When you cut the cord or the spermatic cord, there is about a 2 to 3 inch cord that remains visible. It does not retract. It remains visible to the open eye in the open sac that you remove the testicle from. And so put all these things together and you have a cat neuter already. We're already doing this. And if you don't address the cat neuter and you don't agree with me on those procedures, look at what we've done with dental extractions. That's been going on in veterinary medicine for probably 40 to 50 years.
Dr. Johnson, they're asking to close up your statement.
Okay. And so if you compare it to that, you can ultimately see that we're already doing these things. And there's no reason not to affect this overpopulation issue that we're dealing with. And one more comment. I work with Dr. David Joyce. He's an MD with an MBA, and he does all of the continuing education programs online for the MDs and the RNs at Johns Hopkins.
Sir, they're asking you to cut you.
Develop our.
Dr. Johnson, they're asking me you to close up, finish up.
Okay.
Yeah.
And
Thank you.
Thank you very much. Okay, moderator, can you open it up to the folks online, please?
Absolutely. We are open for WebEx comments. If you would like to make a comment, please raise a hand by tapping that hand button. Dial in users, dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Judy Mancuso. Hold on just a moment. I'm going to send you a request to unmute your microphone.
And I might ask for an extra minute. This is a big issue. And I want to start with, I spent 8 years on the board and we had many cases come before us. I never saw a cat neuter. To Bonnie's point, you bet we saw spays all the time and we saw anesthesia problems. Never saw a cat neuter. I have personally watched hundreds of cat neuters in my day at spay days, etc. They are so simple. And anesthesia is a bigger issue than a cat neuter. I personally pay $1,500 in my local area for a dental that is only ever done by RVTs. And the dental is so much more complicated. So as far as can an RVT do this? Yes, they are already doing much of it, as you heard from Dr. Johnson. And as far as waiting for the perfect and waiting to do this bigger thing, that day won't come. I was on the board in 2010 when we were talking about telemedicine, when we were talking about the VCPR and other, and an RVT helping. 14 years have gone by. And then how did it get done? By statute, by statute. And why does it get done in the legislature? Because the industry blocks everything because of slippery slope and protecting their industry. So we have to do bills to move the ball forward. And Tara, it is so great to see you. And you are so brilliant. And I knew that with the board's help, we could make a rock solid bill, but we didn't get that pleasure. I was hoping in January we would come to you guys and get your support and get Tara and all the perfect minds with the VMB to write this. We have Nancy Ehrlich, we got Dr. Richard Johnson, all these folks that are available to us. You already have schools that are accredited, and we can say that one of these schools, any of these schools, can provide this. We can put a little mark on the website that says, yeah, they're okay to do neuters. They got their special training. We don't mean to leave these things out. We purposely left them out because we wanted your input to make it beautiful, to make it perfect, so it would not have to go through regulations. When I was on the board, regulations were 12 months to 18 months. I
1 minute
understand
left.
now they can go out to 3 years. So the last thing in the world we want to do is kick this thing into regulations. We want it all in the bill. We don't have time to wait. We are killing hundreds of thousands of animals, and CVMA, AVMA, nobody comes up with anything. They have this high volume spay and neuter they want to do. Great. That's going to take years. So is it okay to keep killing millions of animals at taxpayer dollars when we are the board who is supposed to be helping consumers and animals? This is a way to help them. I urge you to help us to make this right and get this bill where it should be so we can get it signed into law and start making a difference. Thank you.
15 seconds.
Thank you. So we did add an extra minute to the time, so I'm glad that that worked out. For the remainder, we're going to go ahead and keep it to 3 minutes. Thank you, moderator.
All right. Next, Dr. Jenny Goodkin had her hand up.
Hi, this is Dr. Jenny Gedkin. I think this is a great example of great intentions all across the board. I don't think anyone here will argue that overpopulation is an issue that I think we all want to address and tackle. There is a lot of enforcement issues surrounding this, but one thing that I want to point out is the heart of this proposal is to curb overpopulation. And as someone who volunteers with rescue and has done shelter work, it is a routine procedure until something goes wrong. We are trained veterinarians in surgery. So I think the word routine and outside of the profession, people calling certain surgical things routine might be an issue here. But I am wondering, because the direct supervision, I have to be on the premises. So I am delegating these neuters that in my hands might take me a total of 2 minutes each to an RVT. I am then doing another task. What happens when something goes wrong? I can do these 20 cat neuters because I am experienced and trained in surgery in less time than a large dog spay. So getting to the crux of the problem of how this is controlling overpopulation when all the codes and regs surrounding vet med, you cannot eliminate a veterinarian being involved with this procedure. As someone who has been in this position, boots on the ground as a shelter veterinarian, I don't see how this is actually going to help our numbers, because this is something that many shelter vets are experienced in. I do hesitate if something goes wrong. I have likely delegated this task to an RVT so I could be, let's say, elbow deep in a spay. And if something goes wrong and I am doing a task because I am not in immediate arm's length supervision of that RVT, what is going to happen to that pet? And if I am, as Ms. Lutz had pointed out before, if I am in immediate arm's reach supervision, I am doing the procedure myself. So I want to get down to the issue of maybe it's time for advocates to also make sure they are talking to the boots on the ground shelter veterinarians and high quality, high volume spay neuter veterinarians that are doing the work now, to see if the proposal as it stands will actually help the spay neuter numbers in reality when they still have to be involved in the procedure on the premises. Thank you.
Thank you. Next we have, I'm going to try your name, Nancy Ellich, or my apologies. Nancy, I'm going to send you a request to unmute your microphone. Please help me with your name.
Some of the issues that were brought up by other people. I wonder how much training veterinary students actually get in cat neuters. From what I've been told, they're lucky if they get to perform one while they're in veterinary school. And I suspect that with the training program that we would require for RVTs, that RVTs would actually have more training in cat neuters than veterinarians do. I think people have forgotten that the veterinarian is responsible to determine if they are going to allow any particular RVT to do this. And the RVT has to want to do it. So it's not every RVT is going to be capable of doing this. Not every RVT is going to want to do this. And not every veterinarian is going to want an RVT to do this. It's only those that want to do it and the veterinarian feels are qualified. As we've already discussed, RVTs are already inducing and maintaining anesthesia, which several speakers have said is more dangerous than this procedure of cat neuter. And they've been doing that since the beginning of RVTs. And someone mentioned about schools implementing the training programs. And schools can't implement a training. I mean, schools could implement a training program, but it won't matter unless the bill is passed. RVTs will only be able to do this if this bill is passed. And of course, in consultation with the Veterinary Medical Board, they will be deciding what type of training is required. And my last and final point is that direct supervision does absolutely require the veterinarian to be available. As a matter of fact, the wording is direct supervision means the veterinarian is present and is quickly available where the animal health task is being performed. So the veterinarian cannot be in the middle of some other kind of surgery while the RVT is doing this. The veterinarian would have to be doing something which would allow them to be readily available if the RVT needed them to intervene. So I think people are a little worried about stuff they shouldn't be worried about. And I think this is an opportunity to decrease the cat population and to increase the RVT population, and maybe even increase the veterinarian population, because we're losing both veterinarians and RVTs. And hopefully this would take pressure off of veterinarians and elevate RVTs to make them want to stay in the field. That's what I have to say.
Thank you very much. And that was our last request for public comment.
Thank you so much, moderator. I wanted to ask you, Dr. Solicito, as the shelter veterinarian in the room, would this, if RVTs were able to perform this procedure, would this have helped in your practice?
Again, I think there was a good point made earlier the direct supervision part of it is actually going to be, I think, counterproductive to the intention, because if we want the RVTs to be able to do the numerous neuters, but the vet is still going to be made available, to directly supervise, I think then you're just losing the opportunity for the vets to just actually be doing the neuters themselves, and have that RVT supporting. So I would say, would it help? I will have to really think of a great, like, protocol of maybe making sure that you're utilizing your RVTs, still supporting the vet, whatever it is that they're doing, if they're doing a procedure, and have a separate RVT if you have, multiple RVTs at the shelter, which we don't. So again, you're tying the RVT into a procedure that a veterinarian could actually do. Yeah, it just, I guess, spreading it too thin.
And taking them away from things that you need them for as well. Yeah,
Correct.
okay.
Are you ready
Miss-
for a motion, President?
Uh,
No, okay.
yes, we're ready for motion.
I would motion that we oppose AB 2133 as it's written.
I'll
I
second that.
second.
Okay, so we have a motion on the table. Did you have something you wanted to, okay? Any further discussion by the board? Okay, any further public comment in the room? Seeing none, moderator, would you please open it up to public comment online?
We are open for public comment on the motion itself. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Judy Mancuso. Hold on just a moment. We're sending you a request to unmute your microphone.
Well, in the many years I sat on the board, we would take a watch over an oppose to give people more time to gel their legislation. And as far as people not understanding how this would be helpful, here is the scenario. Cat neuters are quick. If you want to talk about a shelter situation, you could have a veterinarian say, okay, Tuesday's going to be cat neuter day. I'm going to go around and take care of all the animals doing other things. I will be available in the shelter while the RVTs are knocking out all the cat neuters. We are releasing animals right now from the shelter when it is a mandate in law to be spay and neutered, unaltered, because we can't keep up with the volume. There is too much capacity. You guys are just being very short-sighted, and I am very disappointed in this conversation. And so the RVT could be doing this while the vet is doing other things. It's not about, can I do it faster? Can I do it? No, it's about taking it out of your hands. You find the day when it's good for you to do it. And in private practice, if you say, I don't want to do this, I'm the vet, I own the practice, I don't want my RVTs doing it. The law allows for that. It doesn't mandate that the RVTs do it. It doesn't mandate that the DVM does it. What it does is it sets up a framework so that we can have education. We can have a pathway that the RVT can do it. So if it's if it's a veterinarian in a shelter, or if it's a veterinarian in practice, and they are comfortable with their RVT, they are comfortable in the way they are implementing it, that they are allowed to. It is not okay to keep kicking this can down the lane and allowing all these animals to continue to die. They're leaving the shelters unaltered. And what does that do? It breeds more animals. So please rethink this. Do not take an oppose. Do not just watch the bill and help us. Thank you.
Thank you. And that was our only request for public comment.
Thank you, moderator. Any further discussion?
No, I know it's so late, but just real quick, and someone, well, and in hearing everyone, and and then again the listening, I just thought of when I heard the difference between direct and immediate supervision. I jumped to Grey's Anatomy. You guys are like, really, a hospital show? I'm like, yes, an hospital show. That's what happened in my brain. And like seeing like the madness of what was Grey's Anatomy when there's like the one doctor asking for the supervision, and then like the interns are in like the room, and like just like chaos reigns. And I understand, again, the intention of the bill is understood where it comes from. And then I thought I was losing my mind at the late night of what it is now in seeing SB 1233. And then I know, and this is AB 2133, right? It's little flipped. It's like a rain was like, floop. And what that did, I was like, wait, the CVMA supports this. I was so confused for a moment when I was reading down because it was attached to this packet. In that, I think what would be great in communicating between the both is that it seems, and going to Dr. Nolan's point of creating a course that would help spay and neutering, is that this is a bill that directs UC Davis. And then again, in practice and implementation, how's this going to work? That's how it is with everything in life. That's how we do things. We don't know actually what we're doing or what our path in life is until we take that step that we either do or don't know. So we either keep doing the same thing over and over again and expecting different results, which is insanity, or taking a step forward into a direction that is appropriate. So just I'm like, my last thoughts, because this is what being on the board is for at 6:21 p.m. It seems that SB 1233 is something that is going to help create a curriculum for spay and neuters for both RVTs and vets, proposed how it is it's going to be done, and actually help both neutering. I'm like neutering, both of neutering and spay. So we could talk about more than balls. That was said in a meeting at 6:21. It's on you all. And so so as I'm hearing everyone and how this is going to be just implemented as written, and while it is piecemeal and could solve a moment right now, it seems that there's also another bill that can help bring this together. And that's I think that's what because I have what's up. That's it. I'm in. I feel complete. Thanks.
Okay.
I actually wanted, so this is what I was going to say before, in that in talking to several shelter medicine doctors, I asked that question: what is it that prevents you from doing more? And why don't students come in, and do you take rotations in and have students come into your shelters and do more spays and neuters? And the response was, because they can do them faster and students slow them down. So students slow them down from doing spays and neuters. They don't want vet students coming in on their rotations and doing spays and neuters because the students slow them down and they can get more done. So why are they going to have an RVT come in and do spay or a neuter? Because it's not going to be as fast. And so that to me was kind of eye-opening. And I was like, yeah, I get it. Why would that? So to me, 1233 is a better option than this. And it's not an option. It's not going to work. And yeah, it seems like we're trying to force a solution. And I get, we need to have a solution. You're right. There needs to be a solution, but I don't think this is the one. We're trying to force something that's not going to work. And when there is a better option out there, we need to do something. And I think there is a better option.
Okay. Dr. Solicito, let's try and make our comments brief, but or as succinct as possible, just because for the other people who were holding here. So
No, I just want, I don't want to lose sight of what the intention is, right? And I think by opposing this bill in its totality at this point may also be something that we need to rethink. Maybe, I don't know, if opposing it just like that or opposing with a suggestion of further conversations, because I feel like the supporters of the bill also are not considering the like the concerns that the board has at this point, because we've never really had a conversation, right? The conversations that we've had are very limited. And I think that because the intention is really good, maybe it is worth like just at least having further conversation.
So the one conversation that we did have, we were promised that if the CVMA and the veterinary medical or the veterinary medical board opposed this legislation, it wouldn't be they wouldn't even seek a sponsor, yet they've moved forward. So I have a hard time feeling confident that working with them is going to get us anywhere. Dr. Nolan.
I guess I would add to that, that us opposing the bill does not preclude further conversations either.
Okay, let's take a vote.
Dr. Solozito,
Abstain.
Dr. Grant,
Aye.
Dr. Noland,
Yes.
Ms. Pulowski,
Yes.
Ms. Prado,
Yes.
Ms. Sperber. Oh, I'm so sorry. That was
Wow.
old. Dr. Bradbury, I'm sorry.
Yes.
Motion carries.
Okay, so with that, we will adjourn, and we will be back in the morning. And I think we'll actually be starting with out of order with agenda item 12 because our student liaison needs to report early. Then we will move back to agenda item 10 and then go through the rest of the legislation. Thank you, everybody, and thank you so much to the staff, everybody here, and the moderator. Have a good night.